It's where all the money is. Probably, but I don't know that.
Yeah.
People who are joining online, and they are somewhere up there. How many people do we have on? Hi, everybody. Hi, everybody. Where are you? There you are. All right, we're going to start. Good morning, everybody. All right, we'll do that. We'll do a little call and response. Good morning, everybody. All right, thank you. My name is Ken Thompson. I'm the Chief Medical Officer for the Pennsylvania Psychiatric Leadership Council, and I'm really pleased to see you all here. And those of you online, hello. Good morning. It's really a treat to welcome you to Harrisburg, either in person or online. It's kind of like there's a little person standing on this table here that I have to talk to. That camera right there is sort of, he's a little robot looking at me, and I'm going to direct my comments periodically to you at home sitting at your computer. I also get to look at Deb and Val when I do that, so it's always fun. I wanted to welcome everybody and to kick off this morning a couple of observations. This is the first day of spring, in case you were wondering. It turns out, I'm not sure what we're going to do about Punxsutawney Phil. He totally missed it this year. I think maybe they're missing him. Not sure they really understand him very well. So we're going to find out what happened later. But it's a new season, and we are also here in Harrisburg as the beginning of the new administration starts. The last time we were here, actually not the last time, we had a conference here, but the last time we were here as kind of a meeting was 3 years ago with Governor Wolf. And we had I think then an exceptional meeting that we then went home to find out that all of us were going to spend the next 2 years or 2.5 years essentially at home, unable to see each other. And it's been very good to be able to come back this time as well as last September. We have a really exciting series of presentations and discussions today. I want to set this, though, just a little bit of a context. It's 3 years since COVID started. I learned on the radio today that it's 20 years since we invaded Iraq. And that still shows up in my practice. I'm taking care of a large number of people from Iraq. And the challenges that exist there persist. And I also heard on the radio today that there were continued anxieties about the wobbling financial situation around the world and the fear of bank collapse everywhere, which seemed oddly reminiscent of another period of time in history. So I think we are here in a moment of rebirth and renewal, but we are hearing echoes of some of the stuff that's happened. And in the mental health world, we are here gathered knowing that, in fact, we are in the midst of a mental health crisis, a mental health emergency. We are seeing larger numbers of people with psychiatric challenges coming in. People are overwhelmed. We also have a workforce that is in deep trouble. with people feeling extremely overworked and stressed, as well as the fact that we have decreasing numbers of people doing the work. So we're in a crisis moment, but it's a crisis moment with I'm hoping some hope and some sense that we can find a way forward, which is why we are having this meeting today. That's to figure out paths and things that we can do and participate in that will help shape what happens in Pennsylvania around mental health. So to start this whole process, we have a long day, but it's an exciting day. So we're going to have representatives from the state government and both legislator and the executive. We are going to have folks come talk about the issues of what's happening with mental health, with the mental health budget. We have folks who are going to talk about what we're going to do with the unwinding of the public health emergency. That's going to be, I think, a really exciting and an opportune time to think about what the future is actually immediately bringing us. We have an opportunity later to talk about the centers of excellence and what's happening across the state in each of the centers, and hear hopefully from some of the fellows who are involved. Later, we're going to hear from Wes Sowers and the work he's been doing around the country on LOCUS and the possibility of engaging LOCUS here in Pennsylvania more actively and officially. And then we're going to have a chance to talk about some work that's been really near and dear to our hearts and something that we are very proud of, our efforts to make the face of psychiatry in Pennsylvania look like the face of Pennsylvania. So we are extremely excited to present those folks and those efforts, and to have some of the folks who've been involved in that process talk a little bit about what they've been doing and capture. What I'm particularly looking forward to is hearing from some of the Black residents about the challenges and the circumstances and the hopes that they find. We're going to talk a little bit about some of the program initiatives that we've got around spiritual care, workforce development, and work we're doing with the Coalition for the Common Health. And then we're going to come together at the end of the day and sort of think about any other issues that we have, or figure out what we're going to do to move each of these processes a little further down the road. So that's an active day, lots of opportunity for interaction and discussion. To do that, though, everybody in this room, and hopefully folks online, will get a chance to introduce themselves so we know who you are, where you're coming from. I am hopeful that we have the whole state of Pennsylvania here. And Lloyd has got, somehow anticipating this, has got the microphone and is going to hand it to folks so that you can introduce yourself, say a few words, and pass it on.
You think that's why I got this? In fact, it is. Lloyd Wirtz, so happy to be with you as a co-administrator of the Psychiatric Leadership Council. Well, they're not going to see the other people either. All right. So those of you online will not be able to see individuals as they're making their introductions, but you will hopefully be able to hear us now that I have, in fact, a microphone in my hand. So I'm going to pass that microphone, if your mouth is empty, to Dale.
Good morning, Dale Adair, Dale Adair, the Chief Psychiatric Officer for the Department of Human Services. From Pittsburgh, but I work here in Harrisburg.
I'm glad you're able to join us today, Dale.
Hi, Elizabeth Kunkel. I'm the Chief Medical Officer at Pennsylvania Psychiatric Institute, which is a joint venture between UPMC Pinnacle and Penn State Health. I'm also a board member for the HAP, Hospital Associations and Health Systems of Pennsylvania, and I'm also the chair of the CMO group for the AAMC.
Good morning, Allison Swigert. I'm a outpatient psychiatrist at PPI, Pennsylvania Psychiatric Institute, and I'm also the director of our community psychiatry training program at Penn State.
Good morning. I'm Jim Pechtel. I'm a psychiatrist in Philadelphia, community psychiatrist, and also connected with Resources for Human Development, nonprofit agency.
I'm Stan Mrozowski, a consultant with PPLC, working on workforce issues and I'm with the Spirituality and Religion Committee of PPLC.
Hi, I'm Wes Sowers. I'm a psychiatrist in Pittsburgh and the director of the Center for Public Service Psychiatry there.
Hi, I'm Madeline Lipshy-Williams. My pronouns are they, them, which means if you refer to me, I prefer to be called they or them in reference. I am a fellow in geriatric psychiatry at UPMC and also a fellow in the public service psychiatry program at UPMC. And I will be staying in Pittsburgh, but doing not exactly sure what, but something in the community in Pittsburgh.
Hi, good morning. My name is Scott Cawthorn. I'm the Chief of Staff for the Office of Income Maintenance within the Department of Human Services. The Office of Income Maintenance oversees the 94 county assistance offices across the Commonwealth, and we're responsible for eligibility determination for federal and state programs, including SNAP, medical assistance, TANF, long-term care, low-income home energy assistance program, and then COVID added a water assistance program, emergency rental assistance program, and pandemic employment EBT, which is the school lunch equivalent for those who were impacted by COVID. Happy to be here. Thank you.
Scott, just in case other people out there feel overburdened in their jobs, can you share with us the number of people who will have to have a redetermination from their medical?
Yes, I can. So just for Medicaid alone, we have right now about 3.6 million individuals receiving medical assistance. That's up about, I'm going to say 700,000 from our typical enrollment of around 3 million. Yeah, that's just our SNAP program or our Medicaid program. Then we have another 1.9 million on SNAP. Many of those are in both programs. And then of course our low income home energy assistance program, TANF program. We have nearly 7,000 employees across Office of Income Maintenance.
Thank you. I'm giving money back. I'm telling you now.
Good morning. My name is Sierra McNeil. I am the Director of Workforce Development out of PMHEC, so I'm based in Philadelphia. I'm also the liaison. I gave that title to myself because I actually don't know what my title is, but I am the liaison for the Black Residents Roundtable group. So I'll be speaking to you a little bit later about that group. And then the other thing is I am a social worker. And so I am actually the incoming president for NASW, which is the National Association of Social Workers Pennsylvania chapter.
Hi, I'm Marsha Lorenzen. I'm a resident psychiatrist in Erie at Mill Creek Community Hospital. I'm also part of the Black residents, Black and minority residents, and I do have a strong interest in community psychiatry.
Hello, I'm Ben Gangaware. I'm Western Chapter President of the Pennsylvania Psychiatric Society. Also the Residency Training Program Director at Penn Highlands Healthcare, which is about 40 miles west of State College, if that's helpful for anybody.
Good morning, Mary Ann Alba. I am a child and adolescent psychiatrist from Erie, Pennsylvania. I have the privilege to be one of the co-chairs for the Subcommittee on Racial Justice for Recruitment and Retention, and I'll be talking later today along with Sierra about that program. I'm very active in the Pennsylvania Psychiatric Society as well as at the national level now as a representative of our society to Area 3 of the Assembly of the APA and going to step into the deputy representative for Area 3.
Good morning. I'm Gordon Hodes, consultant child and adolescent psychiatrist for UMSOS. These days, I'm focusing a lot on issues of trauma and trauma-informed care.
Good morning. I'm Valerie Ferry, co-administrator for the PPLC.
Deb Shoemaker. I am a consultant for PPLC. I work with Scott as chair of the Medical Assistance Advisory Committee and as chair for Fee for Service Subcommittee. I'm also now consultant for Recovery Insights, a peer support group that has a grant that expanded in Cumberland, Dauphin, and Perry County, and Lancaster and Lebanon.
Hi, I'm Katie Morton. I'm the Director of Forensic System Solutions at PMHCC, and I'm helping to run the Zoom this morning.
No. We have to say something about Lucy.
It's the Lucy Green, yeah. Who supports everything that we do with emails and reminders and multiple tasks that I can't even begin to mention, much less imagine how they're done. And we're very, very pleased that she's here with.
Well, I actually want to take a moment to just shout out both Katie and Deb as being instrumental in making this meeting happen. Val and Lloyd get their own recognition. They have also been crucial in this, and it's worthwhile saying that we talked about the new administration in spring being here. We are in fact marking now about a year since Val and Lloyd filled the giant steps of David Dinich, who had been the executive director of the PPLC since its inception. And we were just commenting last night at dinner that fortunately, we were very lucky to get the leadership that we have from both Val and Lloyd in this process. And we have managed, I think, to come out of that change with at least as much energy as we had going into it, and that was substantial. So I am really pleased that we are looking at this new era and moving forward. So Lloyd, you're actually supposed to come up here because we are now at the program and ways to engage state leaders part of the discussion. And I think I might just take a moment to just review. Do you need something? Yeah, it would be nice who's on screen. Thank you. Who do we have? Is there a way to share who's on screen? I'm sorry, I couldn't hear you. They can unmute themselves. Okay, so those of you who are online, I don't know how to do this in an orderly fashion unless there's somebody who can look out and call a name. All right, so we've got Ellen. Good morning, Ellen.
Good morning.
Can we hear?
Yeah. Okay, tell her to say something.
Good morning, this is Ellen.
Okay, we can't hear her. I have to fix that.
All right, why don't we call out their names and they can wave to us? That would be the way to do this. Unfortunately, we don't seem to be able to get any sound. So that's Alan DiDomenico from DDAP. Why don't should I read them off? I guess that's easy because you guys don't have a. We have Angela Weeks. Hello, Angela.
Good morning.
Mira Chatterjee.
Hi, good morning.
Andy Hidrogogian. FCL Loeb. And Mina, I can't quite make it. Palak. Hello. Is that everybody?
Everyone.
Nope. No, Sarah Lim is there. Good.
Morning.
Natalie Cook. Angie Armbrust. Eileen Diaz.
I'm just lurking, Ken. I'll be there this
And
afternoon.
that's the only, that's the Kim Thurston,
Hello.
Jasmine Banks. It's quite a lot of people. This is wonderful. We are going to have to be able to hear these folks. Okay, so we will do that in a few minutes. What I'm going to do. Can I turn off this microphone? Yes, I think. Alan, can you say something?
Good morning, everyone.
You turn off the mic?
Yeah.
Okay, is the other mics off too?
Yeah.
Okay, we're
gonna fix that
We're
during
gonna
break.
fix that real quick. Okay.
We're on it.
Is it just?
Okay, I'm back.
Is it plugged in? Like,
Do you guys remember, some of you are probably too young for this, but we used to have audiovisual, and what audiovisual in school consisted of when I was a kid was either an overhead projector or a film strip. And for some reason, that technology consistently overwhelmed everybody all the time. And we had to have an AV department. In my high school, I remember the AV department, which was about the film strips and the overheads. And we had to have specialized people to come run them. There were kids in the class who were specialized, trained to do this because we routinely screwed it up. So I don't know how the hell we do any of what we do now, given what our talents seem to be as far back as when I was a kid. But there we are. AV always is a problem. So while we wait for that to be sorted, I do want to just talk a little bit about the PPLC, and in case folks are unaware of its history, the PPLC came about largely through the vision of Estelle Richmond and Dave Dinich and a number of other people who I was at least happy to be a part of. At the time, and this is around the turn of the last century, we were in a situation where in psychiatry in Pennsylvania, the academic medical centers were rapidly sort of decreasing their interest and involvement in anything to do with public psychiatry. It just was not something that you could be on the faculty and do or be engaged in. So we decided, and this was with Estelle's input particularly, and David's input, the decision was taken that it was really important to create centers of excellence and fellowship programs in public service psychiatry so that we could train folks, so that we could retain them, and so we could retrain folks over time to be able to adjust to the changes as psychiatry and services evolved over time. So that's what got us to get this going. We were able then to fund faculty, and now we have people who are focused on doing and teaching public psychiatry in 4 centers of excellence in the state. And I think we've been able to encourage an ongoing commitment by the academic health centers to pay attention to this and to make sure that we're training folks. We've trained over 80 fellows over time. It might even be a little more than that. We believe that about 2/3 of them have continued to stay in Pennsylvania, and most of those have been engaged in some form of public service. So we think that we are delivering on the goal of making sure that folks have access as much as we can to excellent public service psychiatric care in the state of Pennsylvania. That's why we exist, and that's what we've been doing. There is a little bit more, though, that's happened with time. As we became more engaged with this effort, and particularly as the times became more and more challenging and complex, it became really apparent that it was essential that folks begin to involve themselves in not only training and retraining and retaining psychiatrists, what we also had to do was to think about what was the shape of the work and the places and the kind of work that they were going to be doing. Who was it going to do the work? Where were they going to do it? How is this all going to be put together? So we've increasingly put our efforts into public policy and thinking about what the shape of the mental health service system ought to look like. That has involved us in a number of things. One of them is something you'll hear about later today, the Coalition for the Common Health, which is an initiative to really build primary health services that have psychiatric resources and capability at their core, at their foundation across the state. We have engaged in a number of efforts to address workforce and to be thinking about what we can do to bring more public service psychiatrists and other mental health professionals into the field, particularly working with the Department of Health around how they do designations for mental health service shortage areas, and to try to figure out what we can do to promote that capacity in the state of Pennsylvania. And we have also worked really hard to, especially since the murder of George Floyd, I think we were called up short on that and realized how much we really needed to focus on the issue of diversity, and make sure that the people of Pennsylvania find psychiatrists who look like them when they go into their offices, or when they are seen by them on telehealth or however. The issue of telehealth has also been a real critical concern of ours as we've tried to understand what the changes are that are coming with the change in the end of the public health emergency. So these are the kinds of projects that we're engaged in. And Scott, I have to say, we're really thrilled to have you here. I don't know how often you talk to a psychiatric audience, but you are absolutely essential to our work. And we are, and your 7,000 folks in the field are really critical. We know that if the folks that we take care of don't have a place to live, don't have any food, don't have any opportunity to have some income, that they are in deep, deep trouble, and nothing that we do is going to be able to help them if there isn't some resource. So that's really critical. And we're also deeply, deeply worried about what's about to happen with the end of the public health emergency, and are concerned that a lot of people are not hearing about this and don't really understand the gravity of what's about to take place in the lives of a number of Pennsylvanians. So thank you for coming. And Dale, same, we're very happy to have the state here. And I know we're going to have some more folks that are online with us, with Ellen and others. So we have an opportunity to have these conversations. And I'm going to turn it over to Lloyd to add anything you want to add to all this.
Well, yeah, there are a few things I wanted to add. If you recall what Ken said about the way PPLC started, it began with the engagement of a public official, Estelle Richmond. And then at the same time, an engagement of another public official, the Deputy Secretary for Office of Medical Assistance at that time, a fellow named, and God bless him, he was very near and dear to us for a long, long period of time, as Dave Feinberg. And Dave Feinberg's partner, Brad Shop, is still involved with the Psychiatric Leadership Council. But that's what can come from engagement of public officials, folks in the state who are leadership. We currently, I don't know how many of you people are actually on my mailing list and get all this stuff that we end up sending out to you. It's probably 5 or 8 reports a month, and some of them are a number of pages. As I tell everybody before they get on the list, use them, lose them, do it, forward them to other people if you'd like. Guarantee that they will help you deal with insomnia. They weren't designed to do that, but they will actually do that. But it's at those times and with those folks and the engagement of those folks that can lead us to a point where we can get a collaborative effort at the highest levels of state government, along with the boots on the ground that you folks represent, that will make the difference and matter to the people who come into your offices and who are there to receive services and need the support that is being provided on a regular basis. I gotta say, the public health unwinding is certainly not a welcomed event. We knew it had to come sooner or later. That's the way life is. But attending the Medical Assistance Advisory Committee, of which, of course, our own Deb is the chairperson of that committee, and also attending the Managed Care Subcommittee of that Medical Assistance Advisory Committee, I am hearing more and more about the way the Commonwealth is preparing to make contact itself, but also through the managed care organizations, both on the behavioral health side and on the physical health side, and doing so with a great deal of input from the people who serve individuals and the individuals themselves through the Consumer Subcommittee of the Medical Assistance Advisory Committee group. Recognizing the need to get that input from people who are practicing in the community, living in the community, and hopefully their family members. If there's ways to engage family members, we always try and encourage that. It's part of our name. Family Training and Advocacy Center is the father organization to the PPLC. So having that happen for the folks, those 3.7 million people we heard about, at a very sensitive level and at a level that's very aware for folks that that need to hear about it. And we believe, and as we move forward, that, and this will happen over the course of a 12-month period, thankfully, not, like, okay, everybody on April the 1st will have to have a redetermination. Oh my God. So it's going to happen over the course of the year, but we will learn more about the system itself, I think, through how that works and how that goes. We learn a little bit about reprocurement when those new contracts have to come due. We're now going to learn about the functioning capacity within the Office of Income Maintenance and other components of that system. Engaging state leaders is not an ominous task, but it is a labor-intensive task. You're ready and willing to do it. We happen to be up here for the inauguration of our new Governor Shapiro, a very exciting event. And what a speech Governor Shapiro gave us at that inauguration ceremony. That was quite a gubernatorial acceptance speech. Later that day, I was with a couple of folks from Philadelphia, and we just happened to visit a couple legislative offices within the Capitol. We went 0 for 2 on a couple of them. They weren't in. We gave stuff to it's always a good idea to have cards with you when you go visit legislators. We gave a couple of cards to legislative staff. And then we stumbled into the office of Representative Kinsey, who a number of years ago impressed me as a guy that had a trajectory that's going to look a whole lot like this. I mean, this guy has upward trajectory. He's a legislator, representative from the city of Philadelphia. And lo and behold, he was in. He gave us an hour of FaceTime for us to talk about Psychiatric Leadership Council, for us to talk about engaging of families, for us to talk about ways to better deliver service. But we would never have gotten there had we just not stumbled into that office on that given day. You folks all have very, very important jobs. We know that. But there are opportunities for either your staff or perhaps your administrative staff to take an afternoon or a day, find out, you want to make sure the legislature's in session, because that way you know they're going to be in Harrisburg, and then visit those staff. Even if you don't get to see the legislator, if you get to see a staff, it turns out staff have quite a bit to say about what legislators do or don't support. And getting staff online with you and saying, oh, wait, okay, that makes good sense to me. Only you clinicians in the field are able to deliver the information that those folks like to have and would appreciate having as they move forward in trying to make things happen within the Commonwealth. I say this to any new people that are interested in advocacy. By the way, I think the newer advocates need to have a different hair color than mine. I'm just saying. That is very troublesome and worrisome to me, that there really aren't a whole lot of people out there pounding the pavement and yelling and we ain't going to take it anymore type of stuff. That Stan, do you remember any of that when we were growing up? Yeah. Oh wait, we were part of that growing up. Yeah. But it's that sort of thing that we need to see more and more of. But I'll tell you, those guys and women put their pants on one leg at a time, just like the rest of us. They're human. And if you can bring faces in front of folks who are leading policy decisions, your face, but also the face of perhaps one of your consumers who's doing well, especially if that consumer happens to be in the district of the individual whom you're visiting. Dan Frankel's district out in Pittsburgh, Representative Kinsey's district down in Philadelphia. It's very meaningful to them when an opportunity comes to decide to vote for or against a particular policy decision. When I say policy, I'm primarily referring to finances. That's the way policy and programs are kind of developed. But if you can put a face in there for them to connect that face, the next time that they have a policy decision to make, you've done your job. And my guess is it's going to work well. It's going to work well with the people that you visit, but you got to do it. It's the work, it's the effort, it's getting it out there and getting in front of folks that makes really all the difference in the world. You can also solicit opinions from folks who are part of your group. I don't know if the agencies you work for have family advisory committees or other not your governing board necessarily, but advisory committees to help shape policy. They will make a difference in how your agency operates, and that can make a difference in how you can work with the resources you have or recommend additional resources that you may not have yet but hope to get. Those are all ways to engage state leaders. And I got to tell you, if I were to tell you that I entered this field expecting to do that at this age in my life or for the past 12 years I would have said, no, not me. But as it turns out, this is the kind of thing that grows on you. And you might actually get some appreciation for the work that's being done in Harrisburg and the work that's being done by the leaders that are appointed to the director positions as we move forward. We have an excellent secretary for the Department of Human Services right now. She's a physician, had worked as a physician, I believe, an anesthesiologist, and was working with women in delivery, and then realized that no matter how good the work she could do, it wasn't going to be enough if this patient ends up going somewhere and doesn't have a home, it has food insecurity, kind of recognizing the social determinants of health. That's what got her into the field. That's what ended up getting her to be a county commissioner in her home county, along with Governor Shapiro, by the way, and now got her into the position of secretary for the office of for the Department of Human Services. And then she makes choices about leadership. One of them being for the Office of Mental Health and Substance Abuse Services, and choosing the former Secretary of Department of Drug and Alcohol, Jennifer Smith, to be the new Office of Mental Health and Substance Abuse Services Deputy Secretary. A wonderful choice. Someone with experience in government, knowing, and someone who also recognizes that she's got no clinical experience, but is willing to learn and interested in learning. And when she gets something wrong, is willing to say, got this wrong, got to do it again. We haven't had leadership like that at the top of OMSAS in a little bit anyway. But we do have it now, and it's wonderful to see that we're able to get that kind of response. So engaging state leaders, finding ways to make yourself known, especially in the field of public psychiatry, can't be replaced. It is a wonderful asset to have. And the folks in this room and the folks on this call are people that are very, very capable of providing that type of leadership. And we're certainly very, very happy to see that you're engaged and involved in the Psychiatric Leadership Council. Can we ask if there are any questions at the moment for us? We may need a break to do that sound thing.
Right. Well, I do have two other things that I want to say before we move to that. If there is no question, anybody have a question or anything that's concerned that they'd like to raise at the moment? Okay, so how do we do, what do I need to do? Just have them say hello? Do I need to turn my mic off? No, okay. Is there a question in the chat? There's seven items in the chat. Right. Hello, Mira, can you speak?
Hi, yeah, sorry, I wasn't sure.
Oh, yes, you did it. Yes.
I wasn't sure if the sound was working yet or not. Thank you.
All right.
Yeah, what are the first steps if somebody like myself is interested in advocating on the state level?
What are the first steps if you're interested in advocating?
Are you registered to vote?
I am, but in New Jersey.
Okay, but that is a first step, being registered to vote. Another step is, do you vote? And again, you're in Jersey, but that's another important piece. And doing that with your, I'm not saying you should recommend the party affiliation for the people you treat, if you have large groups of folks that you treat, but certainly letting them know that being registered to vote and then voting would be helpful. Believe me, the folks in aging, the folks in education, they're really, really good at that. We're not. But we do have family members and we do have consumers who have interest in the process. So those are the first two steps that I'd recommend. The next is, who's your home legislator for the county in which you're operating now? Get to know who your representative is and who your senator is. You'll have one of each at the state level. At the federal level, you'll have actually three total. You'll have a representative and two senators that represent you. But you need to know who the representative and who the senator is for where you live. And believe me, when you walk into an office or when you call for an appointment with a legislator, one of the things they're going to ask you is your name, and then they're going to ask you for your address, primarily your zip code. And from your address and zip code, they'll be able to tell who your legislator is, if you're a part of that constituency. And they'll be able to tell if you vote or not, and if you're registered, of course. So that's the first step in doing that. What I wouldn't do is go in at your first visit to your legislator and have a series of problems to lay out. You know, you cut us 10% back in 2012, you never restored that, probably not the best step to take. But the first couple of visits might be, hey, I'm out here, I want you to know that. They can be 5-minute visits. I work in behavioral health. If you've got constituents who have behavioral health issues and you want to give me a call, I might be able to help you find some resources. You're not going to be that resource, but you can help find resources for those individuals. And then after a couple of those visits, the next time you visit, maybe you want it to be with a consumer and with his or her family and talk about a specific issue that needs to be addressed here in Pennsylvania. We all know that the workforce is an issue. So talking about the workforce in general maybe isn't the best bet. But if you could think of something individually within an organization, your organization specifically, that would help to deal with workforce problems, then taking that specific issue to your legislator and getting started after a couple of visits of just saying, hi, how are you? Sounds like an elongated process. It really is not. You can just drop in unannounced one day and then call again and talk about another piece. If you have a leave behind document that says, here's where we need help, whether it's funding or just recognition, or I hear the new challenge for this legislature is going to be regulatory reform and, kind of deregulating what doesn't need to be regulated anymore, coming in with those type of recommendations. Psychiatric supervision time might occur to this group, but those are ideas that you can come in and talk to your legislator about over time. Making sense? All right.
Thank you.
God bless you.
The one thing that I would add to what Lloyd just said is that there is absolutely no barrier to you going to see your state rep or your state senator, even as an individual. It's always good also to go carrying some stuff from an organization like the PPLC, if there's activities and things that we're pressing that you can carry with you. But the most important thing is, no matter how old you are, no matter what your expertise is, no matter what you can do or know, if you have something that you want to make an arrangement, an engagement with your state reps, you should feel free to do that. That's actually also true for your congressional federal representatives. They like to hear, particularly from people who are working in the field, and you should not be shy. I think the hardest thing to overcome is the idea of that whether or not you have the right to go bother these people who are very busy, and the truth of the matter is you do. And it's important to do that because they need to know who's out there and who they work with. And if you're in their constituency, they actually care. So it's important to keep that in mind. We are about to go to our panel in a moment, but I want to set a little bit of a context, unless there's another question.
Yeah, we could do it.
I want to set a little bit of a context though before we go to the panel. There are a couple of developments that have come along that are really important. I already mentioned the change of the administration. What I want to say about that just a little bit more is that we have had unprecedented activity at the state and federal level around mental health. That reflects the fact that we, as I talked about before, we are in a mental health emergency. I would claim it as a disaster. While we are ending the public health emergency, the truth of the matter is that the understanding of the mental health emergency that has emerged from COVID and all the things associated or related to it has not been fully grasped by the people. We talk about it all the time. Everybody knows that there is a huge amount of trouble, particularly for young folks, but there's a large bolus of people who are suffering from psychiatric challenges now, larger than we have seen. There are reports, that it's 25 to 30% more folks showing up with anxiety, depression, various kinds of traumas than we have seen historically. And we are seeing this in this overburdened workforce. It is, in fact, an ongoing public health emergency that is not being recognized. And it's going to cause huge, huge troubles that we are not really being prepared to face, with the exception of the fact that there is at least some mobilization at the federal and state level to think about it. I don't think they're thinking about it hard enough, which is one of the reasons that I'm really kind of pressing for the advocacy and why we wanted to have this meeting today, to start talking about what's about to happen and where things might go. By the way, it's not unusual for psychiatric challenges to emerge after the disaster immediacy has passed. So the challenges, for example, that are now occurring in East Palestine are only just beginning psychiatrically. They're only just beginning. If you heard the news today about that, you can hear how people are now anticipating that the city itself or the town of East Palestine is going to be a contaminated site where nobody's going to be able to live in their minds. This is in the minds of the people who live there. They are never going to be able to sell their houses. They're never going to be able to get anywhere, and they are scared to death. And that's just going to get worse, not better with time. There's no reassurance that is going to actually make these folks feel better, because nobody's going to believe that it's better. That's just an example of the challenges that we face. So we have this problem, but we have the opportunity to work with the state and the federal government, because there is a mobilization and there are resources, more than we have seen in my lifetime as a professional, coming down pike in terms of mental health resources. So that's important. We need to focus on that. The other thing I want to say is a little bit about psychiatry. Psychiatry has, in fact, American Psychiatric Association, much to my chagrin, because we didn't think they would do this. We went kind of, had to really get very bare knuckled about it. I was on the presidential task force around social determinants of mental health. We were told by the APA that there was no way that they were going to fund any kind of activity related to social determinants of mental health, creating any kind of institutional base in the APA. It turns out, a year later, after our committee was disbanded, our task force was disbanded, that they have funded a position in the social determinants of mental health, and they are actually taking on a focus around the social determinants of mental health. And they are now thinking about what a social psychiatry actually looks like. That, I think, is really big. And that's really, really important for us, because it means that the work that we're doing focused on health equity, the work that we're doing trying to make sure that the folks who are most dependent on public resources have access to the resources that they need, such as income, right? Such as housing, such as good education. Those kinds of things become part and parcel of our work. We do not anticipate that people are going to be mentally well and healthy and thriving if they are living in poverty, in ecologically damaged areas, in places where they have no opportunities. These are not places that are conducive to mental health, and we now need to be part of the discussion talking about that. We need to be able to highlight those issues, not just how our patients need this, but how the society itself needs to make sure that it's creating opportunities for people to be healthy and well as people and as communities. That opportunity happens right now. We are in that moment now. We are in a particular moment because we are 2 years out from an election for president, right? A little bit less than that. The government, the federal government, will operate for about a year, and then it'll go into election cycle and nothing will happen. So we have about a year to actually work the federal government as hard as we can to get the resources that we need in Pennsylvania to do the work that we need to address the still increasing deaths of despair, and to make sure that the kids of this state have opportunities to be as mentally healthy as possible. These are all opportunities that are before us, and it's going to be this year that makes the difference. So what I want to try to get folks thinking about is, I know everybody's tired. I know everybody's, we've been through this incredible thing with COVID. I want you to think about what you learned from COVID. I also particularly want to reference to you the work that Gordon has done just recently, wrote up a little piece about some of the lessons that we've had from COVID that he's circulating, and we will circulate to everybody. I want folks to take a look at that and reflect on that. What we have learned must not be that we should be complacent now. What we have learned is that we must be active. We've got to find a way to be as active as we possibly can right now. This is the moment. We have to start now. So if you want to continue a conversation about that, we have every week on Thursdays at 6 o'clock, we have a gathering of the PPLC We've been doing this since the second week after COVID started, and we have continued throughout, and we're not stopping because we know that the situation hasn't gotten any better. And in some ways, it's getting to be more challenging. So we need folks to join and participate. It is a great place of support and inspiration, and I want to let folks know about that. Lucy, we send out information to the PPLC about those meetings every week. If you are not getting those announcements, how can they get hold of the PPLC to make sure they get aware of that?
I think it's
L
Green at pmhcc.org, lgreen@pmhcc.org. Perhaps that could even be typed into the chat, but that's the way to get on that mailing list, just in case you are not.
Okay. So with that, I think Lloyd, take it.
So we've been meeting over this past number of years, as you've heard, and we've had a number of discussions that have happened off and on, and then a number of initiatives that have been created. We got an award actually from the American Psychiatric Association, I believe, for some of the work that's being done by our psychiatric leadership group. And then, I'm not going to ask you to come to the front of the room, but we had a member who was part of the Annapolis Coalition. A very widely recognized kind of national think tank that addresses workforce and other issues within our field. And the fellow's name is Mike Flaherty, and he was a member of our discussions on an ongoing basis. So if Deb and Val, if you could stand up, and Marianne, if you wouldn't mind standing up, Allison, perhaps you can stand up. Stan and Wes, would you mind standing? Because, and Ken, of course, because what happened is the recognition that occurred from the Annapolis Coalition ended up in our getting an award, the Innovations Award for this year from the Annapolis Coalition. And I got to tell you, if you want to see a nervous face, watch a granddad live through 3 grandchildren visiting your house and then a Super Bowl party and trying to make sure that something like this doesn't get broken. Well, I am so very happy that it has not, and I'm going to pass it on to Lucy as soon as this meeting is over. But this is our award from the Annapolis Coalition, the Innovations Award, and I couldn't be prouder than to be part of it. Mike, we were just noting our Innovations Award. So happy you walked in at the right time. Good to see you here. Boy, we really wanted to do it in front of him. I'm telling you that right now. Yeah.
So the PPLC represents folks who are obviously psychiatrists in public service, but it represents the other mental health professionals, psychologists, social workers, nurses. We encourage folks to be members in this activity. We represent and include folks who are family members. We include folks who are consumers of services. We include folks who are providers. We include payers. We include the whole apparatus of civil society and its impact and efforts to address mental health. So this is a place where we want to have the conversations that move the state and move this our society forward. And we are about to engage in that with a new opportunities, new priorities, and a new focus on mental health, substance use, how the PPLC can support the Shapiro administration and state legislature. And at this point, I'm going to turn this over to Allison Swigert and Sarah Lim, who's online, to introduce and start the panel. Are you guys ready?
Yep, I'm here. Can you hear me?
Yep.
Fantastic. And I see Allison is just coming up here as well. Oh, good morning, everybody.
Yeah, I think we're going to invite Dale and Mike up.
Perfect, perfect. All right, so we have Dale and Mike, and do we have, Allison, do we have Scott as well?
Oh, yes, that's right. Scott's here in person. Thank you, Scott, for coming up. Yeah, sure. And we have Ellen online. Yes.
Yep, Ellen's here with me, as is Carl.
Okay.
Okay.
All right. I'm going to turn it over to Sarah to get started here.
All right, wonderful. So thank you for joining us this morning. As Ken says, happy first day of spring. I'm personally very excited about that. My name is Sarah Lim. I'm the Associate Director for PPLC, working at UPMC and coming into you from Pittsburgh. Allison and I will be moderating our panel for this morning. I'll be introducing our panelists, particularly the ones online, in a moment. And then we'll ask some questions which are submitted by our members here. We'll be monitoring the room and the chat for questions and comments as they come up, and we'll integrate them as we have time. But we'll also reserve some time at the end for remarks and discussions. So to our panelists, thank you so much for joining us today. I would like to start with our panelist, our first panelist, Ellen DiDomenico. Tell you a little bit about Ellen first. Ellen is our Deputy Secretary of the Department of Drug and Alcohol Programs, which is DDAP. As a quick recap, DDAP was created as a legislative mandate in July of 2012 as an attempt to address substance use disorder needs in the Commonwealth. Ellen joined DDAP in January 2018. In her role, she oversees fiscal, policy, and programmatic operations at the department. Ellen has an extensive background in state government, including serving as Special Assistant to the Secretary of DHS, Acting Deputy Secretary for OMSAS, and serving as Executive Director of the Governor's Commission for Children and Family. Ellen's accomplishments include facilitating an interdepartmental effort to apply for 21st Century Cures funding for opioid addiction services and state opioid response. This resulted in over $400 million in funding to bolster the Commonwealth's efforts to manage the opioid epidemic. In addition to her Commonwealth service, Ellen spent nearly 30 years working in public human services and education, providing direct services and administration in local programs, including child welfare, mental health, intellectual disabilities, substance use, and other supportive services. She served as part-time faculty in psychology and sociology at Susquehanna University, where she received her undergraduate degree, and holds a Master of Science in Education and School Psychology from Bucknell University. Ellen, thanks so much for joining us this morning. How are you doing?
I'm good, thank you. Every time I hear someone read all of that, I think, who are they talking about? It feels like a lifetime, and I guess it kind of has been.
Well, we appreciate all that you have done, and I'm glad to hear that you're doing well. The question from our members was, we wanted to know if you could, well, first make a comment on DEA's new proposed rules for telehealth for controlled substances, and then kind of as a follow-up, if there are any plans that DDAP is thinking about to respond to maybe some of these systemic barriers that might come up for things like medication-assisted treatment.
Sure. So first, let me just say thank you for having me here. I wish I could be there in person. My schedule just didn't allow it. I'm about an hour north of Harrisburg in beautiful rural central Pennsylvania, joining you today. I have to make one comment to something that Lloyd said earlier. Lloyd, I'm going to challenge you. You always provide great insight and really encouragement. You said some folks like me have big jobs. I think we have big missions. We don't do this for the job. And I think it's really important that we think about what it is every day that we show up for work, what it is we're trying to accomplish. And that's the mission, not the job. So I'm going to ask you to change that when you talk about this going forward and folks like me coming to the table. DDAP is really in a very interesting place, as you can imagine, with all of the changes that are happening from a medication-assisted treatment perspective. And it really is an opportunity that we don't often get from both a policy and a funding perspective to really try to use those levers to make a difference. The changes that the DEA are proposing around the medication-assisted treatment and around the way in which it can now be prescribed, taking away what we have, many of us long considered really roadblocks, and really stigmatizing. I think it's really important to remember that when we treat medication for a disease like opioid use disorder differently than we do other medical diseases, we're really stigmatizing it. And we think that that's an important piece to think about as we go forward here. So the new rules that the DEA are proposing, and that are, some of them are already, moving along, and some of them still have a little bit of time to go, will really get away from what was called the Data 2000 or X waiver. It was a special designation just for that one medication that people had to receive. Now physicians who have other DEA normal course of business ability to prescribe medications will be able to do this as well. We really had a lot of individuals in the state of Pennsylvania that did have a Data 2000 waiver. We were over 5,000, but what we knew was that a significant, probably majority of them rarely, if ever, actually use their ability to prescribe. So again, thinking about how this will change that going forward. There are sort of a couple of nuances in that. One of those nuances is around the training piece. So there was previously some training requirements as a part of getting that X waiver on your license. There will be some training required, and we won't really know probably for a few more months exactly what that's going to look like. Although there will be people who will not need that training because of the virtue of their professional medical training, so that they may not all need that. The other significant piece of this, and again, really thinking about low barrier access, really thinking about how we provide access in real time when individuals indicate that they are interested in starting to go down a path of treatment for their opioid use disorder. We know we have things like bridge clinics and things like that happening around the Commonwealth. There's going to be some sort of good news and bad news in that a little bit. We'll have to see how this all shuffles out. So one of the proposals around the Data 2000 waiver going away is that we are able to do telehealth prescribing. And there are, again, the bridge clinics are great examples of that, where folks can get easy, quick, low barrier access, and then the connections to follow up. One of the things that's in the proposals is that there will be a requirement that within 30 days of getting that first prescription, that there is an in-person exam, a physical exam. And so, I'll mention this. Some of you have seen, popping up all over the internet and all over on signposts, all over, these clinics that are online only. It will change their practice. And I think for all of us, we're going to be watching to see if that's the good news or the bad news, right? Is that opportunity to really think about those practices really having to have some sort of a presence to be able to physically support those individuals, or have other mechanisms to do that, might be, from a clinical perspective, the good news, but we want to make sure that we're not doing things that will result in less access. So, from that perspective, just really looking at all of those changes coming down the path. There are certainly also some changes to what have traditionally been referred to as opioid treatment programs or narcotic treatment programs in Pennsylvania. Methadone clinics, by and large, although many methadone clinics have really begun to expand the medications that they use. It is not just methadone anymore. Buprenorphine has become much more of a common medication in those facilities as well. And one of the things that we were really trying to figure out here in Pennsylvania is, we've had under the disaster declarations, the public health disaster, we've had the ability to do longer prescribing or longer take homes of those medications, and really thinking about, we've learned a lot about methadone over the decades, literally, 40, 50 years of methadone use within the Commonwealth and across the nation. And, some of the worries early on, I think we've shown, are not actual worries about that particular medication. And so really thinking about how we can expand access without what had become very difficult for individuals who are trying to live their lives and work and have families when they were needing to go into a clinic daily, was a barrier. It was a huge barrier. So we now have the ability to do, 14 and 28 day take home medications, but we don't have a lot of uptake of that in the Commonwealth, not as much as we had hoped. And so, really thinking about what are still the barriers to that. We've heard a little bit that there may be some funding barriers to that for clinics, there's some financial limitations that occur when you prescribe, I keep saying prescribe, and you all know I'm saying that wrong. But when you provide 28-day take homes, that there's some funding barriers around that we need to make sure we address. As well as really thinking about the other supports that individuals might need. So I think this is all part of the workforce challenges. I think it's all part of thinking about how we use the resources that we do have in our workforces in the best way possible. So really to not, have long lines, folks standing at methadone clinics to get their medication when there may be other ways to use that staff and other ways to have that individual be able to get to work, get to their kids, school events and other kinds of things that happen when you're not tied to a daily need to present at the clinic. So, I think, there's some other things, and I'm very conscious that you told me 7 minutes. And so you're going to give me a sign, right, Sarah? You're going to let me know when I'm almost done. I'll talk really fast. But so, a couple of the other things that we want to think about, we've done some short-term pieces to help address the workforce through our loan repayment for individual practitioners. We are having some conversations with some of you in the room today around, thinking about if there's some ways that we could look at some funding to do some fellowships in an addiction medicine space that will be sort of a longer term piece of workforce, not an immediate solution, but part of a longer term look at that. And we have to think about what are those things, either regulatory or otherwise, that sort of sit in the middle ground there. To really address, and the parallels between the mental health and the SUD world at that place. So lots of quick thoughts and ideas there, but certainly I'm open to other questions and other things that you'd like me to address.
No, I think I really appreciate your thoughts, and it's clear there's a lot of thought about balancing quality of care with access from your what I'm hearing from your comments. So thank you so much for those comments.
Sarah, I know we have a couple questions in the room, and we should have said this ahead of time, but we are going to let each of our panelists speak and then leave time at the end for questions. So please just hold on to those till the end.
Yeah, absolutely. I mean, we can, if I see something in the chat, I can pick off real quick. If we're under time, we will get to it. But otherwise, I think it's probably best to wait to the end to stay on time, because we did reserve time for discussion. Thanks for alerting me to that, Allison. And I see, Andy, your comment, I think we're going to move on at this point, and we'll get to that at the end. Okay. Thank you for sending that in. Please keep the questions coming. So next, I'd like to introduce two individuals. So we have Carl and Scott. Scott Cawthorn is here with us in person, I believe. So hello, Scott, even though I can't see your face right now. I'd like to introduce Scott. Scott is the Chief of Staff at the Office of Income Maintenance, which is under DHS. Scott is a loyal and dedicated servant to all DHS enrollees and his colleagues. He has volunteered to serve as OIM Interim Deputy Secretary during a significant time of transition. After transitioning to OIM headquarters from several progressively responsible roles in the county assistance offices, he served as a key staffer within the Bureau of Operations as a staff assistant to the Director of OIM Bureau of Operations. As one of the leads on DHS project related, or was one of the leads on DHS's project related to the unwinding of the COVID public health emergency, he has proven to be one of the go-to assets for information, transparency, and concise expertise. Scott, thank you so much for joining us today. In partnership, we're sort of in parallel, I'd like to introduce Carl. Hi, Carl. I see you here on the video. You are joining us remotely with Carl Feldman, Director of Bureau of Policy, also in the Office of Income Maintenance under DHS. Carl has spent, as my understanding, 8 years working with the Office of Income Maintenance and 4 years with the Office of Long-Term Living, advancing policy initiatives at the direction of the Secretary and the Governor's Office. he began Commonwealth service in the governor's office in 2015 and is a 2013 graduate of Moravian College. Carl enjoys cycling and vegetable gardening in his home in Lancaster. And I'm really happy that you are here today. So thank you both for joining us today. This is a question that I think we'd like to send out to both of you. Our members are asking if you might be able to provide comments, both about the unwinding of the public health emergency, share with us a little bit about how it's going, and any advice you might have for us that we might be able to give to our patients who might be facing some of these changes as they're unwinding.
Scott, as Chief of Staff, would you like to go first?
Yes.
Sure. Can everyone hear me all right? Yeah. Certainly. Thank you, Carl, and thank you for that warm introduction. I'm very happy to be here to talk about the Medicaid unwinding, as we're calling it, from the public health emergency. The public health emergency started, as we all know, March 2020, and under some legislation that was passed, states were required to keep anyone eligible for medical assistance continually enrolled in medical assistance throughout the pandemic, regardless of whether or not they completed an eligibility redetermination or were otherwise found to be ineligible through income or other circumstances that would qualify someone for medical assistance. There were a few exceptions, of course, moving out of state, applicant passing on, and so forth. As of January 2023, as I said a little earlier, we have about 3.6 million enrolled in medical assistance. And as we move forward into the unwinding, as a result of the Appropriations Act that was passed at the end of 2022, we will be looking at completing a renewal for all of those individuals. And to be clear, throughout the PHE, Pennsylvania Department of Human Services Office of Income Maintenance made the choice to continue to send renewal packets to each family and household. So they continue to see that information coming in when their renewals were due and return that information. As a result of that, we've seen renewals come back, and we have about 600,000 that we believe would be ineligible based on the information they've already told us. We have about another 575,000 individuals who've been continued to receive medical assistance, but from whom we've not heard. So they may not have completed a renewal packet. So to be clear, one of the important pieces to this is we're not going to just start closing people April 1st. Everyone who's been held open through the pandemic will have an opportunity to complete a renewal and have their eligibility redetermined. And we have a very aggressive outreach program that we've outlined in order to send that message. We start 90 days out, 60 days out, and then 30 days out with progressively more detail, more information saying, you're going to need to renew. We're using what we call helper calls. We're using text messages and emails. We're also using paper mail, and of course, the renewal packet that we're sending them. One of the things that we've heard from our advocacy community is the need to make sure that we have accurate information on our households, updated information, the correct address, the correct phone number, and correct ways to connect with them to ensure that they receive the information they need to respond back. We are now in March, and this April will be our first renewal where the renewals that are returned, we will take negative action on those households. And so with that, we sent out text, as part of our communication plan, as I just said, we sent out text messages. And there's been some concern about, well, will people respond? Will they see a call to action? And so I've got kind of what I'd like to say, let's see the silver lining in this. We sent out a text message and we received tremendous response. We included our Compass link and our Consumer Service Center phone number. That's where someone who can call, have their renewal completed over the phone by someone acting as a Compass community partner, our contracted entity. We saw a tremendous response to that, so much so that it sort of overran our customer service center. We also looked at our Compass metrics to see what was the response online? How many people took that call to action? And we saw a year-to-date high renewal rate return in one day from that call to action. So we're silver lining. People are seeing the message. Where we didn't anticipate was the overwhelming response to the phone. So we're looking at how can we, tweak that to make sure that we're not overrunning our infrastructure and still allowing that opportunity for people to connect back to us. We, as was said earlier, we are taking 12 months to unwind the public health emergency. So that meaning we will be doing approximately, 1/12 of our caseload each month. It's really beneficial for the recipients and also for the Office of Income Maintenance, because trying to compress all of those renewals into a shortened timeline places a tremendous amount of workload on our staff, who are also doing SNAP applications, LIHEAP, all of those other programs that we're administering at the County Assistance Office, ensuring that we're also making sure that we're connecting those individuals and evaluating their Medicaid eligibility. And if not eligible for Medicaid, making the appropriate referrals to Penny, to our child's health insurance program, and ensuring that we keep as many people connected to medical assistance as possible. So I'm going to pause there and ask Carl if there's anything he'd like to add.
Thanks, Scott. I think you did an excellent job sharing about where we've been and where we're going. I too would love to be with you in person, but I'm recovering at home from an injury. What I'd only add to Scott, what you've shared, is the specific ways in which this group can be engaged in assisting people to work their way through the public health emergency. As Scott said, people are going to receive their renewal and they'll need to complete it as soon as possible. Throughout the entire 12-month unwinding period, no one will be terminated immediately on April 1st when continuous coverage ends. And so on our PHE website for the department, we've got a couple specific areas that we think will be helpful. The first is our helper portal. This is an ongoing listserv specifically to connect people to information about the unwinding as we get it. We'll put that in the chat. You can sign up for that with an email. The other is our communications toolkit. This is a broad list of many different documents, you can print, scripts you can use, social media graphics you can steal and communicate effectively about the unwinding and all the various calls to actions that are necessary. And then finally, we also have a page which includes every piece of communication that we are sending to the medical assistance recipients. So if you encounter someone who is getting their renewal or hearing from us, there can be no doubt that those are legitimate engagements, and you'll know exactly what it looks like. And we really hope with those three areas in particular, you'll find it useful and we'll be able to help people throughout the unwinding. I agree with Scott. I think the biggest thing that's changed here and that we're really excited about, that 90, 60, 30-day time frame, we've never before had text messaging to recipients to push them to renew with that direct call to action. We never before had automated calling, our helper calls, to remind people on multiple occasions to do what they need to do to maintain their coverage. And that is a game changer for us. And we hope that it'll be a game changer for the unwinding too.
Thanks for sharing your thoughts and comments. That's really interesting. I have so many questions about that, but I'm glad that we are going to get to follow up with our members after. So appreciate comments from you both. And I see the resource as well posted in the chat. So thank you for that, for that as well. At this point, I'd like to turn things over to our Harrisburg team. Allison Swigert is the other person who's moderating. So take it away, Allison.
Thank you so much, Sarah, and thank you for our panelists who've already spoken and your comments. We're going to move to the second half of our panel here. So I'm going to move next to Dale Adair. Dr. Adair is a psychiatrist, graduated from University of Pittsburgh School of Medicine, completed his psychiatry residency training at UPMC. He currently serves as the Chief Psychiatric Officer and Medical Director for the PA Office of Mental Health and Substance Abuse Services. more usually known as OMSAS under the Department of Human Services. He has an extensive history of experience in state government, and in his current role provides clinical expertise and consultation to the Deputy Secretary of OMSAS and the Secretary of Department of Human Services. He provides input and guidance into policies which affect the provision of mental health and substance use treatment throughout the state. And in particular has been a leader in the development of multiple important programs throughout the Commonwealth, including the first episode psychosis program, which is near and dear to my heart. Also efforts with the Center for Medicare and Medicaid Innovation Accelerator, Substance Use Disorder Project, Centers of Excellence, COEs for the treatment of opiate use disorder, and has served as project lead for certified community behavioral health clinic programs throughout the state of Pennsylvania. Currently, he's involved with efforts at suicide prevention and also serving as a lead on our state's efforts to implement 988 and crisis care. So I'm gonna hand Dr. Adera mic there, and the main question from our group was about the future of telehealth provision for mental health care in the state of Pennsylvania, and what's that going to look like moving forward, including whether we'll be able to use audio only platforms.
Well, thank you. This is on, right?
You guys know? Very close.
Yeah, I have to
There
get
we
it
go.
closer. Okay. All right. Thank you for that assist. Thank you for inviting me to come and speak. And I will tell you, because I know that you had also invited Secretary LOCUS to come and speak. And, unfortunately, or fortunately, she is at the CCAP meeting speaking this morning, and thus could not be here. So she did, it is downstairs. She did want to convey to all of you, though, best wishes for this meeting. And, Lloyd spoke to this, but she really has a couple of things that are really high on her list. One is collaboration with all stakeholders. And so that was one piece that she wanted to make sure that I delivered to all of you. And the other really was, has already been spoken to, and that is around the unwinding. So I'm glad you were here because you saved me from talking about that. So telehealth. I came back to Pennsylvania in September of 2019, and then 6 months later, COVID hit, and we all, resorted to a lot of remote work, right? Telehealth is something that we had been growing within psychiatry over the years. Obviously, when March of 2020 hit, then we saw a real big expansion in growth of telehealth. Telehealth is not going to go away. What we have seen is an increase in access related to it, which has been very, very important. I will tell you, we've had the University of Pittsburgh taking a look at the use of telehealth during the pandemic, comparing pre and post. And obviously, in all fields of medicine, there's been a expanded use of telehealth. But the biggest use in Pennsylvania within Medicaid has been behavioral health wise. Roughly a third of Medicaid enrollees have used telehealth, at least one visit via telehealth. Now, so it's definitely made a difference. I think there are some limitations with telehealth. I would be remiss if I did not tell this group, though, I do have one concern, Because what we have seen has been an increase in providers who are saying the only thing they want, the only way they want to deliver services is through telehealth. That raises immense concern for me as a, I don't actually practice anymore. I stopped when I came back to PA, but as a psychiatrist, that creates concern for me. The Medicaid program is built on choice, right? And part of that choice is if I want to see someone in person, I should have that ability. I believe that, and for years I had argued this, that there were people who we were missing. And just think of somebody who has agoraphobia, right? Who won't leave their house. Telehealth presents an opportunity then to provide that individual with treatment. But I do believe that even from a physical health standpoint, I tell my primary care physician when they want me to be seen via telehealth, I prefer coming in, right? Now I may be old school because I am a little on the seasoned side, but I think there's still a position, an opportunity, and a need for that to occur. So that's my one concern. Audio only, and I'm gonna make this short because I want to make sure that we do have time for questions at the end. But Act 98 of 2022 eliminated aspects of regulation that prohibited the use of audio only. So when that came into effect, audio only can occur. It allows for the payment of audio only. OMSAS is currently working on a bulletin that will detail all of that, but audio only will be available. And with that, I think
Thank you so much, Dale. So last but certainly not least, we're going to turn to Mike Schlossberg. Mike is a Pennsylvania State Representative from the 132nd District in Lehigh County. He's a long history of tremendous advocacy for the provision of behavioral health care. For this current legislative session, the 2023-2024 session, he was elected Democratic Caucus Chair and as co-chair for the House Mental Health Caucus. And then he, in fact, co-founded the Mental Health Caucus in 2015. He's also been involved in efforts more nationally with Congresswoman Susan Wild to help enact federal legislation to improve mental health care access across the country. He's been appointed to the Mental Health and Justice Advisory Committee for the Pennsylvania Commission on Crime and Delinquency, and was named co-chair of the Suicide Prevention Task Force by Governor Wolf. Recently, he received an invitation to join the National Task Force on Workforce Mental Health Policy at the National Conference of State Legislatures. In 2022, he outlined an agenda for mental health care and improving and promoting safe and healthy communities called Hope for PA. He also was instrumental in the Behavioral Health Commission on Adult Mental Health this past year, 2022, helping to create a strategy to allocate the $100 million of funds that were allocated for that. There's a whole lot more, but I think I'm gonna stop there in the interest of time. And I'm sorry to say that you've probably been given the most broad question to speak about, which is, what challenges do you see facing the behavioral health field, and what role do you see as that the government has in responding? And I think there were also, I was also hope you could talk a little bit about the status of the recommendations made by the Adult Behavioral Health Task Force and where that stands. So.
And thank you for the introduction. Thanks to all for all of you for coming out. It's nice to see so many of you again. Broadly speaking, from a challenge perspective, I think that things have changed really dramatically, even in the relatively brief time I've been involved in this universe. And so many of you have certainly been at this longer than me, so I'm sure you know more than I do. But from a policymaker perspective, I will say, I think you've seen really remarkable and positive gains in public conversations around mental health and stigma and the need for telehealth and in the political potency of mental health in general. I think a lot of that has been caused by, not exclusively, but a lot of that really was caused by COVID, because so many people had a firsthand experience with themselves or with their loved one having some sort of mental health challenge during COVID. We all pay attention to the news. You see the same reports that I do that show how rates of mental illness are skyrocketing, and they're skyrocketing the hardest among young adults and children and teenagers. As a father of a almost 12-year-old and a 10-year-old, I listen to the way that my kids talk about mental health and the way that their friends talk about it. And it's heartwarming because they bring up seeing a therapist in a much more casual light than I did when I was their age, 25, 30 years ago. And that's wonderful. The challenges, I would say, are multifaceted. The chief one being rates of mental illness are skyrocketing for reasons that I think are well beyond the control of government. You're talking about something that's deeply societal, structural, cultural, and there are things that you just can't do in government. I don't know 100%. I have some thoughts, but I can't speak coherently to why rates of mental illness are increasing so much. I think a lot of it is cultural. I think a lot of it really is technological. But there are only so many things that we can do in government. The biggest thing we can do in government is try to make sure that anybody who needs the care can get the care that they need, which leads to the greatest challenge I think we face in public policy, and that's workforce. The workforce issues that we're facing are obviously overwhelming. It's the biggest challenge. I can't tell you how often somebody calls my office and says, my son is suffering and they need a psychiatrist or a psychologist. We can't see anybody. That's an area where I think we can do more in government. And I guess that does tie in to the distribution of the $100 million that we allocated in the 2022 budget. So just to go backwards for a second, my original hope for PA proposal was $100 million in recurring funding for mental health needs. No, we didn't get that. What we did get was $100 million in one-time needs that came from federal funding that can go towards mental health needs. We met pretty extensively last year, the Behavioral Health Commission. I'm sure many of you paid attention to it, were on it, saw the work that we did, adopted a report unanimously that said the money will be distributed for workforce development, increased collaboration and coordination, and criminal justice, a lot of funding going to counties. We ran into, predictably, some pushback on that, specific allocation of the money. The good news is that the money's there. It's literally just sitting there. We're going to spend it. I know we're going to get that money out the door. Are we going to get it out the door the way the commission laid out? No, because there's always going to wind up being some pushback in particular. And unfortunately, there seems to be perpetual concerns about county funding. And if counties have money, there were some concerns that there was already that some of the ways the report laid out, the spending should be enacted, would be better for recurring rather than one-time use. So the report is going to get tweaked. The good news is that those conversations really have started. For those of you who pay attention to politics, you know that the House flipped from Republican to Democrat, which means I think we can get the legislation through the House relatively easily. And I will say it's moving in a bipartisan way. I've already begun conversations. It's a 102, 101 margin in the House. So there is no room for error. And I don't think about that at all. But we have started those conversations with Democrats and Republicans. The chair of the Human Services Committee on the Democratic side is Steve Kinsey from Philadelphia. The chair on the Republican side is Doyle Heffley from Carbon. Both have expressed an interest in working together with me and with the commission to get that legislation moving, and both understand the need to get that money out the door as quick as possible. I do think the Senate remains a little bit more of a challenge, but we've engaged with our Senate counterparts and are looking forward to working with them to get this money out the door as quickly and as effectively as possible. And on that note, I am happy to turn the microphone back over and answer any questions you folks might have.
Sure. Thank you so much to all of our panelists for the remarks. And I'm going to congratulate all of you on sticking to the time frame. I think that may be unprecedented. So, which is great because it leaves time for questions. So we're able to take questions through the chat and also from the audience here. We're going to start here in the audience.
Elizabeth Kunkel, I'm the Chief Medical Officer at Pennsylvania Psychiatric Institute. So the question I have crosses across a couple of you. So we're delighted to hear you guys talking about increased access and what's going on in the telehealth regulations. One nuance with the audio only is that we're still being required for folks who have medical assistance to get electronic signatures, which, as you can imagine, is really difficult if you're on the phone with somebody and or if the person does not have an email. So then you're using snail mail to mail your treatment plans and mail your visit verification. So that's one challenge that we're facing in the community. The other thing has to do with the DEA regulations. And we have the DEA overseeing our prescription of controlled substances, but they're tying the prescription of controlled substances to what's going on in the telehealth world, which does not make a lot of sense to us. So we are concerned that the regulations requiring live visits for telehealth for controlled substance prescribing are not only going to affect the opioid world, but they're going to affect children, mental health, and drug and alcohol, particularly for stimulants and benzodiazepines, which right now is a problem because as much as we have a workforce shortage, we have an even bigger shortage in child psychiatry. So if we're saying that if you're prescribing stimulants, you got to get the kid in and the parent, which means the parent can't work, we are creating a real inequity for children, mental health, and drug and alcohol patients that crosses both the DDAP lines and the telehealth lines. So maybe Ellen, Dale, maybe you guys could comment on this, and maybe all of you actually, it hits Mike's comments as well. Thank you.
Ellen, do you want to go ahead and respond first?
Sure. I perfectly am hearing what you're saying. I think that this, in my estimation, was at least better than what we had in place before. Not perfect. So that what our understanding is of what this requirement will be is that they'll be able to prescribe buprenorphine as an example for 30-day supply, but then at that point there should be an in-person evaluation for continuation, not regular ongoing in-person evaluation, but a one-time evaluation. Again, not that it's not a burden, and we do understand where that presents some challenges. We would hope that, we know that medication for opioid use disorder is effective in itself just by the use of the medication, but that for many individuals, there's also the need for some sort of other ongoing therapeutic intervention, counseling, for example. And so we would hope that there would be ways for those things to happen in conjunction as opposed to separate standalone visits. So some coordination, some technical challenges, and we'll see where the final regulation actually lands in terms of what that looks like. None of this is actually in place yet. It is proposed.
To what Ellen just said is that, remember, it's a proposed rule and they are taking comments, right? I have been part of discussions where those issues have been brought out. So those are ongoing discussions. We've been hearing, particularly in the child arena, in adults, but around stimulants, the shortage of Adderall as an example, and all the challenges that is creating as well. So, we are submitting comments to the DEA. I would encourage any of you to submit comments to them. The feds, have those comment periods so they can hear from the field and from anyone who's interested, and they do take those comments into consideration. Does not mean that we always get, that they do what we believe they should do, but they do consider those things before they come up with the final rule.
So.
We'll go to Ken next, and then we'll try to take a question
So
from online.
I wanted to spend one more second on this issue, then I want to come to another question. I want to be clear about the stimulant and the benzo issue, because that is bread and butter for many psychiatrists working in the field, which would not be theoretically under DDAP, but is obviously a substance use concern. I guess the question that I have is, how do we think about that, and who do we think about that with relative to the proposals that we as a state would suggest back to the DEA and to other entities? Because it is really a challenge right now to imagine having all the folks who are using stimulants or clonazepam coming into the office. This gets me to the issue, Dale, that you mentioned, which is, in-person visits and the extreme challenge that I face as a psychiatrist, where once I moved to a video or telephone platform, my rates of no-shows dropped down to essentially zero. And that has meant that I've been much more busy than I was before. Not that I wasn't extremely busy before. Now the reason I do it is because I don't have to commute. I have the time because I don't commute to work anymore. That has made it possible. If I go to work and I both do visits in person, which I'm very worried, and I have seen evidence from other folks that even though people say they want to come in, they frequently do not. So we see a drop in the use of services because folks are not on telephone. How do we do the logistics of this? I think is going to be a real challenge. It's not so much an issue. I agree with you. There's some people who need to be seen in person. There's some people who would request it. I also think that we want to make sure that we don't drop it and suddenly find ourselves having lots of people not being seen because we have moved away from doing as much of the telephone and video as we can. So I wanted to just make that point and think about where we go with that. That actually drives me to the next question, which is the issue of the unwinding. I work at a federally qualified health center. I work in a community mental health center. We are desperately worried about what's going to happen when folks lose their Medicaid and are not eligible for Penny or don't subscribe or whatever, that we are looking at a potential shortfall of several hundreds of thousands of people who are currently covered, not being covered. And what that means for the state, what that means for safety net organizations, the whole process is something that really distresses me. And kind of an example of that is people who are currently eligible for Medicaid and are being asked now to re-up. If I was somebody who had any concern as to whether or not I was eligible, I would put that off as long as I possibly could. Just because why would I take the chance that you guys are going to tell me that I'm no longer eligible, and now whatever care I was getting, for example, I'm getting treated for cancer, I'm getting treated for this. Now you're going to say, oh, sorry, you don't have coverage anymore. That really worries me. And I don't know what the scope of that worry is. So I'm looking for some sense of how worried I really need to be about who those folks are and how many of them there are going to be.
Okay, thank you for that question. And Carl, I'm going to ask you to help me out here as well. And we are equally concerned in the Office of Income Maintenance, Department of Human Services. We want to make sure that those who are eligible complete the process and remain eligible. And to your point of, putting that off as long as possible to otherwise not communicate with us, if their renewal is due in April and they fail to complete any part of that renewal process, we will take negative action. If they do complete the process and we find that they're not eligible for medical assistance, we have automatic referrals that go to Penny, provide all of the information that the family or the consumer has provided to us. We provide that over to Penny so that Penny can continue that outreach and work to keep that individual connected to medical services. Likewise, our children's health insurance program for those under 19, if they are currently on Medicaid and they're not eligible, we automatically transition them to the CHIP program. And as you know, in Pennsylvania, every child is eligible for CHIP regardless of income. So we will take all of those children, transition them to CHIP. Again, then it falls to the family if they're at a CHIP segment that requires a co-payment or at cost CHIP from the family. It will then be up to the family to continue that enrollment. But we do have the pieces in place. The important part for Department of Human Services is that those individuals return the information so we can make a determination. Because if we can make a determination, we can then at least push them to, if they're not eligible for medical assistance, we can push them to our partner agencies. If they don't send us anything, we don't know anything about their circumstances, we will have to take negative action for just really not understanding their circumstances and whether they are eligible for medical assistance or could, potentially take advantage of our partner agencies in the Commonwealth.
Do you have any idea how many people would not be eligible for Penny or any other service? And what the likely numbers are that we are looking at who will lose the Medicaid coverage and have nothing to replace it with?
We don't have a solid number on that, other than to say about the number I referenced earlier, which is about the 617,000 number of individuals who've already completed a renewal at some point during the public health emergency. We've evaluated their circumstances, and it's likely that they would not continue in medical assistance absent the public health emergency and our mandate to continue to cover them.
So 600.
Roughly I would say roughly 600,000. Carl, I would ask if there's anything that you would have to add to that question.
Yeah, I think you'll find the department and other Medicaid agencies around the nation hesitant to say how many people they think are not going to be eligible, because circumstances change. They have an opportunity to renew, and we hope that they take it, because if they do, we can at least make the transition to Penny. They can get the subsidies, and it's pretty decent coverage there. I can say that nationally, I think the Medicaid enrollment overall has grown like 27%. I think it's grown about 27% in Pennsylvania. So I think we know that there's definitely people who enrolled at the height of the pandemic who are not going to be eligible. And that's just how the Medicaid system works. And so no doubt there are many people who unfortunately we can't continue to serve in the program. How many people those are, we're not really in a position to be able to say. There's going to be people, Scott mentioned the folks who were not eligible when they returned the information. Some of them will have changes. The people who didn't return information at all, many people decide they don't want to do the paperwork or fill out the forms online when they think, well, I have a job now. I have TPL, I've got something else. So it's a constant struggle for all state Medicaid agencies. But I think it's right to assume that many people who are currently enrolled will no longer be eligible just based on the way that the Medicaid system is structured nationwide.
I think we'd like to go to one of the questions from online. Sarah, are you able to access the chat?
Yeah, I think this one might go back to you, Ellen. This is from Andy Hogrogrian from UPenn, who's a fellow there. Hoping you could just touch on this idea of, you mentioned take home dosing for methadone. And he was wondering, are there any thoughts of potentially like new requirements or eligibility criteria for that are being considered?
One of the things that's happening with the new proposed continuation regulations around the take-home eligibility, the extended take-home eligibility, is that it's really moving back, we think, in a positive way to making it a clinical decision. So rather than setting up arbitrary standards, there used to be some time standards, like you had to have been on methadone for a period of time. It really is moving back to really looking at this from the clinical perspective. Is the individual stable on the medication? Does it need medication dosing adjustments and other kinds of things that would require more regular check-in with the clinical provider? So really for both the 14-day and the 28-day, it really, they use terminologies like strong, stable. They use stable terminology. So really making it much more of a clinical decision rather than a regulatory decision.
Thank you.
Do we have the mic for someone here? Okay. We're going to go ahead with another question in the audience here.
Yeah. Oh, there. Yeah, it took a second. I actually sort of have two questions, but if it's too much, you can pick one. So one is going back to the telehealth situation. And I am maybe in the minority of people who find telehealth really difficult for the patients I see. I wasn't in Pennsylvania when COVID started and for the following 2 years, but my like show rate plummeted during COVID and telehealth. And the overwhelming majority of people I continued to see were audio only. This was working in a county-run clinic. And so I do have a worry that some of the assessments we do of telehealth access not accounting for, and these were also, I will say, largely uninsured, not Medicaid insured patients. And so that there are these big chunks of people where telehealth is not actually helping them access care. I also work in geriatrics, and not physically seeing people is I deliver significantly worse care, right? Even with video. And so I'm wondering if, in addition to sort of the discussion of how we continue to allow telehealth, there is also any type of, I know people don't like being told where to spend the money, but like if there's any sort of coupling of funding that would allow more support for in-person visits, either by, pairing with transport help that is like, blocked into any of that funding, or I am personally invested in, out of clinic visits, which are not lucrative. So if there's any type of funding being set up for other models of delivering care so that we actually can see people in person, even if just keeping your appointment and coming into the clinic is still a barrier. And I can just say that the other question I was going to ask is just sort of, where do people think that all of the people losing Medicaid coverage are going to end up going? And like, what are the systems that are going to be hit with those people?
I'll attempt to answer the first question. I'll leave the second question alone. So there will always be support for folks that want to come in for visits, right? Because I think you have to have availability of all of that for individuals. As far as the transportation piece, I think that's a little more nuanced. And I'm not quite sure of how that ends up being built in as far as transportation. We do know that as far as barriers for people receiving treatment, oftentimes transportation is one of those issues, right? Even individuals live in the city like Philadelphia that has, as far as Pennsylvania is concerned, has one of the best public transportation systems. It's not uncommon to hear individuals in treatment in Philadelphia talk about the challenges that they face in getting to a clinic. So I think that's an area that we probably have to take a look at. I don't know the precise answer to that question, but obviously, one of the things you've heard from me is the importance of people being able to come into the office. I don't, it's not for everyone. Everyone will not need that, but I do believe it needs to be an option that is available for people.
Allison, we have a hand up here from Ellen. I think he wants to add some comments.
Yeah, I just want to address the second part of that question, if I may. Really, the question around, what happens when we lose a pretty significant piece of funding of behavioral health services through the unwinding. So the mental health system, as well as the Department of Drug and Alcohol's county level systems, really are built on some assumptions of paying for uninsured and underinsured individuals. I will say that from a DDAP perspective, as we've seen the number of individuals eligible for Medicaid over the last couple of years go significantly up, more individuals being funded in that way, the number of individuals being funded by the county dollars has dropped. Obviously, we were likely to see a reverse there, right? So more individuals coming into the county system for funding than and while folks are dropping from the MA rolls. And while we don't anticipate in the short term that being an unfundable change, we do worry about what that means for the long haul. And specifically, I'll talk about some of the other things that, we've done. So when we have not needed to pay for treatment per se, because of that longer term eligibility, we've been able to fund a number of different initiatives that we think support the system in general, mostly around recovery supports and supportive services for housing and supportive services for employment, and supportive services to families. And, as we try to figure out what that balance looks like, that may be sort of the scale tipping that we won't be able to be as robust in some of those changes. So that's part of what we're going to be looking for to see what happens as the unwinding happens. So in the short term, we don't anticipate individuals not being able to be funded for the treatment services they need, but there could be a long-term shift.
Thank you. We're coming down close to our time here. I did want to ask one question of Mike, which is, I think as behavioral health providers, we all see the profound importance of having more funding from the state in terms of providing these programs, whether it be the $100 million allocation from the Behavioral Health Task Force or increased funding for counties, which was mentioned in Governor Shapiro's budget address. And just wanted to ask you, what we as providers might be able to do to help move some of these initiatives along.
The answer and a great way to close out remarks, I think, and that's stay in touch with your elected officials. Continue to work through groups like this, but also I would urge you on an individual level to try to find out who your state senator and state representative is and have a longer conversation. The nice thing, at least at my level, is I only represent 65,000 people, which means if constituents want to have a one-on-one phone call, Zoom meeting, in-person meeting, that's something that we can do. I would definitely encourage you to reach out to your elected officials directly, because we do remember those conversations. I can't speak as well to the Senate. They are bigger than us. Certainly, I have 250,000 people, but with 65,000 people, you get a few folks who care about an issue and it does make an impact. So please connect with us and tell us what your thoughts are. That matters.
Thank you, Mike. And I think we're going to take one final question in the back here.
Yeah, good morning. Just want to build on a couple of threads that we hear and ask really, I guess it's Carl. I build on a couple of threads here and a question to Carl, I guess. He indicated that there are 600,000 that are completely ineligible in the unwinding, and another 575,000 that are at risk. You haven't heard from them. Is the department considering providing information on the primary diagnosis or condition of individuals that are losing coverage, to build on the other points in the Commonwealth? Obviously hospital emergency departments would be providers of last resort, but also counties. To Ellen's comment, the counties have been level funded for over a decade. A lot of the system is kind of in crisis now. And it would be extraordinarily helpful to know. I've seen the data that basically provides gross numbers per county of people who are losing eligibility. But is there some way to tease out whether or not, of the 200,000 people in Philadelphia that are going to lose coverage through this process, that 100,000 of them have serious mental illness, or some that the system needs to prepare for in the context of an environment where there's extreme shortages of personnel, mental health professionals, the people in this room, as well as years of level funding and declining rates of service. All of those things seems to argue for a time for greater coordination as it relates to information sharing. I think there's obviously a statement, but a question to you as to whether or not we can get additional information about what needs these individuals may have.
So I think I wanted to say first, that despite the fact that these people have sent us information indicating they're not eligible, they're not going to be disenrolled right away. They're going to have an opportunity to have a renewal conducted over the unwinding period. So that's very important that everyone remembers that. The 4/1 date, that's the beginning of the unwinding period, end of continuous coverage. That is an administrative date for us to communicate to everyone. This is the date on which we can resume closing cases in the event that someone's not eligible. But a person may have their renewal and have their eligibility evaluated at any point over that 12-month period. So to your second question about the information, what I can say is that we have throughout this process been sharing with the behavioral health managed care organizations the specific list of people who are in that cohort. They didn't return a renewal. They sent us information showing that they're ineligible. So the behavioral health managed care organizations and the counties actually have the information to be able to do that analysis themselves today.
All right, so we're a little bit over time, so I think we're gonna wrap things up here. I'm sure we could all chat for a lot longer and ponder ways to make healthcare in our state better. But I want to extend a very warm thank you to all of our panelists for taking time out of their busy schedules to come and speak with us. So thank you, Ellen, Carl, Mike, Dale, and Scott. Thank you so much for being here. We look forward to continuing to build partnerships across these different areas of state government to really better the care that we provide for our individuals in Pennsylvania. So thank you very much.
I think our IT.
Yes, thank you for keeping us on track, Ken. We are on break till about 10:45 or so.
Is there another microphone floating around out there? Okay, terrific. Do you want to sit? Do you want to stand?
Stand. I've been sitting. Okay, you can sit. I'll stand, and then we'll be about the same size because I'm actually I'll be taller than you. Okay. So we're gonna look at a time here to reflect on the morning's discussion that Sarah and Allison helped us walk through and really covered some wonderful topics. You do really have to get close to this thing to get it to work. All right. Before we start with our own thoughts, anyone from the audience want to make some comments or share some additional questions that you would have loved to have asked? And so maybe one of my first thoughts is, can we start to have a dialogue with some of these folks on a more standard basis to get our questions continued to be answered? Might there be a dialogue? Could we set up an infrastructure around such a thing where we have a core group to work with? And I know Dale is still here, so I don't know whether his thoughts, although he's always available if we have questions, he usually is responsive. So that was my first thought, is can we do this not just yearly, but more frequently?
Yeah, I guess I want to make sure that are we hearing anything from folks online? I don't know if there's anybody monitoring the shop. Can we tell? You're there. Oh, Lucy, okay, I can't see you. There you are. Anybody in the audience, any other just reactions to what you heard today? Kathy?
I just wanted to respond to Mary Ann's suggestion, which I thought was a good one, and just posit that, thinking of the groups that met throughout the pandemic on a bi-weekly or weekly or monthly basis, that maybe going forward, for instance, the racial disparities group was a very task-oriented group, as opposed to the other group, which was more generic, I would say. And that maybe we might want to use some of that time or that newfound ability to get together kind of subcommittees of this group to meet on a Zoom basis to address some of these issues as they come up more effectively.
I do like that idea. It's like finding an infrastructure where we could have that more ready dialogue, and they can hear what our needs are, and we can hear what their work is and where their barriers and how we might be able to be helpful with those barriers.
So I know the AAMC and the NABH are preparing responses to this DEA proposal that has us doing live visits for controlled substance prescribing. So I would offer to share comments that I've made on the proposal, but I think it would not hurt for PPLC to send out a response to the proposal as well.
And I will share that the Pennsylvania Psychiatric Society's Government Relations Committee has been working actively to provide some feedback and response to the Behavioral Health Commission fiscal part of, where are they looking to break out that funding and to what targets after the commission met last year. And so once those are finalized, we certainly can look at how that might get shared as well. Because
Can you say something about that? This is the financial element of the commission that is a continuation of the commission that we had before.
I'm not sure I'm going to be able to answer this well enough. If I had Ken Serta here, he would be able to answer it, or Lois Haggerty. My understanding is that the commission made the recommendations, but it has to go through a fiscal process so that monies are released to certain specific areas.
Well, do you know about this? We had a commission, the 100 million at Mike's commission. Dale was a co-coordinator of that. Where does that stand exactly right now?
Senate. If I had to guess, I'd say. But look, this is just me talking, okay? Not somebody from PPLC. It's the Senate. And if we can get somebody in the Senate to agree, I'm sorry, am I embarrassing? No, good. Because we need to get the Republican-controlled Senate to agree to the disbursement that was centered and focused and created and made by the commission itself. And we're not able to do that. Senator Brooks, majority chairperson of the Human Services Committee in the Senate, has basically held one hearing. Near as I could tell, there were no different recommendations that were made at that hearing. And the money still needs to be kind of appropriated through the legislature. So somewhere along the line, somebody needs to be able to create enough heat within the Republican-controlled Senate to make a recommendation for the dispersal of those funds to the House, which, if it's reasonable, I would assume would collaborate and cooperate with that. But right now, I think that's where it lies, and how it gets released will depend on their willingness to do that.
So when Marianne is talking about the financial, how does what you're talking about fit into the process that he's talking about? Is the group you're working on trying to get the Republicans to do take the action that they need to take, or is this? I guess I'm trying to figure out how the Psychiatric Society is imagining its role in this, and how we might buddy with them in that process.
They're working with legislators
To do that.
To do that.
Okay.
Correct.
Okay, got it.
Dale, you would?
Yeah, Dale, maybe you know something about this.
So the only thing that I can tell you is that there's some draft legislation going around. I don't remember if it's within the House or the Senate that actually looks at doing a couple things that the commission end up putting in the recommendation. One is extending or creating a new commission. And number two the important part of what you're talking about, it lays out disbursement of the funds. For the legislature to allocate the monies, it requires some act of legislation. So there are a couple of the legislators that have actually drafted some legislation.
So-
Hasn't been introduced yet, I don't think, though.
So a question that we could ask is, are there any folks in the PPLC or other related organizations that live in the constituency areas of any of the folks in the Senate who might be influenced by hearing from somebody in their constituency? Right? Is there a way to find out who those are, what areas they are, and sort of alert people in the PPLC to that?
Of the folks who are drafting the legislation, or which folks are you talking about?
Well, probably both, but obviously the people who are most significant are the folks who are oppositional at the moment.
Yeah, that actually is a probably good question that would have been for Representative Schlossberg when he was here.
Well, we can ask him, I think.
He will be able to tell you who are the most favorable and who are the most opposed.
Yep, that would be, and so I think maybe that's something we could think about and look into. Okay. One thing that I wanted to comment on, just as a general thought in this presentation that we had obviously we had Dale, who's coming from the executive. We had Kurt, and I'm going to Carl Feldman and Scott, who are also in the executive, all within DHS. And then we had who was else on our Alan from DDAP. So we had legislature and executive with Mike Schlossberg here. So we're sort of talking about the role of government in mental health, right? In this particular thing, the only branch we didn't hit was the judiciary. So I wanted to sort of, I would almost take an argument with, it's not really an argument with Representative Schlossberg when he said that this is sort of beyond and extends beyond government, because I'm not sure that we are fully recognizing the role that government plays in structuring what our health services look like. And not only that, what our capacity to support people in communities looks like. So income maintenance is obviously not about health service, although it's about with Medicaid, about financing it for people. So the notion that government isn't intimately involved in sort of the industry that we run and are involved in is obviously not true. Government drives what we do. We are, for all intents and purposes, we are agents of the government. That's what we do. So I guess a question that I have is the sense, do you think that government, when Mike said that, when Representative Schlossberg said that, was he in some ways trying to take away the role of government from structuring these health services and to sort of deny the role, or was he just trying to decrease our expectations? Kathy. And then I saw you, Gordon.
Just briefly, the Appropriations Committee hearing within the Senate is scheduled for April the 12th. And that's when the Senate will, the Appropriations Committee for the Department of Human Services within the Senate is scheduled for April 12th. And that's when that Appropriations Committee will kind of scour through and try and figure out what appropriate, because obviously it's a big increase for human services. It always is. We have more people there that are signed up and on Medicaid and Medicare, but Medicaid being the specific interest. So there's going to be more money poured in there. And then each year they ask, well, how comes you needed a supplemental appropriation? Well, it's because you underallocated to us last year. Go figure. We asked for a number of billion and you gave us less. So that's what's going to happen. But one of the most effective ways of impacting things that happen in Appropriations Committee hearings is to go to the minority party, find out if your senator is on the Appropriations Committee as a minority party, the Democratic Party, or finding a way to contact a Democratic representative, a Democratic senator who was on the Appropriations Committee, and give them some questions to ask, because they're happy to do that. They just may not have the questions. So if you know someone, and I was just kind of writing down some names, Scott Kearney is the minority chair of the Democrats on the Appropriations Committee in the Senate. Art Haywood, Vince Hughes, and Nick Miller are also Democrat senators who are on the Appropriations Committee. So if those are your senators, or if you can get to your senator and let them know that you're very, very concerned, that Appropriations Committee hearing is happening in, what, a couple of weeks? And that's where the basis gets laid and the roadmap then gets set forward as the rest of this season is turned toward budget negotiations within the House, Senate, and eventually to the governor's desk.
But it would also be important to look at those that are in the majority in the Senate too, because if they're part of the barrier, we need to help them loosen that barrier to this process in a very kind and relational way.
That's exactly right. That would be a good thing to do. What you tend to see happening is when there's a party position taken, most kind of adhere to the party position. And having been a public official, I know that an uncomfortable public official is probably a better public official. So if there are ways to get folks who are on the majority side to think twice about their positioning of their party stance, because we know what that party stance is going to be, and it's not going to be toward dispersing those funds immediately. So we need to find a way to get those folks to feel a little more uncomfortable and a little more likely to come forth with possible compromise. And that's what we're looking for here, compromise. Not draconian rule either way, but we're looking for compromise. And that can happen if you can urge your senators, majority party or minority party, but to ask difficult questions during those hearings. It can make a difference.
So we had Kathy and Gordon. Gordon first, Kathy, either way you want to do this.
I was also thinking about
Close to your mouth.
thank you. I was also thinking about the point, Ken, that you picked up on about the limitation of government. And, you know, I think there's a distinction to be made between that which might be strategic in terms of advocacy and that which is conceptual. Conceptually, I think public policy in general impacts the well-being and the mental health of people and the social determinants of health. And there are many, many, many opportunities to expand that set of interventions, including education, for example, that is on the table for other education that's on the table for other reasons, the recent court finding, that would definitely impact the well-being and mental health of individuals. So it seems to me that conceptually, public policy well beyond the funding of mental health services is relevant here. As far as what one goes for and what one asks for at a particular time, that's a different issue.
And that I think in there lies the rub. That's where we have to try to figure out where we are at the moment historically for what we can do.
My comment was along the same lines, but I was thinking that Representative Schlossberg was suggesting that some of the root causes to some of the increased problems are not necessarily caused by government. So for instance, a lot of the declines in adolescent mental health, there are social forces around social capital, around media, et cetera, that have had obvious impacts there. But I would agree that those foundations, the foundations of mental health are very affected by supports across the whole range, of body, income, mind, all those health supports when people get into trouble.
What's on? You just have to hold it closer to your mouth. Who knew? So I think this is kind of a theme in what we are experiencing and what we've been doing in our conference and in this meeting. and that the PPLC sort of exists around already, but it was not where we started in its focus. And that is the role of government and public and human services in general and public policy overall is extraordinarily important to mental health and well-being. And the role that psychiatry plays in that has been, I think, for some period of time, a bit circumscribed. We have really tended to try to focus on this issue of mental health services and increasingly smaller and smaller pieces of the mental health services. What I'm taking out of this is that engagement with government and public policy is really essential to our work. And that we need to be, when we say that, it isn't just a theoretical thing or purely a conceptual thing. It is, in fact, the work of day-to-day getting to know people and having conversations and knowing who your representative is and actually going to meet with them or being involved in various levels of government as a citizen, so that civic society and the work that we do intermixes with the folks who are making some of these very important decisions about how money is spent. And I don't know that that was a message that was conveyed to me when I was earlier on in my career. I did not go do my fellowships, which I did a number of actually, and have anybody say, you know, you really should go meet your rep. You should go just meet your rep. Take a bunch of you and go meet your rep. Go talk about what the issues are that you see in the society that you're, and in the patients in the community you're working in. Go talk to them. Just do it because that's what you do as a civic society member and a professional. And that's a message I think is really coming kind of clear. Maybe that's because we're in a moment of government activism at some level, but it is something that I'm carrying forward here, and I really look forward to further discussions. The young woman who asked, "How do I start?" I think that was really a really important question, and Lloyd, I think you gave an answer, but I think we need to help support that answer over time and figure out how to make every element of that work as best it can for the work of providing good input to public policy and to services.
And so as I think about that, I think about the efforts of Vote ER, I think it's called, and getting the vote of folks that are not going to be heard for their physical or mental health reasons, being hospitalized, and having them be able to vote. I think it really goes back in the pipeline. So if I think about pipeline issues, what do we teach our children about the role of voting and your voice in democracy? And I think we've had this assumption that somebody's going to look after us or take care of it, the somebodies in this legislative process, and that we don't have any say in it. And so I really am resonating back to the comments that Lloyd made early on this morning and included Stan in that, you know, being out there and being voices, but we need to hear voices from everybody. So, which is what's really been very neat in this organization, because we have voices across the system of our community. So we have folks that are running organizations and programs. We have frontline staff, whether that's social work or psychiatry or nursing, and peer support. We have folks that have lived experience, and we have family members, and we can't lose those voices. We have to expand them, because this is an area of which we have had to and continue to fight stigma. It is part of our whole health care. And it's a place where those voices have been really not heard. So how to continue to educate families and to be partners together in this, because when we stay in our silos, our voices are less heard as well.
Yeah, I was, thanks for bringing that up, Marianne. I was thinking about, so it sounds like there's work to be done on the parts of us as providers in connecting with, building relationship with legislators, and government officials, but I also was thinking back to some of the points that Wes made last night at dinner and connects into the vote ER drives is, you know, how do we, or what is the role of the PPLC or us in getting the message out to citizens of Pennsylvania about what are the sort of the important issues that they should be looking for, that they should be educating themselves about in voting. You mentioned Vote ER. So at Pennsylvania Psychiatric Institute, we have another faculty member who has had a running project with Vote ER, doing voter support activities and registration for psychiatric inpatients leading up to elections. And we are looking at expanding that to our outpatient services as well, because there are a lot of barriers to people with mental illness voting, and their voices are really, really critical and important. But I'm just wondering, you know, sort of what is our role in helping perhaps the average voter or citizen be more informed about how government and the legislators they choose create the conditions that they live in, create their influence their access to mental health services, shape the social determinants in which their kids grow up and in which they grow old. And I think there's some ways in which Republicans have been really a lot more effective in their messaging and their buzzwords. And I'm not going to pretend that I have any sort of expertise in marketing or anything like that, but I guess we need to get better at this stuff in some ways, in getting the stories out and helping people understand why these issues are important.
We are at time.
Yes, we are.
So I think we are moving on to the next phase, which is
Centers.
the Centers of Excellence and their updates. So I'm going to step down. Are we going to have folks come up who are here and occupy the panel?
Sounds good.
Sound good?
Yep. Sure. Oh, you took my paper.
Oh,
Don't,
it's
don't,
yours.
it's mine.
Mine's over there.
Oh, no, yours is,
Oh,
which one is, yeah. I'm trying to,
That was
those are yours. Okay. We got it sorted out. So, we are gonna move right into the Centers of Excellence in Public Service Psychiatry with updates and sharing of experiences. We are gonna have UPMC with Wes Sowers and Sarah Lim and some of the fellows, I think. We're gonna have the UPMC Rural Community Psychiatry Fellowship group, and that's with myself. And we'll have two fellows that'll share. And we have Rachel Talley, who's going to be on Zoom, I hope, with her UPenn program and her fellows. And we have Allison joining us to share about the Penn State Hershey excitement. Wes?
Fabulous. So are we going to have our fellows kind of go with our center or at the end?
Yeah, we didn't decide.
We didn't decide. Why don't we, shall we do that at the end?
Yeah, why don't we run through ours and let them. then
Sounds good.
theirs.
So anyway, just want to give a little bit of a report of what we've been up to at the Center for Public Service Psychiatry and our fellowship. And joining me is Sarah, who you met a little bit earlier, who is our newest associate director. And so it's been great to have her with us this year. Julia Macedo, our other associate director, wasn't able to join us today, but they are both busy filling the shoes of Bob Marin, who retired about a year ago, a little more than a year ago, and are really doing a great job with that. We have 3 fellows this year. 2 of them were not able to join us today. And, you know, one of our areas of emphasis is family and the importance of family. And family responsibilities have kept them from joining us. But Eric Zimmerman is one of our fellows this year. He, unfortunately, we are going to lose to Chicago next year. But Claire Becker is one of our other fellows who's going to be staying in Pennsylvania, working with an ACT team at UPMC. And so we're glad that she's staying. And Madeline, who's with us today, and we'll hear from in a little bit, is our first hybrid geriatric fellow. We've had several child fellows join us in the past, but we hope that Madeline will set a great precedent. And Madeline's looking to stay in Pennsylvania also. And so we're really happy to have her with us this year. I think we've had a good year in terms of kind of transitioning our Community Psychiatry Forum, our video seminar series, to the PPLC. And we have, again, about 20 sessions this year that we've kind of distributed leadership among the centers of excellence. And that's been going very well. And our actual participation, I think, has been up pretty significantly this year. We usually have between 20 and 25, I think, participants in the sessions. And as I said, they've been all very stimulating and successful, I think. Likewise, we have kind of transitioned the annual conference that we've done to the PPLC. And this past fall, we had a meeting, a conference on the mental health crisis that was really successful and had good participation. We are recruiting for next year, and looks like we have 2 fellows. There were 2 other fellows, potential fellows, who decided to defer until next year, at least possibly for next year, once they're actually working in the community. The other thing that is sort of on the horizon, and I think has been mentioned earlier, is we are working right now to develop a proposal to DDAP to help fund a sort of specified position for a fellow that is committed to working in addictions. And so we hope to kind of work perhaps to develop hybrids with existing addiction psychiatry programs to kind of enhance their curriculum, and also to recruit others who are interested in leadership positions in the addiction community, treatment community. So we, in the course of that, we're hoping to sort of enhance the emphasis on addiction in all the fellowship programs in the state, and have a continued partnership with DDAP around that. So that's mostly the news that I have. I don't know if Sarah has anything that she would like to add.
Thanks, Wes. I think one thing we are hoping to improve is earlier engagement with our residency program. We have a great body of residents here, and we just got our new matches, and very exciting to see the community that we have over in Pittsburgh. So we would like to work with the program to make particularly our noon sessions in community psychiatry training available for some of those residents who might not be able to commit to the full fellowship, but may be able to come in and catch a few courses and maybe get some lunch. So I think that's one of the things we're hoping to do is start with visibility of community psychiatry earlier on in training. So that's one thing we're hoping to, I think, get off the ground myself personally in the next year.
Okay, thank you.
So I have the pleasure to work with the rural component of the UPMC Community Psychiatry Fellowship, following in the very large shoes of Penny Chapman. So those of you that know Dr. Chapman, she had been really very instrumental in developing this. And I have been able to partner with her and now take that on for the last couple of years. We have just a recent new graduate, Danielle Cavallari, who's a nurse practitioner at Community Health Net in Erie, an FQHC program. And you'll hear her talk a little bit, as well as our current fellow, and that's Angela Weeks, who's a physician assistant at the UPMC Safe Harbor Community Mental Health Center. What's unique about our program right now, being rural, we've really expanded to look at multiple partners for the fellowship application and participation, originally starting with residents who are entering the workforce as fourth-year psychiatry residents, and then attending newly minted attending psychiatrists with interest in community psychiatry, interested in leadership development and mentoring. And we've had that opportunity. And then in recent years with Dr. Chapman's leadership, we've included nurse practitioners and physician assistants. They are partners in our teams, and with their interest in community psychiatry, they round out our team. And so being able to support and train and help them in their abilities and skills to be effective in community settings. So it's been a real privilege in that regard. We are looking at developing a more robust opportunity for elective time with residents. And given that we are rural and have a broad geography, we're going to be looking at the ongoing partnering with Mill Creek Community Hospital's LECOM program. And we do have a resident right now that's doing a community psychiatry elective, and looking at partnering as well with a relatively new program with Dr. Gongoer with Penn Highlands Du Bois program. So thinking about electives in their third and fourth year when elective time is more robust and available to the residents, and again, how to get that message out for community psychiatry. I think that I'm going to stop there, and we do want to hear from the fellows, so I'm going to pass this along. And I think, Rachel, I'm going to pass it to you. Tag, you're it.
I am here, and I will keep it brief because I definitely want us to leave plenty of time to hear from the fellows too. First, I apologize that I could not join in person today, but I'm Rachel Talley. I'm the director of the Fellowship in Community Psychiatry at the University of Pennsylvania in Philadelphia. And in terms of updates for our fellowship, I think the main update to share for this year is that this has been a time when we've continued to sort of look towards expansion in terms of partnering with new agencies in the community. Philadelphia, of course, has a wide and large array of community mental health organizations. And so my hope has been that our fellowship, as with the other fellowships, can sort of be an engine of seeding talented psychiatrists in community agencies across the city. And so this year, our three fellows who are all on the Zoom call today, Drs. Andy Hagrogian, Dr. Mira Chatterjee, and Dr. Hefsiba Loeb, were all at sites that were basically new partners for the fellowship this year. One is the Consortium in Philadelphia. One is the Philadelphia Department of Health Ambulatory Health Service, which is basically the primary care clinics, public primary care clinics in the city of Philadelphia, where Mira Chatterjee served as their first collaborative care psychiatrist, as well as Hall Mercer, which is the University of Pennsylvania's community mental health organization. I'd like to flag that Hefsi Loeb is our first ever child-trained community fellow, and so it's extremely exciting to have that aspect to our program as well, and certainly something I continue to hope to have in recruiting is folks who have specialty training in addition to adult psychiatry training coming into our fellowship. And so our fellowship now partners with 6 community agencies, these 3 as well as our original partner, Horizon House, Comar Inc., as well as Pathways to Housing PA. And I think our other main update for this year is that this year we had basically a new associate director join the leadership of the fellowship. She unfortunately could not attend today because she is on maternity leave. She welcomed her first child, a beautiful daughter, a month or so ago. That's Dr. Ashley Unn. But we now have a 2-person leadership team, which I certainly hope will help to continue in terms of expansion for our program. So I think I will leave it there and pass it over to Allison.
All right, thank you, Rachel. So I'll round things out here before we hear from current and past fellows. So I'm the director of the Community Psychiatry residency or training program at Penn State. So we were originally set up as a postgraduate fellowship training program for a variety of reasons. That position has been very hard to fill or recruit for in the Harrisburg-Hershey area. So we have spent the last year retooling and redeveloping our program and creating a community psychiatry resident track within the Penn State General Psychiatry Residency Program. And I think as someone who's pretty involved with medical student teaching and also doing a lot of interviews for psychiatry residency, I think this will allow us to really capitalize on many young people who are going into medicine who really are already very social justice oriented, equity and diversity minded, and hopefully capture those individuals early on in their training. So we will be starting our community psychiatry resident track this coming July. We did match someone into the position, so we're very excited about that. And this will add another psychiatrist who's being trained at Penn State each year. So it brings our cohort of residents from 5 to 6. And we will be planning to recruit someone into that position each year moving forward. So we're very excited to be moving forward with that. The resident will get, we'll build on the already great structure of the psychiatry residency, but with additional didactic teaching in community psychiatry mentorship, and then more immersive clinical experiences, particularly in the PGY 3 and 4 years. So we also have been working on developing partnerships within the community. So one of the challenges is that training psychiatry residents is a little bit of a different funding model than training psychiatrists who are in a PGY 5 position, who've already graduated from residency and can bill independently. So we've been working on developing partnerships with local organizations and counties. So we have just entered into a partnership for grant funding through Cumberland County, which is the county just to our west here in Harrisburg, to help support this community psychiatry resident track, and will also result in more resident time being placed in Cumberland County, which will help hopefully both in the short and the long term alleviate some of the workforce shortages there. And we're also in the stages of developing a relationship with CABHC, the Capital Area Behavioral Health Collaborative, which is a nonprofit organization that's tasked with handling the behavioral health choices contract for medical assistance for the 5-county area, which includes Dauphin, Cumberland, Lancaster, Lebanon, and Perry. So we're looking forward to kind of growing, having our residents train in a sort of broader array of sites around this region, and moving forward with that. So I will stop there, and we will hear from our fellows.
Wes, do you want to share your?
Should we start with our in-person fellow, and then we'll move to our people joining us virtually? Yeah, why don't you come up here so people be able to see you?
Hi, everybody. I don't know entirely what everyone wants to hear from me, so I'm also happy if there's like a question, but I guess I could take my mask off for a second. you heard before. So I am a fellow at the UPMC program. My like main appointment though is as a geriatric psychiatry fellow. And so in terms of like the funding and how it allows me to do that, and then having a little more flexibility since I am still in a trainee position within the organization to combine those. I am new to Pennsylvania, and my residency was a public community oriented residency. So I already had done a lot of community training, and I think this is maybe something that I was like, there's probably some amount of self-selection into who is participating in our fellowships right now. I've never considered really working in anything other than community psychiatry. And one of my goals with the fellowship was to understand better some of the like structural components of working in public systems at different levels, particularly too, and knowing that I'd be new to the area, learning more about the kind of organic networks that exist in Western Pennsylvania. And so it has in fact been helpful for that. What else should I contribute to this? Anything?
Just your interest, maybe.
Oh, sorry. Yes. Yeah. What am I doing? So my like hopes and dreams longer term is so my interest in geriatrics is largely, it's partly in aging, but also in psychiatry's role in medical disability justice work, which is kind of been limited. And so working with people who have other chronic illnesses and chronic physical disability and mental health disability kind of combined. I think geriatrics is an interesting place to think about that in terms of the networks that are needed. And I would like to have some type of integrated team that does street-based psychiatry and in-home and in-community psychiatry. So what I'm currently looking at now for what I'm going to be doing next year is I will be doing some amount of street medicine, street psychiatry. It's just sort of unclear where at this point, and like in combination with what other work. So that is where I am going.
Thank you.
So I'm going to introduce two fellows that we have. One is a recent graduate, and the other is the active fellow. We have the opportunity to partner with a number of providers in our large geographic area in northwestern Pennsylvania. Today, we're going to highlight the fellow that has come from the Community Health Net FQHC, and she'll share a little bit about her experience and the project she worked on. And the other fellow is from the Safe Harbor UPMC program. Historically, we've worked with folks at Stairways. We've worked at partnering with Deerfield and Journey. So it's been an exciting process over time. Danielle, tag, you're it.
Okay, so my name is Danielle Cavallari. I work at Community Health Net in Erie. I am a nurse practitioner. So mainly, I see primary care patients. Just recently, Community Health Net got a nice program going for a behavioral health program because we have such a need for it in Erie. As Angela can probably tell you, there's a lot of people that need, mental health, and there's just not enough providers in Erie. So although, I'm a nurse practitioner, we're working with the therapists, counselors, and the other nurse practitioners in Community Health Net to kind of get more patients in to be seen for their mental health and not just their physical health. So what specifically I'm working on or have been working on is basically a postpartum program for mental health, or perinatal program really, for a lot of these moms. in the Erie community, which has been quite difficult, just because, I mean, with, as people know, when you work in mental health, unfortunately, the upkeep of appointments can be quite difficult. So that's been one of the barriers like we've had to really get this program up and running. We've made a lot of good connections with the help of Dr. Albog and just within the Erie community. There's good programs there like the Erie City Moms, which runs a program for, moms to come in, they get a wonderful meal. You can, have your child go to daycare and there is diapers, clothes, anything you need there, and just some time like for themselves. So we've partnered with them, we partner with the Erie High School who has teen moms. So I actually have two teen moms that I'm seeing right now. If they don't necessarily see me, they'll at least be connected with our case manager who connects them with their case manager, to make sure that, these moms, whether they, like I said, they physically see me, just to make sure that there's nothing that they need from us, or just to get them connected with somebody like the Erie City Moms. And then we've also connected with Emma's Footprints, which is an organization that helps with quite a bit, but one of the things that it was started for was, pregnancy and infant loss. So, although it's been a, slow process, as Dr. Albog knows, having these patients in consistently, we really have hit a lot of people in Erie just to kind of, know about us and know what we do. And it's more than just, looking at the physical health and really trying to help, these moms and their children. So that's kind of the biggest thing that we are working on now.
Thanks very much, Danielle. And you and your team, I know will keep moving this forward. So we have her and she's staying in Pennsylvania. All right. And Angela, go ahead and share your efforts currently and go for it.
Hi, everyone. My name is Angela Weeks. I'm a psychiatric physician assistant in Erie, PA, working at UPMC Safe Harbor Behavioral Health. I mainly see adults, some adolescents as well, outpatient, and I work at the crisis residential unit as well about once a month. Dr. Alba has been a great resource. I learn something new every time I talk with her, and this fellowship has really been a great educational journey. My focus right now is a burnout reduction project. So with the shortage of mental health clinicians and with seeing such a high turnover rate even at Safe Harbor, I thought this would be a very pertinent project to do right now. And I've been lucky enough to connect with Dr. Ken Thompson. So I'll be utilizing integrative community therapy as the burnout reduction strategy. That'll be twice a month for 3 months, and we'll measure the Maslow burnout inventory before and after. I've learned the fun of proposing new research and how long that actually takes, even with a fairly simple project. So it's not up and running yet, but I hope that I'll have some results soon to update you guys with.
Thanks so much. And I think, Rachel, you want to introduce your folks?
Sure. So I'm happy to have our 3 Penn Fellows share a little bit about their experience. I will say, let's start with Andy, since you're the first on my screen.
All right. My name's Andy. I'm one of the UPenn Fellows, trained at Temple in Philly, wanted to stay in Philly. So far this year, I've been working at a community mental health center doing general adult outpatient work, just sort of seeing whoever kind of walks through the doors. I feel like we're sort of a last line clinic for people who just can't get access to any sort of psychiatric care. And I also split my time between that and a methadone clinic. So very interested in hearing sort of the the DDAP changes and the policies coming that way. I would say, the benefits of the fellowship is you really get to dip your toes in the water of community psychiatry and see what it's like, just in terms of patient care, which I think we get some exposure to, but a lot more of the administrative side of things. That's not something you get a lot of in residency, and figuring out what you like, what you don't like, sort of, what mountains to die on, when to bang your head against the wall, when to stop. Also, built into our fellowship is we get to work with a lot of city officials, like the Department of Behavioral Health. And, I got to spend some time with the Behavioral Health Justice Division, which was trying to, work to get people who are incarcerated mental health treatment and maybe get them released, unincarcerated, get the backlog of people out of jails. So a lot of unique experiences that I did not, expect to have in my life, and I'm very grateful for. I would say, unfortunately, I'm not staying in Philadelphia. I'm moving to New Jersey, just because it's where I live now. So a little bit for commute reasons, but I will miss Philadelphia, and hopefully will return in some capacity someday.
All right, thank you, Andy. And maybe Mira, you can go next. Again, you're just the next person lined up on my screen.
Hi, everyone. I'm Mira. I currently work at the Philadelphia Department of Public Health. Their system of FQHCs, the ambulatory health centers, as their first collaborative care psychiatrist. The population I see is primarily patients who are undocumented or uninsured, who are really waiting on wait lists for a while to get into a community mental health center. I think it's been a really cool experience. I've learned a lot about, and I really like that you can work in a team. You have like primary care and internal medicine on board, which helps in some stressful situations with patients. But I've definitely learned about having to teach an institution that doesn't have psychiatry on staff, just certain things that I thought were really basic, like coverage, patients being able to access a physician very quickly, how to handle a transition year, since all the patients I have now won't have a psychiatrist next year. But it's been a great experience. I'll still be working in Philadelphia next year in some capacity. I don't know exactly what yet. And I think for the fellowship in general, when trying to recruit, one of the things that I found so helpful is having mentorship and having sort of like professional guardrails in that first year out of residency, that first year practicing as you're by yourself, how to be an employee, what it's like to do that when you're not a resident. And I think maybe in the recruiting efforts, highlighting that, because it's just been, I think, I'm so glad we've done the fellowship because of that. Thank you.
All right, and last but certainly not least, Hefsey, go ahead.
Hi, everyone. Great to be participating in this conference. I know some people because I was joining PPLC meetings for quite a while before doing the fellowship, and it really helped me to connect with people who have shared interests in it. When I was working during the pandemic, it really was a great source of camaraderie. So I'm very grateful to this group. I also did my training in Philadelphia at Jefferson. I did my adult residency and my child psychiatry fellowship, and I attended medical school at Temple. So currently this year I'm working at Paul Mercer Community Mental Health Center, which is at Pennsylvania Hospital at Penn, working with the family-based services team, which is an acute outpatient home-based service, and then also working with outpatients at home Mercer. And also we have some time, protected time, which has been a real highlight for me, working with community behavioral health, which is our Philadelphia Medicaid carve-out. So we've also met for supervision weekly with Dr. Shoyinka, which has been an incredible experience. And I've been able to pursue a project with the family peer supports through Philadelphia's Department of Behavioral Health, which is an area that I've had a strong interest in for for a long time, and it's been really exciting and something that I am hoping to continue doing into the future. So, and kind of like Mira was saying, the best part of the fellowship has been or for me, I think this is what you were talking about, Mira, the supervision with Dr. Talley for me has been, I think, I'm not sure that I would have been able to really make it doing this work without the weekly supervision, because community child mental health work is harder than I thought it was going to be. There's a lot of acuity, a lot of families who I think are not totally comfortable with kind of standard of care work that I learned about in fellowship and kind of memorized for my board exam. It's different. So I think navigating the gray areas, I know I wouldn't have been able to do it with Dr. Talley. So I also strongly think that the fellowship has been a real changer, a kind of game changer for my career, because I feel like I've developed some skills that I'm looking forward to using into the future. So I am going to be staying in Philadelphia, working in outpatient, I think, again, with a family-based team at a outpatient community mental health center here in Philadelphia, which I'm really excited about. And then again, hoping to continue some of the community engagement work with the family peer supports, which I think is just a really important kind of area for families who are kind of not maybe struggle with some of the aspects of outpatient services. Just, I think it's a real area for opportunity. So thank you so much.
Okay, so thank you all. This has been really, it's a rich effort from the group. I'm just really appreciative of it. And I want to store in my quotes or labels, I like the professional guardrails. I really enjoyed that image, and thank you, Mira. I'm going to borrow that. We are at 11:52, so we have 8 minutes I could gift to everybody for, no, okay. Ken, tell us what we're doing now. Okay. Microphone.
So I have two questions for the fellows. The first is there anything that you could say you would suggest we say or do to encourage more people to engage in this fellowship? What is the message that we need to be saying to people about why they should do this? That's the first question. The second question is, for those of you who are leaving Pennsylvania, what do we have to do to get you back? And you can all answer at once.
I mean, I'll jump in and say that for me, just to be totally honest, I don't think I would have realized the clinical challenges that came after I started my job. So for me, the real attractive aspect was the academic piece and the ability to develop a project. And yeah, that was something that really drew me in. So I think maybe, again, for me personally, highlighting that protected time to develop interests was a draw. Now, having done it, again, like I said, I could offer a whole lot of other reasons, but the me before, that was the draw.
Maybe it's a bit Spartan and like a little bit pragmatic, but to have a program where your interests are supported while also being financially supported better than other fellowships and having a nice lifestyle. I think these are all like selling points that should be hammered home.
I may put Angela on the spot because she's been my helpful recruiter. We have someone in the wings, but I think it was in part her doing.
Would say is just getting awareness out there about what it's like to do a fellowship. As an advanced practice provider, really the only fellowship opportunities out there for us before I started or learned about the Rural Community Psychiatry Fellowship were, 2-year long, 1-year long, unpaid or very low paid things that you kind of didn't have control over, and didn't necessarily get to select your interest in. But with the flexibility of this fellowship and how well it fits into my clinical schedule, how I'm supported to explore the interests that I have in this field, has been really great. And the best way I think to recruit people is just to assure them that, this is doable with your work schedule. You will get the time to explore your interests and you will be supported in this.
I have one additional question for the fellows, which sort of follows up on Ken's, because I think one of the challenges with the way psychiatry residency training is structured is that in most programs, your first 2 years are very acute services based. So, I mean, you have, for those who are have gone through psychiatry residency, there's 6 months of medicine and neurology in the first year. And then there's a lot of inpatient consult, largely hospital-based rotations. And so for me, I got through residency without really even knowing about the field of community psychiatry. And I think one of the struggles that we have is people get committed to other fields before maybe they even get to their outpatient training and learn about community psychiatry. So just curious if you guys have any thoughts about that, about how to sort of highlight this field earlier on, or what helped connect you to this field even kind of early in your training.
I went to Temple's residency and we had someone speak to us, I think the first and second year. So I think having efforts to have that done earlier in training, so it's like an option when people are going through the rest of their training and thinking about different specialties. And another thing to highlight, I think that really resonated with me was that there was some freedom in this, that like, it didn't mean you were locked into one subspecialty, that you could explore or learn about different ideas or different job options. One of the reasons I did this fellowship was I just didn't really know what I want to do and thought I'd be exposed to something cool and interesting, which I definitely have been. And I think there's probably a lot of people who know they don't want to do jury or forensics, but don't really know what the other options are other than being employed by their own academic hospital or starting a private practice. So for first and second years, just getting this in their mind and saying like, this is an alternate path forwards.
It takes it like 2 seconds to turn on. So I agree the earlier outreach is probably helpful. I think it's really exciting that there's a community track position at Penn State now. Like I said, I'm maybe in a slightly different position. So I went basically to the community track program of an academic institution. So was primarily in public settings, and all of my like non-hospital work was it's different than here, right? Because it's directly publicly operated. But so when I came here, for me, part of wanting to do the fellowship was actually knowing that I was going to be in a much more like straight up academic medical center and wanting to continue to have a connection to public psychiatry and learn more how to combine them. Because one thing I think I didn't really get out of residency is we theoretically are like a track within the bigger center, but really you just sort of functionally become public. And so what I'm trying to figure out here in Pennsylvania, it's really a different beast in terms. So I am originally from New York. I went to medical school in New York, and then I have lived in various places, but did my residency in California. And there is more directly publicly run programming in both of those locations. And so people are talking about sort of what the options seem to be. I think having the fellowship be a place that can actually more clearly explain what those options are, and hopefully like more regionally too, right? Because that has been just like very confusing for me. And looking for a job now too, figuring out how can I get hired to do the type of work I want to do in a system that is like primarily dominated really by UPMC in the region I'm in, right? So, yeah, this is rambling, but I guess I think the starting earlier, if there's any way to like track in earlier, and the other part that someone had mentioned is like the mentorship supervision. That was also something I was seeking, and I think, really encouraging and sharing the importance of that. I think if people haven't had it before too, they might not realize the value. I know in my residency, our supervision was somewhat like variable in terms of quality and commitment. And I had been really interested in it and got a really good supervisors. And then I had other people though who like kind of no one ever explained to them what supervision was, and they just never really did it. And that's sad to me because my supervisors and mentors were like really some of the most important parts of my training. And currently in the fellowship, it's like, I think maybe the single most valuable piece of it. And so some amount of also earlier explaining what mentorship means in a setting that isn't, this is going to be someone in your lab who lets you work in a lab. It's a different type of relationship.
Thank you. Marcia, you had your hand up, so we'll have one more comment and look to wrap up for lunch. But I do want to highlight the importance of protected time and mentoring, supervision, leadership opportunities. I think those are all things that if people hear that, they might be excited. Is it on?
Can you hear me now? Okay, great. So just to jump off on your last words, Dr. Albo, about protected time. Time in residency, I think, is such an important thing, especially in the first couple of years. And because that can be challenging, places like didactics, I know we do have a lot of educational opportunity and training on different, pathophysiologies and that didactic time. However, if we can take the moment to teach on public health and community psychiatry opportunities, maybe take half an hour or 20 minutes ever so often in didactics for residents all across. They can have an early pre-exposure. That's one idea. Another thought I had was, for me, when I think about psychiatry, I'm already thinking it's very integrated into, community health in so many ways. And so for me, I did a master's in public health, so I had an early interest in early exposure. But for those who may not have had that, having an opportunity to give residents exposure by having maybe some protected days, maybe giving them the choice to have a day or two to actually just rotate separate from an elective. It doesn't have to be a full-blown elective, but just having a couple of days or a day and having another resident cover. I know sometimes that can be hard, but I see something feasible to get exposure into that public community psychiatry early. I would do a couple of days outpatient. I know I'm not third or fourth year yet, but it provides that opportunity. And honestly, I have not heard much of a community psychiatry talk among my residents. So I feel like that could definitely be beneficial because I heard a lot from Dr. Albo and my seniors. So I just wanted to share that, just having a protected time and early exposure.
Thank you. I really appreciate all the comments this morning. This is a robust effort that has grown, and it's really neat to be a part of it. Ken, can we dismiss for lunch? Okay.
Now is it on? Very good. Okay. So how many of you attended the conference in the fall? So a good number of you. So, you know, at that meeting, we did a presentation on LOCUS, which is the level of care utilization system. And I did a kind of a brief review of the instrument. I'm going to give an even briefer review of it today, just to kind of refresh everybody's memory, or to kind of give people an idea of what the instrument is and what it does. But more than anything today, want to think about how LOCUS can help us in kind of addressing some of the mental health crises and some of the problems within the system, many of which we were talking about last night. But, you know, resources are an important piece of what we can and cannot do. And if we have ways of minimizing the number of resources that we use while maintaining high quality of care, we can extend what we do considerably, and we can make more resources available to go directly to care rather than in the garbage can of administration. Okay, so you know, part of the issue is that I don't know how to work this. Am I pointing it in the wrong direction? I'm pointing it this way. Can I get, maybe I could get you to do the slide 20. Maybe that would be easy. So if we can go to the second slide, you can just maybe do it right on the computer. So one of the issues is that we have not had any standard way to or process for making service intensity decisions and treatment planning. And so, you know, we can really benefit from a system that, you know, provides common language and allows communication and collaboration among stakeholders. We need ways that we can enhance quality improvement efforts, reduce some of the dysfunction and fragmentation of the system. And so a big piece is reducing administrative waste and maximizing value. So the next slide we can go to. In the past, you know, service intensity decisions have been pretty much in the hands of clinicians through the 80s. And what we eventually ended up with was a lot of inconsistency and discrimination in many cases, and rising costs and questionable quality. So that's how managed care organizations kind of came on the scene, and they developed medical necessity criteria to limit the number of services that were prescribed and to control costs. But, you know, obviously there are a number of issues related to medical necessity criteria, and I think we've all kind of struggled with them a little bit. You know, they're kind of complex and cumbersome. They're inflexible, difficult to access in many cases. They're focused on acuity of symptoms, and limited relationship to treatment planning, and basically have created adversarial relationships. I'm sorry, we can go ahead with the slides. I forgot to say so. We've got it working. And the next slide even. So yeah, basically we've had these adversarial relationships which have not been very helpful. So ideally a system, clinical systems should allow individualized person-centered planning. Next slide. Next. Oh, I'm too far ahead, I think. One more back. One more ahead. Well, anyway, basically there's a slide missing. But in any case, we want a system that can provide individualized planning, have standards that everybody can adhere to, that create efficiency in our systems, integrated management so that management of care and resources are in the same hands, and really driven by outcomes and a full continuum of services. So basically what the AACP did in the mid-90s was to begin to think about how we could do that and how we could create a tool that would reach these goals. So in the process, we developed a set of principles that the tool should be quantifiable and dynamic, dimensional ratings, that there should be non-diagnostic criteria, that the tool should be easy to understand, should be flexible, give reliable results, and be empowering and collaborative with service users. So the result in 1996 was LOCUS, that describes a pretty unique set of service intensities, which I'll say just a little bit about in a minute. There's the specific but simple criteria, computer-friendly, dimensional guidance for treatment planning, and helping us again to manage value. The next slide, CA LOCUS, or the child and adolescent version, followed in 2001. It was developed in conjunction with the American Academy for Child and Adolescent Psychiatry, and they later added also the EXI, or the Early Childhood Service Intensity Instrument, in 2009. But these are a family of tools who basically do the same kind of value management. So LOCUS, family of tools, they have 6 dimensions, 6 levels of resource intensity, each level characterized by 4 variables. It's integrated and independent of diagnosis, and provides efficient scoring for level of care determinations. So the next slide, the 6 dimensions are risk of harm, functional status, medical, psychiatric, and addiction comorbidity, recovery environment with 2 scales, one for stress and one for support, treatment and recovery history, and engagement and recovery status. And so these dimensions provide a fairly holistic assessment of people's needs and kind of address a lot of the social determinants that we talked about today. We can go on to the next slide. So the rating system for LOCUS is that there's a 5-point scale in each dimension. There's a criteria set for each numeric point on the scale. We select the highest rating in each dimension, which in at least one criteria is met. And if no criteria is exact, we select the closest fit. When uncertain, we choose higher ratings, and the dimensional scores are summed to get a composite score. And that is in part what determines the recommendation, but there's also independent criteria. So higher scores indicate a need for higher levels of care, and these conditions can sometimes override the composite score in making the recommendation. On the next slide, real quickly, there's 6 levels of care, and they kind of range from maintenance and health management for people who have graduated from services, all the way up to level 6, which is basically analogous to inpatient care. On the next slide, the levels are kind of unique in LOCUS in that they're really arranged in a way that allows us to build a plan around the person's need rather than fitting people into services that are predetermined and static. They're defined by care environment, clinical services, support services, and crisis and prevention services. And each level has a menu of services, of service elements. And these often overlap between levels, especially in areas of support and prevention. The cost is basically proportional to the level of care. So higher cost services are at the higher levels of care. And it really presents a fairly seamless continuum. So there's a number of advantages of LOCUS over traditional medical necessity criteria. Its simplicity, it creates a platform for clinical documentation and all aspects of clinical care. It's participatory and around person-centered and recovery-oriented care and empowering. It's a unique service continuum that's very flexible and adaptable and easily translated into level of care recommendations. I think one of the big things too is it removes a lot of the bias and subjectivity of typical clinical interactions and how they may be. And so it helps reduce that bias and discrimination. There are a number of extended uses of LOCUS. And the next slide, particularly with regard to systems planning and identifying service deficits, can be used for monitoring outcomes and rate setting, and kind of simplifying and getting away from some of the fee-for-service structures that we have. So that's just a little bit of an overview of the instrument. On the next slide, basically, over the past 27 years now, we have gradually made some progress, and it was adopted in several states and Canadian provinces, but not really used up to its potential. And things changed quite a bit in 2018. And at that time, there was a court case in California, and it was Witt against United Behavioral Health. And the allegation was that the United Behavioral Health criteria were self-serving and overly restrictive. And so the finding in that case was that that was in fact the case, and that LOCUS family of tools, along with the ASAM criteria, were identified as the standards for service intensity decisions in psychiatry. And so that really kind of got a lot of things in motion, and they actually identified 8 principles for medical necessity criteria that were more or less borrowed from LOCUS. So that has made a big difference, and it's resulted in, we can go on to the next slide, a lot of attention on LOCUS, and Optum, or a division of United Behavioral Health, adopted LOCUS for its 40 million members. That was followed by passage of legislation in California that mandated LOCUS for all behavioral health entities. And Oregon and Illinois followed with similar legislation. There's about 6 other states who have that underway. And New York State also identified LOCUS as principles that should govern all behavioral health plans. So, we've been trying to get Pennsylvania to do something with this for about 25 years, with some starts and stops and little success. But, I think what we want to think about here really is why, this would benefit us in our mental health crisis. And so if we go ahead again, and another slide we can go to. So, for clinicians, we benefit in terms of efficiency. It facilitates collaboration in our therapeutic relationships. It provides a structure to kind of facilitate clinical interactions and helps with communication and reduces fragmentation in that regard. For payers, on the other hand, there's improved outcomes, reduces some of the adversarial nature of their relationship with providers. It helps with systems planning, can provide a platform for simplified financing and basically cost reduction by reducing the number of hours spent in utilization review. For service users, it provides opportunities for collaboration and participation in treatment planning, investment in those plans, and creates greater equity and reduction in discrimination and continuity and consistency in planning. And the public even benefits. You're so good. Because we get advanced value and improved public health, greater transparency around how decisions are made, and again, greater equity and access. So, all those benefits come from this. And I think, what we have been talking about this morning quite a bit is advocacy and how we make changes in the system. And, so what we would like to see is for Pennsylvania to join the other major states across the country. The AACP's vision is that this would be a standard across the industry, across the country. I think our focus might be across Pennsylvania and help Pennsylvania to join these other states. So, it really makes, when we talk about advocacy, it does make sense to have a focus. And, just kind of tying into some of the things that we were talking about this morning, much can be accomplished just by moving towards a system that provides this kind of continuity, eliminates some of the administrative waste that we experience at the moment. I think, much of the public is really disgusted with their treatment in the medical system and the denials that they may get for care from companies. And so it's an opportunity to tie into that public discontent. And so basically, what I was hoping to propose today is that the PPLC really adopt this as an advocacy priority, and that we can have significant impact in kind of carrying this forward. I think a big part of that is creating a strategy for doing that, and it may be around managed care organizations, mental health administration, and it may be even be legislation, which is what some of the things that we talked about. But we can also raise provider awareness and public awareness. And what we'd like to do is develop a work group that can work on those strategies. And I would just invite anybody who would be interested in working on that to contact me, and we can put our heads together and see what kind of strategies that we could come up with. I don't know if we have a minute for questions, if anybody has any.
I do. And I'll be quick. So this process has been going on for quite a while, sort of set a idealistic idea when managed care was harsher than it even is now, I would say. So I've seen managed care adopt or shift towards some of those principles for a variety of reasons, probably, maybe even including impact from this. How hard do we fight for this to be adopted versus assessing what, maybe a company is using that has moved in that direction and maybe has their own history with that, or, reason to have that version rather than this one?
I think we're relatively fortunate in Pennsylvania, and that, many of our managed care organizations are much more progressive than they are elsewhere, and they are tuned into public needs. And so that's a great thing, but it still doesn't reduce the kind of lack of transparency, the lack of accessibility to, what we're talking about here. Doesn't really reduce the administrative expense to the same extent. And it doesn't really put us all on the same page. And so, some of those issues around communication and, reduced fragmentation and some uniformity, we can't do that without having one standard, I think.
Wes, we have a question from the online community. If you'd
Go.
like to take it.
Sure.
This is coming from Mira. Thanks for this question, Mira. Does LOCUS have to be adopted on level, or can individual payers
I am not hearing that.
Oh, there's sound issues.
Well, we could, obviously, if managed care organizations chose to do this, and this is certainly one area that we might focus on, is to, I haven't had much luck with it so far, but I'm only me. And, so if the PPLC was behind this and really lobbied the managed care organizations, that would be one way to do this. And, we have a couple of very progressive organizations here in Pennsylvania. I think, as with everything else, change is hard and nobody wants to change, and there's always an excuse not to change. And so, there needs to be a little bit of a groundswell, I think, to get them to make these moves. But I think that is obviously one target that we can take in developing a strategy to make this happen in Pennsylvania.
And if there's a time when this would be more likely to work versus others, we now have a deputy secretary at OMSAS who came to us from DDAP and who forcibly implemented ASAM from her position at DDAP because she had to. It was required from the federal level, but she did it and she gets it. So if you're able to form a group of folks who are interested in advocating toward this, I think you have a better chance of success now than you've ever had in the past. And what a good time to put some effort in.
Well, and I think just to have a coalition, and that PPLC and other organizations can join around this will make a difference as well. And again, that's another area that we would probably want to target. If we had OMSAS on our side, that would be a great help.
They write the contract.
Yes. Okay. So, yeah, if you would like to participate in this, or if you know anybody who might like to, please contact me.
Number 4, welcome to board.
It's on, yeah. So I'm not exactly sure what a moderator is going to do with this group, because this group can certainly moderate itself. But I'm very, very happy to be here and talking about looking toward the future, a little bit of the past, but more toward the future regarding our racial justice subcommittee. I got to tell you, I'm going to drive home because I brought a vehicle here. But what I really am going to do is I'm going to fly home, because I've heard more about advocacy on the part of this group than I have ever heard at a meeting in the past. And that's a wonderful, wonderful gift that you can bring to the people that you see on a daily basis from your offices, if you're able to provide a little bit more attention to the option of being an advocate. I did bring the stigma buttons. They're on the back table there. Please feel free to take one or more if you would like to have them. And if you need a larger supply, let me know. I got that in the vehicle as well. But certainly glad we're here and certainly glad we have the panel here representing the discussion on the racial justice subcommittee that was created and working within the residency programs. And so I will turn to Mary Ann and to Ben and ask for that presentation.
Thanks. And what I'd like to do is welcome Crystal. And since Crystal, yay! We all got to introduce ourselves this morning. So Crystal, would you please do the honor of your introductions? Tell us a little bit about you. Thanks.
Okay, so can you hear me okay?
Yes.
Okay, because I'm sitting in an airport right now, so I wasn't sure. I'm Crystal Korenchak, and I am a family member with lived experience throughout many systems, basically, you know, mental health and through children and their adult years as well. I currently am the Family Policy and Engagement Consultant for the PA Statewide Systems of Care Grant. And anything you want to ask about anything, just go right ahead.
So I do want to know what your time frame is so that we can make sure that you get to present without missing a flight.
Good. No,
You're
I'm
good?
good. I just was worried about the background noise if you were going to pick any of it up.
Okay. So we have the great opportunity to co-chair the Racial Justice Initiative that has been just humming along. Lots of learning, lots of work since 2021. Actually, it started before that in terms of the planning. I think our first roundtable occurred in January of 2021, and we'll hear more about that. This effort really came out of the process that Ken had us meeting regularly through COVID on Thursday evenings. And at some point, I believe in May of 2020, we all experienced as a country the murder of George Floyd. And it caused us to pause and to think about, what are we doing as a group? How do we manage this? Do we talk about it? How do we think about how it impacts our work, our patients, our families, our communities? We are in public and community psychiatry. And so how do we get this conversation rolling? And what we did was we divided our time between COVID, which was front and center in our experience at this time, as well as this racial justice initiative, and brought a lot of, as I said, learning process, certainly for myself as an ally in this work, and making a determination that we couldn't just talk about it, but we needed action. And I'm to think about some things that I've learned with folks that I've been working with, intentional action. And so we worked together and developed 2 work groups. Crystal and I believe Rachel Talley helped to spear up the Training, Education, and Curriculum Committee, Subcommittee, and myself, Eileen Diaz, who I think is on the line still, I hope, and Leon Cushenberry were my collaborative co-chairs in our subgroup working on recruitment and retention. And so it really continued to move forward with what we would be doing, how would we tackle this, and looking at the data that is really embarrassing, challenging, speaks to the biases and the institutional challenges, challenges in pipeline, where you look at the numbers of African-American Black psychiatrists, which is, I think, 2.9% of the workforce, and they are at least upwards of 15% and greater in some communities, that they don't have the representation, that there's choke points, there's maybe no points in the pipeline, and how to look at that as our point area to intervene, but with the idea that we're going to make that broadly, looking at what are our lessons learned as we move along for all underrepresented in the field of psychiatry in particular, and even thinking about, as we've moved along, it's kind of expanded, thinking about workforce. And so I appreciate Sierra's communication in that, because it is similar in other areas of our health professions. So we started with those initiatives, and we moved toward thinking, how do we get our best information? How do we understand this problem from really the ground experience for those that are in this? And what we developed was a roundtable, and Leon Cushenberry and Rachel Talley and Dr. Sosamulu were extremely helpful in putting together, along with Eileen Diaz, a source of many questions that we wanted to look at, tackling areas of themes where we would pull together residents of color that have self-identified through each of the 13 programs, residency programs for psychiatry in the state of Pennsylvania. I should back up a minute. We really wanted to focus on Pennsylvania, and how do we increase our numbers? What can we do there? And so we really want to look at how do we partner with our psychiatric programs in residency training. And so we were able to send out letters with Dave Dinich's help, and made personal communication with a number of the program directors to get a list of folks that we could invite who were residents of color to a roundtable where there would be safe discussion, making sure that they could speak openly without being identified, without setting them up for undue troubles and bias. These are importance of a safe environment. And so learned a lot over the course of time around what it is, what does it mean to have a safe environment, to be working in, learning, and being able to talk about problems in a way that is safe and healthy so that you can make a difference. So we did have that roundtable, and we've learned a lot there in that data, which set us up for being able to then focus on themes that we could perhaps tackle and change into the future. And from there, what we learned as well in that roundtable is that group really felt heard and empowered in meeting together with like-minded folks across the state, whereas perhaps in a program, I'll use my Erie program, where there are 2 residents of color and not having access to necessarily other folks. And so that ability to have that mutuality, sharing of information, both things that are positive and progressive and helpful, as well as the barriers and the hurts and the microaggressions and managing that. They really welcomed and suggested that could they meet again. So that was another seed that was planted. And indeed, we are having them meet again. And we're going to be letting Sierra talk more about that experience in a little bit. So what came next was really pulling together the Learning Collaborative. And the Learning Collaborative has been a really energizing experience, certainly for me, learning lots and meeting the program directors from across the state. They have valued this time. It's a 1 hour a week. Excuse me, no, it's not 1 hour a week. Maybe it feels like 1 hour a week for us in planning. It is a 1 hour a month, not all months. So March was a buy. I think we've had some buys in December and August, just to allow for some decompression for their workload. Their work is, 12 months a year recruitment to their programs. And we wanted them to be thinking about how does diversity, equity, and inclusion get factored into their work, in their thinking. How are they recruiting? What are the things that are interfering with creating Pennsylvania programs to be really welcoming for residents of color and in their training and to stay afterwards. And so what we've got is 2 areas. Crystal helps with the co-chair for the training, curriculum, and education. I've been doing the recruitment and retention with Eileen and with Leon and the group. And we've actually over time merged those because there's some synergism, and rather than having too many more meetings, we've tried to keep it limited. We are excited that the program directors participate, and they've really opened up and felt more trusting of each other. And I'm going to let Dr. Gongaware share his thoughts about that. I think I'll stop for a moment, and I'm going to pass the torch to you, Crystal, so that you can talk specifically about training and the curriculum.
Yeah, so for me, it's been an interesting journey because much of this I had no knowledge of or real understanding. So I think for our group, I kept asking the questions. Why is it like this? So we initially started out we had 2 paths that we were looking at. So what about curriculum? And there was discussion around that. Well, it might have been 3 paths. And then there was, what about the training piece? What does that look like, and how that and the curriculum is tied together? So we started looking what existed out there at that time. And there wasn't a whole lot, but there was some things. And we were able to provide that information to the learning collaboratives when we had our first meeting. And there was some development happening in Pennsylvania. So Rachel Talley had been involved in some, and there was residents from UPMC from Pitt, and they shared with us what they had done. Internally, we were having a lot of discussion around, should all of this be woven into the curriculum? No matter where you were at in the curriculum, this kind of racial justice thinking was taking place, instead of it having been separate. And of course, our committee did think that that's what should happen. We did spend quite a few months initially putting together a resource list. And at that time, I think it was Marcia Richardson was heavily involved in our committee, and her and some of her interns put all this resources together and did a really nice job. So we hope that once we passed it on to the training directors, and it's now public on our site, we hope people take advantage of that. And I know I personally have had people outreach to me wanting to know if they could take a look at the resources to see if they, we had found things that they had, which I thought was kind of interesting. But at some point, we knew we were going to have to merge the groups because the work is overlapping, and we bounce back and forth between the 2 committee work. I mean, we're all working as one committee, but the 2 trains of thoughts will go from month to month because we still need to keep focused. And of course, our focus has actually looked at how do we tie residents to community groups, and how do we tie residents of color into other local community groups? And if not, how do we address that? How do we address different things? Like, how do we address also the need for people of color as faculty? So we're taking a much broader view and trying to figure out what we can build or help people build. Let me put it that way. It's not our job to build it, but how do we help people build something that will last and stay for Pennsylvania? As a family member, I can tell you, it's very important to me that this get done and done right, because it affects all of us. It affects from the time someone enters this mental health system and the family that's involved with them until they're no longer with us, either their families or themselves. And what you do and how you train impacts what happens to everybody in our state and our communities in the future. At least that's my perception, and I keep reminding them of that. So, Marianne, did I miss anything?
I think you have hit a lot of the high points, and I was just going to look at our technical team if we can make sure that the reading list is accessible to folks. Okay, I thought that's what you were doing. One of the things that I want to share is that really our effort is to have things be actionable at the various programs to really truly meet a goal of expanding the opportunities for residents of color in the state of Pennsylvania's psychiatric programs. And within that context, as we've learned with our centers of excellence in community psychiatry, staying in Pennsylvania, that we help with that and recognize that we're at sort of the final stages of that pipeline and that there's additional work ahead. We're trying to kind of stay in our lane right now to accomplish certain things and not get too distracted because the efforts can be much larger. So I know that we have in our learning process wanting to look at how do we influence high school students. But really, we know that it really comes earlier than that, that the planting of seeds in younger ages when children go to see their pediatrician or their family doc and they look like them, all of that expands the opportunities to say, I can do this and I can move in this direction. What you are speaking to in terms of community resources is so important. So it's another area to look at. How do we partner that allyship and resources to do this work? What I'd like to do.
Marianne,
Yep, go ahead.
just wanted to add real quick when I talk about the community work. There was a semi-plan developed, and then we realized we were putting out too much too soon, and that we didn't want to run the risk that people would just blow it off because we were asking a whole lot. So we do know it has to be in steps, it has to be concrete, and it has to be actionable. And so that's kind of slowed us down a little bit. That and I am the official timekeeper, and the meetings end relatively on time, by the way. Or we'd be having discussions Monday night till midnight.
That is true. We have a hard stop at 7 and Crystal keeps us to that. What I'd like to do is invite Ben to come up and talk a bit about his experience as one of the members of the Learning Collaborative and go from there.
Thank you, Marianne. My experience has been a good experience. I'm very glad I was invited to be part of the Learning Collaborative. I wasn't quite sure what to expect at first, but it's been a fun ride. I hope it continues for a long time. I'd like to just share my perspective as a program director. Like Dr. Thompson said earlier today, there's a gap in this field of psychiatry in terms of diversity. There's a real deficit. And the point of the Learning Collaborative is to try to do something about that, to try to fix it. So like Marianne said, we've been having meetings pretty much on a monthly basis. Sometimes it's bi-monthly, depending on what else is going on in residency world. But we've had very good turnout. We've had turnout from every residency program in the state, not just residency training program directors, but a lot of times assistant program directors. A lot of times residents themselves will participate, which is nice. And for the most part, people do a good job attending every meeting every time. We were able to use the meetings to target certain issues. We wanted to sort of have a theme for every meeting. Okay. And we were able to discuss in detail different strategies to try to help solve this problem. I can remember one of our early meetings was to discuss the possibility of a reading list, which I think had been completed prior to my participation. There was a meeting about curriculum as well. We've had meetings dedicated to resident involvement. I know we've discussed specifically resident recruitment. for underrepresented minorities. We've discussed faculty development or how to recruit minority faculty, which is very important to residents who would like that form of mentorship. So every meeting really had a theme, which was very helpful in terms of us generating productive ideas. And I want to say that we've enacted some of the ideas and strategies we've come up with. To my knowledge, most programs in Pennsylvania now are tracking the number of residency applications they receive for underrepresented minorities. Many programs were not doing that before. I know that most of us have gathered feedback from our residents. Many of our residents have been participating in the Black Caucus meetings that Sierra will be talking about more shortly. And we had a meeting about ways to increase equity in terms of our ranking. I think one of the themes that stuck out to me most and was a recurrent theme throughout all the meetings was the idea of a pipeline, a way to go out and to find people as young as high school aged people and try to encourage them to pursue a career in psychiatry. I can tell you, I've seen the data from the most recent match cycle. Most Black applicants match this year. Okay, that's great. The problem is there aren't enough of them. We need more Black applicants to help increase diversity. So pipeline programs, while they would be intensive, I think are the way to go. And we're going to have many more discussions about that moving forward. So, and I want to add, this is a very unique program. I have friends in graduate medical education in Texas, Ohio, Louisiana. Most states do not have a learning collaborative like this. I think it's very unique that I was able to meet every residency program director in the Commonwealth, urban and rural, and they're all available and they're all accessible, and people, generally speaking, are very helpful. So I'm very glad I got to participate. And I think in reality, when you have a group of people, when you have every training director in the state who will be training every psychiatrist in the state, that's a powerful force that can do a lot of good. So I look forward to participating for years to come.
So there's plenty of work to do. We meet on the third Wednesday at 3 p.m. There we go. Yeah, Monday night at 6, Wednesdays once a month at 3 p.m. and every Thursday at 6. Yes. Ken. Microphone.
This is actually going to be a little hard for me to say because I am so proud of the work that you guys have done. I literally, it makes me extremely humble to see how hard folks have worked and what this process has been. And I wanted to just make sure that I said that publicly, and I acknowledged the work that Crystal and Marianne and Leon and Rachel and who am I forgetting?
Eileen. Yep.
Eileen have been doing every Monday. Contribution of Lloyd and Val in this whole process has just been incredible. Sierra's participation, fantastic. It is the only program that we know of in the country doing this. We can't find anything quite like this anywhere else, which is why we're getting awards and recognition for even proposing it. Ben, what you're doing and your contributions, I think, are really standing out. I have to say, in my own biased way, I did not anticipate that there would be any folks of color in your new residency program. That's not true. That's in the middle of the woods in Pennsylvania. The part that some people, I think, unfortunately describe as being Pennsylvania, right? That part. So, so I wanted to acknowledge that. And I wanted to also say something that I think that was really driven home to me in conversations with Leon, with Rachel, with Sosamulo, Dave Dinich, that this work, as folks are noticing, you can't help but notice it because we live in the kind of society we live in. But the folks who've spoken so far, including myself, we're all white folks, right? We're doing this work because we know that while racism is a problem for Black America, it's actually not a problem of Black America. It's a problem of the white culture that we've all lived in and had some advantages from. So it is the work that we have to do to fight the racism that's been built into the systems that we have benefited from, to make the possibility for other folks, particularly Black folks, to have opportunities to do the kinds of things that we do to serve the people of the Commonwealth. So, so I think that's really important, that this is an effort that really does break down racial barriers and is focused on not leaving the victim as the person who has to find their way out without any support or help, but the folks who are actually part of the group that's been victimizing, to reverse what we've been doing and how we do what we do. And that power, I think, we really can move mountains. And I think we can get to a place where Pennsylvania really does, in psychiatry and other parts of the mental health system, that looks like the face of Pennsylvanians. And I look forward to that continuing to grow. And the work that you guys have done is the way we start. And it is really important. So thank you. That's I just wanted to say that. I'm sorry.
Well, I appreciate from just voicing for myself, but I hope for the rest of our work groups. And we've had lots of folks along the 2+ years of efforts in our work, in our learning and collaboration. So I thank you for those comments. I will say I was remiss earlier in stating that there's been a active coordination and collaboration as well with our Pennsylvania Psychiatric Society friends. So some of us wear multiple hats, and the Ken Sertas and other folks, Rich Silbert, who, pause for a moment, have been wonderful advocates for this work. And got that rolling. And I think now Larry Reel as well, who helped nurture all of us to this point in time. So lots of voices, lots of energy for this work, and we need to keep moving it forward. So I look forward to the collaboration. I don't know if there's any other questions or thoughts from folks.
Hi. Again, there are not enough 5 stars that can be given to this program. It's just, and all the work that you've done with this, it's just really tremendous. I want to also ask, without detracting at all from the wonderful work you're doing with psychiatric residencies, but if the goal is to provide providers of color across the mental health system, I just wonder how that work can be expanded to the nurse practitioners, to PAs, and of course, to therapists themselves. So I wonder if you've given that any thought.
So we probably have given it some thought and tried to stay in our lane as to keep it in a way that we can tackle it and be intentional so that we get some wins. What I would say is, in the collaboration between the Psychiatric Society and the Pennsylvania Psychiatric Leadership Council, we made 2 different yearly applications to the assembly of the APA's Best Practice Awards. In our first year, we were a little too young in our efforts and we didn't get anything, but it was okay. And I would say last year, when we resubmitted all the work that we did, it was awarded the best practice award for large district branches. So it is that, like, how do we get the word out? So there's word out. People are starting to look at, as Ben said, across the, our different areas of network. What are you doing? How are you doing this? And thinking about what they might do. What's the synergy in how we tackle this intentionally in the pipeline?
We have a question from one of our online participants, Aylin Diaz.
Thank you,
Hi,
Sarah.
Eileen.
Hi. So I wanted to add to the wonderful work we have done also. I think a lot of dissemination is within us. What we're doing right now with clinical psychiatry is great too, in which we're going to figure out how this could be disseminated at a greater level nationally through the news, through the clinical psychiatry news that we receive every day as psychiatrists as part of the APA. And also figuring out if this could be disseminated in the mental health services. So even like placing it out for conferences and so forth. So I think that's the other way we could be able to disseminate. So I just want to add to the contribution you made, Marianne.
And Eileen is our resident research writer. She helps us with how we go about doing that and put things out into that universe. And I think Ken has put in a workshop. Fingers crossed, we'll present.
So
you're good.
So I'm just listening to all of this, and I'm hearing sort of two themes. One is the theme of, can we recruit more Black psychiatrists or even people of color into the field? And the other theme is providing a safe space for the people who are entering the field. Are there other goals that I missed, or other pearls that you want to offer us from the work that you've been doing?
I think if we look at those two, and I'll open this up to Crystal and Eileen, Ben as well, in terms of thinking about an answer. When I think about safe environments, that is such an important area institutionally for where we all work. And so there, is there more to this? One hopes. I will share an example. One of our programs recognized that their boardroom, where they brought applicants in person, and of course everything's kind of switched to virtual for a time, but when they would bring people there for as applicants waiting to be interviewed, the room was filled with pictures of, pardon me, old white men. And so they really thought, well, yes, these are all important people in our history, but however, what's the message here, and how might that not be heard well or experienced? Just as one example, but really thinking about how we can make a difference in our places where we work and live, to allow for safe environments for people to learn and grow.
Yeah, Marianne, as well as how do you make the safe environment for faculty of color so that we retain them? That, that's a recruitment process as well. But, creating a safe space for just doesn't, we've been able to do that hopefully with the roundtable meetings that continue, that those residents of color have decided that that's what they want. But we also have to figure out, how do we create a safe space, given the institutional barriers, because it has to be a safe space for everybody. And that's not, and that's a tough nut to crack, because you're talking about institutional change. So it's part of our discussion. So it's just not a straightforward, we now have a safe space meeting. It's like, how do we create those safe spaces for everybody? Particularly faculty has been on our mind a lot, because, there's probably, there's not that many people of color in faculty. So recruiting that, we have to create institutional safe space. And that's going to look a little different and maybe a little bit more difficult to do. And then how do we make Pennsylvania a safe space for everybody who lives here? You know, hopefully you can transform. I think big, by the way.
And thinking about, you know, the learning about subtle and not so subtle minority tax that, you know, if we have faculty on board, and what are those expectations, written or unwritten? Are they valued in their contract monetarily? What are expectations? And do we all own this, as Ken was saying earlier? And I would say, yes, we do. And so what is it that we need to step forward with so that it's not just expected, sort of check the box, got the DEI. Stan, we want to hand that to.
In answer to Elizabeth's question, the other element that we're looking at, and I think Crystal was starting to get at this, is through the curriculum approach to have all residents, all psychiatrists be able to serve people of color.
Yes. Yep. To have those be welcoming environments. We know that there are major disparities in terms of the healthcare access and level of comfort to see someone for your healthcare. For
And
those of minorities.
Yeah, and thanks, Stan, for bringing that up. I know I've mentioned it a lot over time. I also just wanted to real quick, you know, Hepsi has also been part of the work, and I didn't know whether she had anything she wanted to add. She's been crucial, very crucial at the beginning of the work, and I know jumps in when she can.
Hi, Crystal, thanks for mentioning that. Yeah, I echo all that's been said. I think that, I mean, for me personally, it was meaningful to be involved with the work, and yeah, gratifying to see the program directors involved, and it's an incredibly important area. So thank you. I don't know that I have anything to add, just to echo how important it is, and that I think it really seems to have taken root.
And we did hear a suggestion from one of our younger members to create a pathway. Absolutely been considered at a couple levels. I tell you, doing that could be labor intensive. Trying to figure out how to do that, though, might not be. So hopefully being able to figure out ways, or at least suggested ways, to develop pathways from maybe middle school, certainly high school, to acquaint people of color and others about the fact that community psychiatry is a good place to be. And you need to consider that if you're considering a career in healthcare. So again, thank you. I would hope that you'll be involved with that going forward if we can start to figure out a way to make that happen. It also needs to be noted that he left a 5-month-old to come here to be with us today. Very impressive, very impressive.
So Lloyd, I'll let you take things forward so that we can have Sierra.
That's what the moderator does. I knew it was something. And the next portion of our agenda is directed toward the Black resident experience, which you heard a number of things about, and which was really kind of led off by one of our coworkers, our workforce director, appropriately so, and that's Sierra McNeil. And we have a couple of residents who are participating in that experience as well, who are with us, and one will join us today.
Yes.
Very good.
All right. So I do want to thank Marianne for giving a lot of the talking points in the beginning, because then now that we're running over time, I can talk a little bit more about how the group works, the purpose of the group, and then also allow time for Marcia. And I don't know if we have any residents on the call that would like to speak about their experience. And so I am the liaison. So what that is I am the person that the PPLC communicates when they want to speak to the Black residents group. So as Marianne mentioned in the beginning, we had our first meeting January of 2021. And so this was more of an information. So we went into this trying to understand better what is the experience of Black residents. And so I was a scribe for that. And so listening to a lot of the experience of Black residents, I've noticed that the experience of Black residents is also my experience as a Black social worker, and that this hierarchy or this invisible hierarchy that we see between psychiatrists and social workers is actually non-existent when we talk about how we are both Black professionals. And so some of the themes I do want to talk about that came up was there was a lot of, some residents spoke about the silence on social justice issues. So when George Floyd was murdered, a lot of residents wanted their hospitals to at least say something or do something. And there was a lot of silence from these hospitals, not really either knowing how to have these conversations or knowing what is the next steps when we want to address something like that. The lack of diversity within the programming and also their faculty members. And then also the experience of how it's very difficult to kind of build rapport with their supervisors. And so when you take all of these things into account, the biggest theme that we've heard through this is isolation. It is very isolated when you are a Black resident, when there are not many people that look like you that you can talk to. And so even though I think the intent of this was information gathering, I think we saw that this was an opportunity to continue this roundtable group. And so that's what the PPLC did. And so this group meets once a quarter for about an hour. It does not stay the same. I actually change it based off of the availability of the residents that are attending. And so usually I send out a doodle poll, they pick the date, and then that's the date that we move forward. This is Zoom. And the reason I think it's really great, and I hope Marsha will speak to this, is that because it's on Zoom, we're actually able to connect the Black residents that are across the state of Pennsylvania. So it's not just siloed to where they're currently at. The other incentive that I try and share with residents to get them to come to this group is that we give them a Grubhub certificate. I recently just learned that one of the residents had explained that she has been living on a diet of Skittles and Tic Tacs because that's how busy they are. And so I think this is a great incentive as when we talk about making sure, but I think this is a great incentive to have a hot meal to come to this group, but then also get to connect to other residents. And then the other part that I did want to mention as well is that we're looking at, before I say that, I just want to talk about how some of this stuff works. So because the communication does come to me through to the Black residents group, an example of what that looks like is that Dr. S and Dr. Talley had a great research opportunity for the residents to kind of get involved. And so I met with Dr. S and Dr. Talley. We had a conversation about what that would look like as far as the residents getting involved. And then I emailed the residents just letting them know that Dr. Talley or Dr. S will be in attendance for the first 5 minutes. And that's exactly what it was. They were attending for the first 5 minutes, explain the research opportunity, and then they left. We want this to be a therapeutic opportunity for the Black residents. And so that means we need to have as minimum involvement from the PPLC members. And so that's why the communication actually runs through me. We are also looking at future works. We do not want this to be a group, a work group for residents, because we also know about the token being a token. And so we don't want this to be a work group for the residents. But I do think, and I've been talking about to my supervisor, Val, about this, that this is actually an amazing opportunity for Black residents to really address some of the challenges and barriers that they're facing. And so I would love to talk to the residents about that. But again, not making this a work group, but more so having them organically come out of this group with how can we address some of these challenges and barriers. And now I'm going to hand it over to Marsha.
Hi, everybody. And I really appreciate being a part of PPLC and having Sierra really help coordinate and orchestrate all of this because Lord knows, our time sometimes is hard in residency. So you do so great with that. Thank you. And so with the experience for us, it does allow that safe space. So it is among us. We get to talk. We half the time we do vent about residency and the difficulties there. Sometimes we give ideas on how we function in psychiatry with consults. How do you handle consults? How can we do this different in our program? But the other part of it is because there's always so many things to do in residency, this has to be a deliberate interest. To be real, we have to have a deliberate interest in doing this, and we have to motivate others to have a deliberate interest in doing this. In the same way, we have to have deliberate actions to get things done, like here at PPLC. So for me, I've made it a deliberate interest to be a part of this group, which is important. And I know Lloyd was talking about gray hair. And genetically, at 16, I started graying. So thank God to box dyes. But I do appreciate my seniors who we do depend on advocacy for, and even our non-people of color, we do depend on our advocacy for. I really appreciate what Dr. Thompson shared as well, because through that voice, it could come down for us and really help us as minorities. I do like the pipeline idea. That's very important too. And another thing that Crystal shared, which I really liked, and I was actually going to bring up that point, is the boundaries of advocacy. Where does that go for us? Not only advocating for, as people of color, in psychiatry and medicine, advocating for patients and ourselves in the institution. Where does that boundary lies? How radical, or would it be considered radical with certain things that we may suggest or may want to feel like we can grow and continue to contribute? So I really do like the idea that it is agreeable, the idea that it is also an institutional thing. So that's all I had to share. Thank you.
Do we have any questions? Are there any residents online that would like to share? I don't know if there's any residents online. There's something in the chat. Is that a no? Okay. Thank you.
Actually, I'll actually ask a question if there's time. I guess I was in the work group. Thank you. Thanks for coming back. I was in the work group, as Crystal mentioned, and was really interested in the experiences that were reported in that initial roundtable in the PowerPoint. And I'm just wondering, you know, beyond the kind of idea of a supportive space, what other, you know, I wanted people to know about those things that were reported, because they were so upsetting to think that that's what people are experiencing. So I guess I'm sort of wondering, how are you sharing, how are you giving feedback to the programs about what needs to happen, what's happening? I know that, you know, part of the space is being very private, but I think that this is so important also to be communicated to the programs so that people know what people are experiencing.
So thank you. I brought Mary Ann up here to help with this question. But as far as for the Black resident group, one thing that we are looking at is how to utilize this Black residents group as a way to recruit people into Pennsylvania. So as Lloyd has mentioned earlier, that this is the sort of the only group that is working in this function. And so we have been looking at how to create in person. So we had talked very briefly about having the current residents that are involved in this group meeting with the newly matched residents as a way to, one, kind of start that relationship, but then also say like, hey, this is a great opportunity. This is kind of what the group has done for me, and see how we can kind of branch this group out. But I'm going to let Mary Ann answer the second part.
So Hepsi, thanks so much for that question, because it is part of our ongoing, how do we set the dialogue and support facilitation with the Learning Collaborative, and how does the Learning Collaborative grow? And I think you used the term plant roots, that it's rooted, and I do feel that it's rooted. And so our goal is to help support them in some of this conversation and thinking about what is our next topic? What are our next things that we want to wrestle with and work on and share? And I've been so impressed with how they've been sharing with each other very honestly around areas of wins, but also areas of difficulty. And so I pulled up some of the themes that were generated from that residents roundtable. Here's a couple. So residents are uncertain about the genuineness of their training program's attention to racism generally, acts of omission, such as microaggressions. So thinking about that as how do we help in the leadership, in the supervision, not only for residents, but for the staff that residents are working with in the various sites, and for faculty. How do we help with faculty that may be struggling with their own biases, recognized or not recognized? Concerns of minority tax of Black residents relating to their own well-being within the program, acts of commission, tokenism doesn't equal diversity. I'm hearing Leon's voice in my head at the moment because he's been a wonderful teacher for us. And the theme of invisibility, and I think that you talked about isolation, like not seen, that it's not seen, it's not talked about. And then systemic racism and discrimination, and forming communities through mentorship, sponsorship, and allyship. So those are some of the themes that were presented at the roundtable. It's not exhaustive, but areas that we've been looking at, and that led to a call to action around recruitment and retention, as well as what we're doing in training and curriculum. Thoughts, Pepsi?
No, I mean, I appreciate you bringing those up. I think it's like, I think was kind of said on some level, you know, everyone is responsible for creating a welcoming environment of curiosity, of growth. And so, you know, I think it's important to convey those areas for improvement. Even though I know one of these themes we've talked about is that it's not necessarily the responsibility of the Black residents to tell other people what they should do. But I think that without knowing, you know, we can do our best to, you know, I think it's helpful to know. To me, reading that really was eye-opening in terms of hearing kind of the first person experiences. So I guess there's sort of a balance between, you know, reflecting and communicating. I don't know, I guess that's one of the challenges, is that the confidentiality is very important, but yet, you know, I always would say this, I would want to know if it were my program, what was happening, what were people's experiences. So I think that was a very, if nothing else comes, that was a very important kind of, you know, product that came from the first roundtable.
And I think one of the important things that we've been wrestling with, and the Annapolis group has pressed us for this as well as ourselves pressing, and that is, how do we measure success? How do we measure reaching goals? And I think about this as it really is a dynamic process. If you think that you've got it now, you can't rest, because it's a work in progress always. And paying attention to that intentionality of our relationships and communication, and what are the messages that are being sent overtly, covertly, and how are we managing those? So getting back to how do we measure success, thinking about, yes, in numbers, but also in the environment. So getting back to Kathy and Elizabeth's questions, thinking about safe environment. How does one look at that kind of progress in institutions? Because I would say that's a value, and that would be a successful piece of this work. So numbers matter, but they're not the only way to measure this. Okay.
Do you want to say a word just about the fellowship?
Yeah. You can say a word, and I was gonna. So there is, I don't know whether I have it pulled up. No, I don't have it pulled up here now because I changed it. So we did want to think about, again, how do we keep our activity moving forward. And there has been potential opportunity that I think feels like one of our future considerations, and it has to do with the American Psychiatric Association Foundation's fellowships and SAMHSA fellowships. And there's a number of them, but one in particular is their Public Psychiatry Fellowship. And there may be some opportunities for perhaps some of the centers of excellence or members of the Pennsylvania Psychiatric Leadership Council's institutions to perhaps in the future be partners with that fellowship activity that residents can apply for each year across the nation. But in particular, with a focus on public psychiatry, I think that our team is really positioned to be able to do some of that boots on the ground experiential process that might be incorporated into that fellowship in particular, but perhaps some of the others as well, because they talk about a community diversity fellowship, and there's a couple others in there as well.
The other possible pathway that we might take is something that I'm really kind of keen on. We talk and have had obviously nursing involvement. We've had social work involvement. We have really struggled to have psychologists involved with the Pennsylvania Psychiatric Leadership Council. That reflects a certain tension that exists between psychiatry and psychology right now, partly related to the issues around the pursuit of prescription capacity by some of the psychologists, so that the associations are struggling with each other. We know, however, that in public service, we need all hands on deck. We do want to make sure if people are going to be doing things like writing medications, that they are eminently qualified for that. So it's not just something that we are, I think, not going to discuss. However, that's a process over here. Process on the side of what we're talking about right now is to look for a way to participate, if we can, with the American Psychological Association's fellowships in diversity and public service. And we've actually had a meeting with Arthur Evans. We're fortunately well placed to have a conversation with Arthur, who's now, it's been 6 years since he left and went to the APA. And some of his folks from the APA, and they are very interested in trying to figure out how psychology and psychologists might be better integrated into the work and efforts that we're doing at the state of Pennsylvania, in the state of Pennsylvania. So we're looking forward to, we've had an initial conversation. We're looking forward to trying to see what kinds of things we can work out with them. And what we can discover about connecting with psychology and psychology programs in the state of Pennsylvania to have the kind of stuff that we are working with psychiatry and already is being done with social work spread to some of the other areas across the state and the other professions. So that's a work in progress. I don't know how it'll go, but we are pursuing that. All right. Now we've got PPLC program initiatives updates.
Yes, we do have some updates. And the major update is in the back of the room. There's some cheese. And if you folks don't go get it, you know who will. Just saying. Just saying. But not only is there cheese, but we do have some other programs that are ongoing. And we just want to give some acquaintanceship to folks who are online and folks who are here. And with us first is Mike Lane, who works with Wojak and Associates. He is our primary consultant for the Coalition for the Common Health. The Coalition for the Common Health was formed a number of years ago in order to try and enact a successful merging of several departments by Governor Wolf. At that time, he was talking about merging the Department of Drug and Alcohol Programs, Department of Aging, Department of Health, and Department of Human Services. At that time, Department of Public Welfare, and they were trying to make it into one large department, again, calling it Department of Human Services. And in that context, we thought that having some boots on the ground represented by people who are part of our work group here would be a good way to go. And that's how the creation occurred for Coalition for the Common Health. And with us is Mike to kind of share some of that background and current status.
Okay, great. Thanks. I didn't see any string cheese. That would have been better. out of the can. March Madness and string cheese. So Lloyd mentioned a little bit. I'm going to touch on several points, sort of the history, the formation, sort of the pivot during when COVID happened, what the group is focused on now. And again, I'm Mike Lane. I work for Wojak Government Relations. We are a full service lobby firm here in Harrisburg and in Philadelphia. I think what's unique about our firm is that we have a dedicated healthcare practice where we're working with hospitals, provider groups, nurse family groups, a whole bunch of stuff. So not a traditional retail lobby group per se, although we do have that on one side of our shop. We do have a dedicated healthcare practice. And that's how we sort of got connected through just our stakeholder involvement, our general sort of purview in the area, as well as knowing folks for, several decades now and kind of connecting with PPLC and then eventually this Coalition for the Common Health. So the idea of the Coalition for the Common Health goes back quite a bit to about late 2017, early 2018, and here we are sort of five years later. The idea of that initiative was to bring provider groups together, physical, behavioral, oral, all the delivery systems together to try to figure out how to essentially modernize the human health and human services system. And I think we're hearing a lot of those themes still today, sort of the modernization of it, maybe in different ways, but the core idea sort of remains is that, and we can get into it a little bit if you'd like to, the regulatory system, the legislative system, all the regulations are sort of a little bit historic, need to be brought forward and modernized. How do you do that while trying to also make those advances in the real time sort of clinical realms that you are all working in, whether that's doctors, patient care, talking about residency, all those things. So that goes back quite a bit. So it started through the PPLC initiative, became the Coalition for the Common Health, or we call it C4, CH, Coalition for the Common Health, because you have to have a cool acronym to go with your name. But we're really charged with, and while I work for a lobbying group, we don't really do any lobbying per se. We're not over on the Hill lobbying, but we are and consider ourselves a prime resource for education, information, sort of light advocacy within the state agencies, within our conversations with the folks in the General Assembly, as well as we have a really unique opportunity now with a new legislature coming in and a new administration for the governor. So we've had a lot of good opportunities there. We've used that recently to engage with folks that are either in their current position, deputy secretary, We've interacted with Representative Schlossberg, who was here this morning, and that goes back a long time now, as well as advocating in all the, what I would say, the critical state agencies, DHS, DDAP, DOH, et cetera. So that's really the prime focus of what we're doing. Back when I thought it was interesting, back when the coalition was created, they identified several core areas that they wanted to explore. And every one of them that were in play 5 years ago remain important and relevant today. So I'm just going to read what they are. They are service innovation, the idea of how do we deliver services, what are the ways we deliver it, what needs to be modernized about it, what can be innovative given either technology or just the general practice changes. So that's one. Regulatory modernization, legislative, I talked about that. We have a lot of DHS, DOH, different code regulations that have been, decades old, that are in desperate need of modernization. They did go through a task, they meaning the previous governor, did do some modernization of the nursing home regulations. On their legislative agenda was to do the hospital. They've done some outpatient related modernization, but again, these are things that are in need of desperate modernization. So still relevant there. Workforce was identified at the time. Obviously, that's taken a new front and center place, pre-COVID, COVID, and now we're coming out of COVID. Patient, consumer, and family, and as well as the idea of whole person primary care. So at that time, when looking through those issues, and we know that through COVID, workforce has been a huge issue, kind of pivoting to that alongside this whole person primary care, that really rose to the top, whole person primary care. And I think you're all familiar with it, but in terms of whole person primary care, and this has really been the item that this coalition has focused on, engaged in. We have about 25 organizations, I would say, comprised of physical health providers, behavioral health providers, psychiatric providers, oral health providers, FQHCs, doctors, family physicians, and all down the line. So we meet once a month, and we've been meeting once a month sort of a steering committee, a focus steering committee, and a member meeting. And so if you think about that as a quarter of each of the year, we're doing that. So next week, we're coming into our full service member meeting. And we are going to benefit a little more. I think we're going to ask a few more questions. We're going to have the folks from OIM to kind of explore further about the idea of what I heard was 600,000 to 1 million folks coming off the rolls. What's that going to look like for patient care continuity? What's it going to look like for general financial stability and structure of people who had insurance and don't have insurance anymore? What's it going to look like from the provider side, where you were treating folks and being paid for items that folks might not have insurance anymore? What does that look like for financial stability across the health system sector? And so we'll ask a few more there. But in terms of whole person primary care, need these when you turn 50. So we're going to put these on. Whole person primary care is the foundation of a high functioning healthcare system that meets the majority of an individual's health needs and is easily accessible. Services addressing physical health, behavioral health, oral health, substance use needs are easily navigated by patients. The care provided is coordinated across settings and patient and family centered across the patient's life course. A multidisciplinary team of healthcare professionals coordinates those transitions of cares across settings, collaborates around each patient to address their specific needs. Comprehensive, coordinated, includes prevention, assessment, recognitions of social determinants of health and trauma. So it's a real full service definition, but it's something we've been trying to get the state to move towards. We believe we had some traction in the Wolf administration, offering, whole person centered care themes. We had the regional collaborative care. What are the name of those, Lloyds? Thank you. RACs, not to be confused with the other RACs on the Medicare side that take all your payments back, but different RACs. So we've really been working to that. We do again believe a new administration, a new DHS secretary, new folks in leadership in the General Assembly, a change in one chamber of the General Assembly on the House may give us the opportunity for some additional partnership there. But you can see how in 2017, 2018, those themes, although they may be a different in terms of priority level, are still really all relevant today. And those are the task forces this group has been really focused on. Now, again, the best plans, right? We needed to adapt, pivot, change as it related to COVID. Workforce took on a different meaning, but whole person care, workforce running sort of neck and neck there. But again, this group meets. Someone was mentioned how often the psychiatrist group meets. I mean, we're meeting Mondays. We're meeting in advance of our, we have service innovation, workforce, legislative, regulatory, patient family centered, communications groups. We have all these active groups going. So for the purposes of my update, just wanted to give you a little bit of how we're working in connection with PPLC, how this coalition is working in connection with the state. But also wanted to tease out a little bit from other colleagues. And I think Stan and Val are going to talk a little bit more about something we've been focusing on a good bit: spiritual first aid, one component, and then the general workforce component overall, some of the materials we've developed and ways we've worked at it as a group. So at a high level, any questions, any thoughts there? Didn't want to, yes, please go ahead.
Yeah, could you talk about how these efforts, for lack of a better word, integrate with the efforts for integrated behavioral health and reverse integration, or, the collaborative care movement?
Yeah, I want to turn that over to someone who has a little more clinical knowledge than me. I know they are not on exact the same sync, but anyone out there? Yeah, Ken, please go ahead.
So the whole person primary health services that we are imagining actually would incorporate some of the would incorporate the collaborative care models and reverse collaboration. But what we're really looking at that kind of goes beyond that is the foundation of primary health services, in which it's not like you're adding on behavioral health. We actually want behavioral health to be at the core on the foundational level. Because what we're finding is if you talk to, and actually just a recent report came out, published in Health Affairs, that primary health medical providers are now seeing over 15% of every visit that they have, 15% has a mental health fundamental background. It isn't a secondary issue, which is often the case. It is the primary reason that folks are coming in, and that has doubled what it was before COVID. So, so what we're finding is that the primary health services on the medical side are desperately in need of reinforced and foundational psychiatric capacity at a level that we have not actually anticipated fully. And I think that the initiatives around collaborative care and the various forms of approach to trying to bring mental health into primary medical services, I think that what we are seeing is an acceleration of that and an increasing desire to try to figure out how we would create a real foundational, I'm using that word a lot here, but foundational capacity across the state to provide this whole person. It's team-based, which I think is an important language that I would add to this. Whole person, team-based primary health services that are the foundation, and then community mental health services would be built on top of that, but that a lot of the resources that we need would actually be at the primary health level, rather than to have a primary medical foundation and then so without much psychiatry, and then try to layer a community psychiatry on top of that, which is what we've done now and just has not worked. It just doesn't work. So we're trying to figure out how to build that foundational stuff. And one of the things that's good about having a change in the administration, especially if it's kind of a re-up and a revamp, is that it gives us a whole new world that we have to work in and stuff we have to do that we hadn't done before. And we're looking forward to that.
Good. Yeah. Opportunities. While we wait for our next question, is that helpful? Good. I'm glad. I want to go back a second to the OIM comment I made earlier. You know, each part of and it takes the better part of an entire year and it keeps rolling on an annual basis, is the idea of the state budget each year. So last year in the final appropriations, you had the 100 million for the behavioral health, ARPA funds, which have not been pushed out yet, needs sort of not so much authorizing legislation, but sort of a plan as to which agency is going to push it out and how they're going to push it out. It was still showing in this year's budget. When they proposed this year's budget, they give you a snapshot of the previous 2 years. So it's still showing that it's sitting there. So it's not lost, which is a good thing. At the same time, it's not out there when it probably should be. But the idea of the budget each year, we have just a new proposal for the Shapiro administration was over $44 billion state fund budget, 117 billion when you count the federal funds and other augmented funds. So Pennsylvania has a state budget of over 117 billion. Just last year went over to 101 million, first time it ever hit 100 million. So something like that continues to grow. The DHS budget is $19 billion or 43%. It's the largest driver of the budget in terms of human services. Last year, it eclipsed the education appropriation. So it used to be education, DHS or Health and Human Services, and then all the rest. So now you could see how the increased cost there is taking over. Combined with that, in this year's proposed budget, there was a $385 million savings in the budget that the state was accounting for those folks that won't be on the Medicaid rolls anymore. So they have a pretty good understanding of who and how much, at least in a guesstimate way, is going to be coming off the rolls in terms of who they won't be paying for, quote unquote, anymore. And I thought the other comment earlier was particularly interesting, trying to isolate or stratify those folks who are coming off. How many have behavioral health needs? How many have ongoing chronic care conditions? All those type of things would be helpful to know. So just a quick word about the budget. You know, they are figuring an amount that's not going to be paid for based on the end of the PHE. And they also lose the enhanced federal match on the Medicaid services, which was a 6.2% increase during the pandemic. That accounted for the state budget relief of about $150 million a month, or close to $2 billion for an entire year. So you could have maybe a perfect storm coming with the idea of folks coming off the rolls, increased spending in other areas, loss of federal funds. And then you have the Independent Fiscal Office, which is a group that's charged for doing some financial forecasting for the state, saying, hey, if you continue down this track, we have a huge fiscal cliff here. So we need to be prepared for that. So just some context around when people say, you know, spending and other revenue sources. Go ahead.
So I'm swing back around to thinking about whole person primary care and how to shift, transition, develop, incorporate, integrate what we know. And it's not easy. I know that the American Psychiatric Association has really been in an effort to get out the word on a collaborative care model. They are right now looking at how do you get closer to training. So they will be hosting in April teams that bring together residents in psychiatry and in primary care and their training directors to look at how this works and how they might be drivers in terms of the curriculum in the residency program, so that we have a lot more workforce that is familiar with thinking about integrated care, whole health care. How do you work with a partnership with your primary care brethren and delivering positive care for our communities?
Great comment.
One thing just to let folks know, which is part of the problem that we're dealing with, is that psychiatry is recognized by the federal government as being a primary health care provider. However, the profession decided that it no longer wanted to be considered a primary health care provider. So we are struggling a little bit within the field itself as to where psychiatrists fit into this whole primary health movement, which is one of the reasons we're a little confused about all this. And why what we've been pressing for is the concept that, like family medicine, like internal medicine, like pediatrics, there is a primary health aspect of psychiatry that we have to build on and expand. And that has very serious workforce implications, because if you think of ourselves as being a highly specialized group of people, specialty medicine, two things happen. One is you have to keep the numbers very small. You have to keep the numbers very small, and it allows you to charge very high rates. So there's an aspect of psychiatry that's very interested in keeping psychiatry very specialized and very small and being able to charge extremely high rates for it. And then the other aspect, and this is part of the culture war that we're fighting when we are engaged in whole person primary health services, is that we are actually saying, no, actually psychiatry and related fields need to be part of the primary health movement. That is against our, quotes, economic interest in the small sense, but it is clearly the support of the overall profession's interest to be able to be involved and engaged in the psychiatric challenges that exist in the country. Otherwise, it will be addressed by other people, like psychologists or anybody else who can possibly do it, because we have limited and continue to have limited our numbers so much. So that's a little challenge. It's at the national level that comes down to an impact at the state level.
Okay, we ready for next, folks? Thank you very much.
I don't know how many folks out there will remember Vivian Spies. Vivian was our primary person to sign people in. And so just to give you a brief glimpse, there's a sign-in sheet in the back of the room. Hopefully when folks arrive, they signed in. You folks online are free of that. So we do hope that you signed in back there. And now we will turn to Stan, who's here to talk to us about the spirituality initiative that is part of both the coalition and the Psychiatric Leadership Council. Stan Brzezowski.
Ken started us this morning by saying that we have a mental health crisis in this country, more people needing help and less people available to provide it. So it has occurred to me that over the past couple of years, our spirituality and religion committee of PPLC is trying to address this in two ways. One, to incorporate concepts of spirituality, meaning of life, transcendence, if you will, into the work that we do with people. And the second way is to engage the faith community as to serve as peers, to help people that may not be in the mental health system, but may be struggling with questions about life meaning, about anxiety, depression. Certainly COVID has exacerbated all of that. So to the first part, the importance of spirituality and these bigger questions in mental health care, we rely on Lucy for so much. And so once again, I'm going to ask Lucy if you can bring up the video. I figured that you would much rather listen to an expert talk about this than me. And so we have Lisa Miller from Columbia University.
I told you that we found the antidote to the greatest epidemic of our time, suicide in young adults. The rate of death by suicide rivals the rate of death by auto accidents in young adults. And basic science, bears a bell, shows us that we are 4 times less likely to take our lives when we have a strong spiritual life than we share. There's nothing in the clinical and social sciences is profoundly protected against suicide. Together with my colleagues at Columbia Medical School, when we look at structural and memory, we look at the architecture of the body for analysis. What we see is in people with a sustained spiritual life, broad and pervasive regions of cortical thickness represented in red. These are regions of reflect and orientation. With 80% overlap, these regions are not fed or fit in people with a current major depression. Normally in an MRI study, you see a person published, but there's a little slightly difference. These are huge regions, right? Just there effectively greater processing power, thicker cortex. The cortical thickness across the regions of the spiritual brain decrease the level of symptomology of depression 1 year after your meeting. That is very strong evidence that indeed spiritual life is neuroprotective against depression. The Army gets the same slides with American pilots as higher than 18 to 25 minutes. It's one story. It's our American story, and it's the epidemic of suicide. And so the Army decided to take a data-driven approach and support the spiritual core of every soldier. And in 1 year, we are already seeing a 28% decrease rate of suicide. And higher end of that one. Of course, higher education, in all of our institutions, we see one of us transformed to support the spiritual core. Can we move from narrowly transactional relationships with young adults to ones that are loving, that are far more genuine, that are transformation? People's personal spiritual life can be formed in many ways. Some people say this through prayer and meditation, others say in nature. Nature is like people, that's what I realize. And in fact, the regular science that says nature actually entrains the brain, walking through nature. That's very much what prayer can do. It awakens our natural spiritual awareness. People realize their spiritual nature in many times. One of which is religion. For about 2/3 of people, they say I'm spiritual and I'm religious. And then for about 1/3 of people, they say I am a profoundly spiritual person, but I am not religious. Both are good and both have the same neural correlates. There's much stronger draws. When constantly Jewish and Muslim, well, actually, we're all using the same spiritual neural correlates. So I often hear people say, I'm a spiritual person, or I'm really fine spirituality. And everyone is welcome to find it and never fulfill exactly the same one. And it is also the case that just as we were born with 2 eyes, 2 ears, and a nose, we are born spiritual being, the natural seat, the mercy all are transcendence. We are born, every one of us, with many capacity for spiritual awareness. There's one spiritual break. We all have it. When we realize our nature, when we dedicate our strength and spiritual core, who we really are, then our lives unfold in entirely different. Life is healthier, life is far more resilience, life looks different, it's far more of an adventure and solution. And when we boil it down and write the data, where the hundreds of love say one shadow, there's nothing different than the protecting against the diseases or disability and prevention of our time. It's a strong spiritual work. Over the past 25 years, as scientists and as clinical psychologists, it's become crystal clear to me that suffering is an invitation for a deepening of spiritual life. We have to say yes to it. Spirituality is not a life thing. Spirituality is the deep reorientation in our lives through which we see into the truer, more foundational nature of reality. There are always two realities, and they both matter. We are a point and we are a way. We are magnificently distinct GPS coordinates all over the globe and exquisitely diverse zip-like bodysuits, and at the very same time, we are part of one human heart, one human life, one us, a unit of reality, one fit of consciousness, loving, sacred consciousness. And we are built to be able to toggle between these two realities. Every one of us is built to be able to achieve we are exquisitely unique, and we are part of one great sea of one. We are aware of our soul and we are really awesome about our revolution that achieving more is alone can be enough to handle challenges of life. We must be able to look at life in a bigger way, in a deeper way, and that is our awakened awareness. Awakened awareness is when we share and we say, what is life showing me? What is being out there? It's a stand of deep curiosity, full observation of the eyes. Yes, that's part. But whatever our language, we are no longer controlling. We are in a dynamic conversation. In K-12, you know, I was talking to the long conversation. I was taught to go after what I wanted in it and give it every little strength I could so that I could lead it. And that's kind of the scale of this completely insufficient for the meaningful forward. That we teach children really need as adults we need to help revisit this and teach ourselves and have a different conversation of life. Go from saying, we're going to launch and having any words to the deeper, more fundamental question of what is life showing you, what is life showing us. So leading those achieving areas and awakening areas. And when the two of them became our life becomes magnificent adventure, it becomes quest. Constantly part of the seeking, helping each other realize the way darkness. We are loved, we are held, we are guided, and we are not alone. And not only that, we are given the ultimate opportunity to show up for one another so that we might be loving and holding and guiding and never be alone. That's the spirit of that.
I can talk a little bit about spiritual first aid and how this ties in, but I'm first curious of your thoughts, reactions to seeing this.
I was thinking about the children, adolescents that I treat in residential treatment that are isolated, that there's a focus on sort of the individual. They have to figure it out and learn the skills, and very often they are disconnected chronically over time with the important pieces that would offer this support.
One of the projects that Dr. Miller is involved in is spirituality in K-12 education.
You know, I'm a member of a Lutheran congregation, and we think we manage our own show. So we have these assemblies in our region, one region being northeastern Pennsylvania, and I somehow got roped in to attending this one. It's coming up in about 2 months, and I'm wondering if I can forward that film to our bishop. Just the concept of spirituality and the way it can positively impact suicide. It would be a significant piece to share with any spiritual group, but I think that spiritual group needs to hear that as well. And we keep hearing about the separation of church and state. That doesn't have to do with the way we care for folks in our programs. And really, I think people in Harrisburg and higher government levels really do understand that. But we keep hearing about, well, no, you can't be, you got to be making sure you don't. We're not pushing a particular ideology or way of thinking and believing. We're pushing the fact that having a spiritual base can help you in addressing where you head. I remember when I first entered the field, my supervising psychiatrist said, if they want to talk about anything religious, get them to talk about something else. Well, okay, I guess I had to believe that. I was all of 20 at that time, 21 at that time. Then I opened an inpatient behavioral health unit for seniors. Guess what? If the radiologist wanted to come onto the unit, of course I let them onto the unit. I took somebody out of group if necessary to do that job. If the person's pastor wanted to come onto the unit, I took that person out of group and got the pastor in there to do that job. Because you got to know what's important at every point in life. And this is one of those things.
I think Gordon is up first, Ken.
Oh, all right.
He has a mic, Ken.
Got it.
It's working good. So I think this is very profound and extremely profound and extremely important. I've also been doing a lot of reading about, the whole issue of not necessarily deaths of despair, although it's incorporated, but lives of despair. And there's a lot of evidence that the promises that people grew up with are not being realized, and that the sense of opportunity that has organized so much of our historical thinking is missing. And it manifests itself in a lot of different ways that are not necessarily in the interest of the person or in the interest of the community. So I'm not meaning to negate this in any way, but it seems to me that there are social and economic forces that are going on at the same time. And clearly a spiritual approach is fundamental and helpful. Seems to me, though, that we need to bear in mind some of these larger forces that need to be addressed as well.
Sure, no question. Okay, Ken, now you're up.
So and this is a little bit inside baseball, but last night I had a conversation with Stan at dinner about whether or not AI was going to revolutionize psychiatry and whether or not we even needed to have psychiatrists because AI is going to just take our place. He didn't really go that far, but sort of. Sort of.
I was pushing.
You were pushing. So, and I was and this is the word I was looking for, I was profoundly inarticulate in terms of my capacity to come back at you on this. Until, and I didn't get to see this slide, and I'm going to talk about that in a second, or the screen. I'm going to talk about that in just a second, but or in a little bit later. But it did occur to me that probably what you were showing on that screen, and this was when Lloyd was talking, was that there's something profound about spirit and sense of connection and relationship and being part of this human story in this galaxy that we're inhabiting that you can't put in a machine. You can't put it in the machine. So that's the question I want to ask, and I don't know the answer to it. Maybe I'm wrong, but how we get profound out of AI and how we begin to understand that in the work that we actually do in psychiatry and other therapies, social work, et cetera, that actually sometimes it seems very mundane, but it's actually extremely profound. And that's about the human connection. And I wonder how we don't lose that. So I'll stop that.
Yeah, I'll answer it by saying we need to move mental health treatment out of psychiatry, out of social work, out of psychologists, and into everyone else so that we can all support each other's mental health. Yeah, and we certainly need the specialties, but we need far more of people being able to support one another, parents being able to support the mental health of their children, siblings being able to support each other, friends, and so on. And I think, one of the things that's exciting to us about spiritual first aid is that it does provide a disciplined, kind of a structured way to help people use the natural inclination. Typically most of us want to help other people. And so, spiritual first aid provides a bit of a structured training. It's not extensive. It's, 8 to 12 hours of training. You can do it online. It's pretty cost effective in that regard, but it provides the structure. And it also provides a way of making sure that you're self-care so that people are able to help others because they're grounded in themselves. Marcia?
Just wanted to add to that, being able to, I just wanted to add to being able to see patients and all that they go through. A very strong theme with psychiatric patients is their history of trauma and the challenges they've been through. So that chronic healing or acute healing, that's a strong theme. So in healing for these patients, they may exhibit various psychiatric diagnoses throughout that process, but part of that healing can include and should include spirituality and what that means for the patient. But at the same time, having time as a future psychiatrist and even psychiatrists to be able to provide that type of support is important, because there is a high volume of patients. I'm sure everyone's on a schedule and how much they have to see. So being able to allot time for that thorough, whole person, team-based type of approach is important. So allotting time and allowing them to heal as part of their treatment plan.
Yeah, good point. Okay, so very briefly, we've learned about this thing called spiritual first aid. It's developed by folks at Wheaton College. They have a they call their Humanitarian Disaster Institute. They initially started to do this when they got called in to respond to kind of natural disasters, Katrina, other hurricanes, other kinds of disasters, and they build around the research of this concept of people helping one another. Wheaton College is a Christian college in Chicago, right outside of Chicago, and they initially developed spiritual first aid as a Christian with a Christian focus, and we contacted them and started to work with them, and we brought a group of rabbis together to review what they had done. And the rabbis were very clear. Yeah, this is pretty cool, but it's Christian. And we can't use this with our congregation, and you can't use this with people that aren't Christian. And so to their credit, the folks from Wheaton redesigned the whole thing. And so but they still have the Christian version because there are some congregations that want to use that, and that's fine. But the community version is applicable to anyone. And it talks about spirit or, spirituality. It doesn't talk about religion. They're sort of just getting started, but there's in Pennsylvania through our work, there's a group in Souderton, Pennsylvania, Eastern, maybe Lehigh Valley area, I think. There's a Mennonite pastor who has 75 of her congregants going through the training to do spiritual first aid for the people in their community. In the Pittsburgh area, there's a man who works with the Veterans Administration. He wants to train the chaplains in the VA to do this. In Philadelphia, Samantha Granum, who is, I think her title is something like Faith and Spiritual Affairs Director for the Department of Behavioral Health and Intellectual Disability Services. There's an interest in DBHIS, the Community Mental Health Program, their County Mental Health Program, in developing, in expanding their use of mental health first aid by incorporating spiritual first aid. We just recently were joined by a group of folks from Erie, two of whom defined themselves as being faith community nurses. I don't know what that is. I'm going to find out more about it. So I'm just telling you, this is sort of expanding. At our last meeting, we had discussions about maybe this training could be made available to university chaplains, universities, as she talked about, the educational system. We're looking at potential for making this available to mental health staff across the Commonwealth. So we're thinking about how to use this to maybe to extend the mental health services that we're offering to help people that are struggling with kind of daily living kinds of things. And the idea around it is to help the spiritual first aid interveners, if you will, the helpers, practice, what we would call active listening, non-judgmental, accepting, trying to help the person identify what their most critical needs are, helping them with coping skills, and being able to refer to the professional resources that are needed, whether that be a psychiatrist or a minister or a rabbi or a shaman. So that's where we're at with our committee. It's exciting work. Kathleen, Dr. Klein has been extraordinarily helpful as a guiding light for our committee. We're appreciative of that. Bob Marin, who is in retirement stage now, was a member and helped us really get that committee started. So we're excited about the work that we're continuing to do that Bob helped us get started. Any questions about our committee or about this whole concept of bringing spirituality to make our own lives better?
Something that any interested party can do now, or do you need access to it? How do you get it?
We can give you access. So if you know of someone or if yourself are interested, we can give you access. We sort of have a special relationship with the folks from Wheaton since and they have numerous times given us credit for helping them to move beyond their Christian version, because it really opens up what they're trying to do. And so the usual fee, I think, is $129, but they've given us access. So I think we can give you free access to it, Gordon. And then you can maybe give us some feedback about what you think of the training, or if someone you know. Is that it? All right. Okay, Kathleen. For the benefit of the people that are still on.
That's right. I just wanted to say quickly that Stan holds this all together. So everybody needs to know that there wouldn't be any meetings. We wouldn't have moved forward. We wouldn't have discovered the humanitarian disaster relief organization that we did and other good works were it not for Stan. So that is really great. I want to acknowledge that.
Yeah. I don't know how this happened.
All right, well, Val and I are gonna try to round things out and take us home, I guess. You want me to go?
Introduce yourself, I guess.
Sure.
And then we'll have some fun with the mentor.
Yeah. All right. So we have a couple slides where we're definitely hoping for audience participation, both in person and virtually for this part. So as a group, the PPLC and the directors of the Centers of Excellence in Community Psychiatry have been thinking through a little bit about a project to help support community psychiatrists and community psychiatrists or practitioners of community psychiatry, and particularly those who are early in the stage of their career. So next slide, please. Oh, the link. Yep. So we do have a poll or a question that we're hoping for participation, a Menti poll here. All right.
You can use your phone.
Do we have the question up there?
So we're gonna have people go to the
Oh, okay. So if you could use either QR code or you could use your phone and go to menti.com and type in the code. Okay.
Is everybody able to get the code?
So I think the question is on the, if you go to Menti. Okay.
Are folks able to pull it up? Getting there.
Okay.
To experiment.
Yes.
Trying something.
Experimenting with interacting.
All right. So everybody has the code. You can go to the next slide. That's right on the same Menti. Let's see, like it's right down the next one.
Number 3.
Number 3.
All right. Yeah. So the question is, if you could go back in time when you were new in your career, what did you need to thrive in your profession? Nope. Those are responses. Those are responses.
You can put in your own responses.
See, getting new responses.
Yeah.
Okay. Okay. All right. We'll give it another few seconds here. Is there a way to make that slide bigger, Lucy? There's got to be a PowerPoint or present mode. Yeah, maybe present mode. Can you just click on the present with the blue button at the top right?
Let's try it. Skip.
I think this is a preview, so.
Okay.
Can you X out of that? Can you just click the present button? There. Oh, but it's still tiny.
Oh, there it is.
All right, so this, so thank you for all participating in that. So that, so with the way these word clouds work is that the words that are bigger in the middle are ones where you've had more of the same response. So that means more people have entered that in. So we're a relatively small group, so it's a little bit hard to get a whole bunch of the same responses, but clearly we see mentorship as coming up as being of central importance, support opportunity. I see mentors, just a slightly different version of the word. And then a whole bunch of other things. Sort of hard. Time. So time came out as another big one as well. Okay. All right. Well, thank you for participating in that. So if we could go back to the other part of the slideshow.
We'll be able to save it on the back end, so I can share them.
Yeah. That concludes the very advanced technological portion. All right. Okay. So I'm just going to go through a couple of slides of thoughts that we had put together. So I think some of this reflects experiences that I've had as well, which although I'm more of a mid-career psychiatrist, I'm sort of relatively early career in community psychiatry. So these were kind of challenges I found as well. But I think some of this discussion arose out of discussions that we were having about workforce shortages and how to support our workforce, how to recruit more people into the field of community psychiatry, how to deal with burnout. And so just a couple of thoughts about this, that obviously when you transition from some sort of training program, whether it be residency or fellowship, there are a number of challenges that are raised at that time. And it's often a really big shift and a steep learning curve for people. I think the fellows who spoke just before our lunch break actually teed some of this discussion up really well, that, you know, when you go from a training program, you're often losing the support and supervision that is built into residency programs or fellowships. And I think if you end up going into outpatient practice, depending on the site where you are and what kind of structure there is, being in outpatient practice can be very isolating in a lot of ways. You are oftentimes dealing with people who have a lot of different needs, severe illness, and trying to figure it out as you go along. And you're trying to treat people longitudinally, which honestly, a lot of the textbooks and the studies will not answer the questions that you have that arise in your practice. We also have a lot of increase in demands on time and productivity as you move into independent practice and attendinghood. So the number of patients that you're expected to see, the number of other activities, or mentorship or committees that you're expected to be drawn into, increase quite a bit as well. And then I think many psychiatrists, particularly those who go into a practice at a community site, are often asked to step into a leadership role, to become the leader of a team, without necessarily a whole lot of experience or training in how organizations run, in leadership skills, perhaps having limited knowledge of how the behavioral health systems work or are financed. And then finally, I think there's a big learning curve in terms of figuring out how to advocate and negotiate for yourself and for your colleagues, for your patients, and also your community. So Lucy, if you could hit the next part here. Oh, one back. That's a little touchy. Okay. So we've had, so one more. Yep, hold. Okay. So we've had discussions at 2 of the PPLC evening meetings to just kind of bring up this topic and get people's perceptions, and I'm hoping to get some more feedback about it today. So one of the things, probably not surprisingly, is that clinicians at all stages of their career really identified a need or a desire for more support and learning opportunities. And there were a number of barriers that came up. Adequate time, I think, which has already come up today, is a major barrier. This, you're talking about either time outside of working hours or non-billable time that you're asking for from your employers. But it does feel like there is a sense among many of us that there's a need for ongoing clinical mentorship, for the opportunities to connect with colleagues. Some of the other topics that came up were related to also just sort of banding together to help evaluate and positively influence our working conditions, and thereby hopefully encourage more people to go into our field as well. So if you go to the next slide, so from kind of some reading and brainstorming that I did and Val and I have been thinking about together, I just wanted to throw out there a couple of sort of possible models of support that we've been thinking about. So, this sort of support can occur in either a group setting or one-to-one. I think back to some of my kind of mentors in residency who talked a lot about when they got into practice decades ago, having a dedicated or assigned supervisor, a psychiatrist that they would, with more experience, they would meet with on a regular basis. That was really helpful. But this can also occur in group settings as well. Another way to think about this is sort of the value of having people who are at the same stage of training or career meet together. So peers versus pairing people up based on being at different career stages. And I think different values can be attained from both of those types of models. And then a couple kind of models that are already out there that exist. So some of you may be familiar with the ECHO model. So this was a model that was developed largely as a means of disseminating information or expertise from a hub with clinical experts to more community practitioners. So this started actually with a hepatologist who wanted to improve treatment of hepatitis C in his broader community. And there have been some models of this done, for example, at Penn State with child mental health, with child psychiatrists disseminating information and providing support to pediatricians who are doing a lion's share of this work. So that's one sort of model that we could look at. There's also the concept of process groups, and some residencies do this already. Some are run by peers, and then some are run by facilitators. I had this, I would say, informally in my residency as a happy hour at a local bar that my whole class went to after pretty much every didactic session. But it was incredibly beneficial, and I still miss that to this day. So there's formal and informal ways of doing this, right? We can also look at kind of more like paired mentorship models or kind of one-on-one supervision of a earlier stage career psychiatrist with a more senior psychiatrist. And then one model that I kind of stumbled across, which I found particularly interesting, is that so the Royal Australia New Zealand College of Psychiatry, the RANZCP, has these peer review groups, which are voluntary groups of small self-selected groups of peers that get together on a regular basis in a supportive setting. So it's very self-directed. They set their own agenda. The group drives the process. They range in size from about 4 to 12 members and usually meet monthly. And this really helps provide them a number of different opportunities, one for professional development, and think back to the terminology of professional guardrails that was used earlier. But also psychiatrists who are involved in it from a study really cited importance in supporting the emotional well-being, because we know that the work we do is very, very challenging in a lot of ways and can be very draining, and also learning from each other. And I was thinking about this too, as we heard the presentations about the Learning Collaborative across the state, and Ben from Penn Highlands talking about how great it was to be connected with other residency program directors across the state, the residents to talk about how wonderful it is to be connected with residents across the state. And I think there's just so much value in what we can learn from each other being at different institutions and settings. I've learned a lot from my colleagues, and I think there's more that we can do there. So that is just a sort of a selection of possible models. And then Lucy, if you want to go to the next slide. Oh, You're already there. Okay. So some topics for discussion. So I'd love to hear from those in the room and those online. So what kinds of connections or supports might be most beneficial to those early in their careers in community psychiatry? And, you know, we have a number of fellows here today, but there also are certainly plenty of psychiatrists who go into the practice of community psychiatry without necessarily the opportunity to do a fellowship. So thinking about their needs as well. And then what role should or could the PPLC have in connecting with and providing support to early career psychiatrists? So if you want to take those down, I guess maybe so we can see the Zoom. And we'll just open up for discussion.
So I really appreciate this, even though I'm in the twilight years of my practice. I've got plenty of folks that I'm encouraging in the early career universe. And this was a topic of conversation at our council meeting for the Pennsylvania Psychiatric Society, of which we've done a little bit of partnering in another major effort on racial justice. And I'm wondering if we don't have to reinvent the wheel, and we might have some collaboration around what might be really neat things that are beneficial for early career, that transition bridging from residency to attendinghood, and as well as participation in organizations like this, so that we have what is going to further encourage Lloyd on his very positive trip home, which is advocacy, advocacy, advocacy. And right now, that's really been challenging at the resident early career level for a whole variety of reasons. So what are the things that will really support that?
Thank you. No, we can just give more. I mean, I like the idea of not having to reinvent the wheel. I think that's a great idea.
Other thoughts? Oh, good. Somebody.
Well, I'll.
Great.
Sorry, is someone, I can't tell if someone's talking.
Well, why don't you go ahead, Hepsi?
Okay. Sorry, I'll say that I think I run into a lot of difficult clinical situations that I've definitely used supervision for, in particular related to, I guess, just kind of standard of care issues, and even just with the Adderall shortage, for example, it's really challenging to prescribe stimulants at the moment. So I guess that's kind of a usual need for people coming out of training. Specifically, I'm a child psychiatrist, so I think probably connecting with other child psychiatrists would be, in community mental health, would be ideal, speaking for myself.
Thank you. All right, we'll go to Madeline here.
Yeah, I just like a pretty direct answer. Like having a list of people who to connect with within like more specific communities. We talked earlier, like with having the roundtable group for Black residents to connect with other Black residents. I know there's already like a lot of pressure on people who are like the only one of some group, but I am often, so I'm transgender and I'm often the only one. And there are a lot of times I would actually just like really like to talk to a supervisor who is similar to me. And I know there's like a very small population for that, but I'm assuming that other people who are in like smaller groups of psychiatrist representation feel that way too. And like personally, I'm happy to talk to any other trans folks in mental health, like as a support to them. So I do think like it may not be overburdening, but anyway, just if there are like lists, like honestly lists of like people with shared identities, because there are some things that I try to like work through in supervision in the past, and it just feels like I really need to talk to someone else about it.
Yeah, that's a great idea. So having a list of potential mentors or supervisors with specific experience or expertise. So you don't have to go searching for that. That's a great idea. I believe Jasmine was next online.
Yes, I wanted to comment, I guess basically from a foundational, maybe boots on the ground perspective as a family member, in terms of answering what I think would be helpful, an additional point to be helpful for individuals in their early careers. And I would, I guess, sum it up by saying having family partnerships and maybe developing cultural humility. Because most of the involvement that, the experience that I've had in my own family, most of it was with the psychiatrists, the social workers, and other clinicians. I'd sum it up by saying it was adversarial, hostile, and offensive at best. So what I noticed over the years, now let me just say quickly that I am an adoptive parent. So I did come in sideways to caring for youth who are now adults now with serious mental health issues. I've adopted 5 sons. I parented 15 children. So I've been around for over 30 some years. I'll round it off to 30 years. So about 30 years of experience with the mental health systems, in the children's systems and in the adult systems. And I'm part of the Philadelphia system, and thank God for the allies and the mentors I have in Philly. But what I've noticed overall is that most of the psychiatrists, the social workers and therapists and other clinicians seemed to have very little at best experience with the family perspective, our role. They weren't used to collaborating with families. And it reminds me of the spirituality component, in that family involvement is very natural and very spiritual to me. So I just wanted to add that component to how do we establish relationships, positive relationships, maybe with students, maybe when people are in college, inviting families to come speak, share our perspectives when they're in college, somehow having some relationships when people graduate, and are involved in their internships, etc. I know that FTech is involved in that. Thank goodness for that. But I would like to see that expanded, and I just wanted to add that to the discussion. Thank you for allowing me to share.
Yeah, thank you so much for sharing. I'm sorry that you've had that experience, Jasmine. There's definitely a need for more specific training on family involvement and collaboration in training programs, but I think it's also an area of education and ongoing work once people are in practice. So there's a way that, it could be incorporated into these endeavors as well. Eileen.
Hi, Allison. This is Eileen Diaz here. So I want to commend Ms. Jasmine Banks for letting us know about the family component. It's so important, being a child psychiatrist and also being like director of Hispanic clinic, and just seeing how many families come in and their issues, and being open towards them in a non-judgmental way, and how important that is to actually elicit information from the family members and to connect with them, especially when their dear ones, their loved ones are going through such a difficult time with mental health problems. I also wanted to add how we could be able to be more effective. I know one of the things we had discussed before is that sometimes the APA itself, many of these early psychiatrists are not part of it. They don't want to pay the $1,000 fee to have that membership. So they won't be part of it. So it's figuring out what creative ways we can find, be it through social media, LinkedIn, Facebook, Instagram, that we can connect with these groups of people who have like ran away from the APA or ran away from the system and are on their little silo somewhere, and we need to like connect with them. So it's figuring out a way we're able to do that. And how are we able to kind of use the power of what we have through the internet and websites and be able to connect with them to bring them in to our groups. because those are the ones that are lost. So we ought to got the lost ones in.
Yeah, absolutely. Room for creative innovation and how we connect to, absolutely. Any other thoughts or comments, Jim?
I just have one thought that seems to be one way I've stayed in touch with some colleagues and built a sports team is that colleagues that I've known, especially if they've got an area of some expertise, I'm not good at calling them socially, but there seems to be an accepted norm that, you know, if I call their cell phone, it might well be like a, you know, a curbside consult, and often is. And I think we actually appreciate that from each other. You know, yes, was, oh, I'm sorry, I haven't called earlier, but here's this. So as I think back, that's actually helped me keep a support network of colleagues.
Thank you. Is this something we think the PPLC should take on? Is this something we should have a role in?
Are you seriously asking?
Well, we should say that if you want to talk about this further, anybody here or online, we'll be talking on April 20th at 6 p.m. If you're interested in getting the Zoom link, if you don't have it, reach out to the great Lucy Green at lgreen@pmhcc.org. Katie will put it in the chat yet again. I think that we would love to hear perspectives from professionals at all levels of their career, but particularly for fellows and residents. You're in the thick of it right now, so would love to hear what you could possibly benefit from as well. So please feel free to join us.
All right. Well, thanks for your participation, everyone. I'm going to turn it back over to Ken.
Thank you very much. So Allison, I did have a thought, which was that it's not clear to me that we have done enough research on the Australia, New Zealand model. And it's pretty clear that why do you think that's where I was going? In all seriousness, I think that they're onto something. I know that also that they do this in the UK, and I don't know if they do it in other parts of Europe. But this idea of having pods of psychiatrists being in connection with each other is I mean, it's something that we sort of do. I mean, and the PPLC is really a little bit that, but I think we could think about how to formalize it and make it bigger. And obviously, I think the PPLC ought to be engaged in that. And Jim, did you say that you were building a sports team? Is that the word you use? Did I mishear you? That you, when you said building your team, or I thought you support. Oh, so I heard I'm building a sports team. And then I thought that's actually a perfect segue for what I wanted to do, because you guys know that we, unfortunately, we have to deal with the fact that there's some parts of the state that, you know, continue to struggle with their teams, reaching the pinnacle and just not quite closing the deal. But we feel sorry. We do feel that, and so sports has been a metaphor that we use, and in that context, I just wanted to read as we round out tonight or this afternoon, a thing I just got emailed to me. So Dateline Washington today. This was actually released yesterday. Ted Lasso and President Joe Biden are teaming up, as a television sports coach would say, to believe in the importance of mental health. Biden and First Lady Jill Biden will host actor Jason Sudeikis and other members of the cast of Ted Lasso at the White House today for a conversation on mental health, Apple TV announced Sunday. Cast members, including the discussion, will be Hannah Waddington, Jeremy Swift, Phil Dunster, Brett Goldstein, Brendan Hunt. I don't know how they're going to broadcast this or say anything about this, because these guys all say the bad word all the time. I don't know if you know this, if you watch this show. The White House official said the meeting will focus on discussing the importance of addressing your mental health to promote mental well-being, overall well-being. The president on Sunday tweeted a photo of a yellow poster bearing the word "Believe" above a door leading to the Oval Office. The sign is reminiscent of one fixed to above Lasso's office door in the AFC Richmond locker room on the show. The Emmy Award-winning show, which is now streaming in its third season, has tackled mental health issues in its storyline, chiefly through its chief title character played by Sudeikis, an affable coach who seeks therapy after grappling with panic attacks. In regard to the mental health stuff, it was just there. It's been there forever, but it's really come up a lot, just knowing where the characters were headed and how important it is to work on yourself to help your team. Sudeikis told US Weekly in 2021. And I think that we are trying to explore that and personify it in a way and kind of Trojan horse that there's bigger issues in this fun, silly little comedy show. People have really responded to that, Sudeikis continued, and myself and other people in the cast and the writing staff get messages daily from people thanking us for really opening their eyes to what it means to go to therapy and what it means for someone in their own life to go to therapy, and just speaking about these things and taking the stigma off any form of health and mental health, whether it be nutrition or mental emotional health. Biden has made improving mental health a key portion of the unity agenda he debuted in this 2022 State of the Union address when he urged the country to take on mental health. Let's do more on mental health, especially for our children. Biden also said in this year's State of the Union address, when millions of young people are struggling with bullying, violence, trauma, we owe them greater access to mental health care in their schools. The Biden administration is focused on training more providers, making more affordable and accessible care, and creating healthier and safer communities, including online. A survey, 2022 survey by CNN and the Kaiser Family Foundation, found that 9 in 10 adults in the United States believe a mental health crisis exists in this country. The White House has enlisted celebrities on several occasions to raise awareness about key issues, including mental health. Actresses, singer Selena Gomez, who shared her own struggles with bipolar disorder, appeared with First Lady as a mental health youth action forum hosted by MTV at the White House last year. Content from Biden's meeting with the cast of Ted Lasso will appear on the White House's social media channels, according to Apple TV. So, why do I say all that stuff? Because this is the moment, folks. Who's not watched Ted Lasso? Okay, Lucy. We got in a third season. Lucy, we're going to work on you to watch Ted Lasso. What? Oh, that's. Anyhow, Ted Lasso is really quite good, I have to say, and it is actually really good on the mental health stuff. So, by the way, in a kind of weird way, is this new show called Shrinking. But what I want to say about it, what I want to say about this is that the moment is here. It's in the media. It's in people's minds. 9 out of 10 folks think we're in a mental health emergency or crisis. We have to do something. One of the things, and I want to appreciate Stan for mentioning this, the idea that we want to popularize or make mental health care something that's sort of infused into the community that all of us participate in, whether or not we're professionals or not, is a concept called task sharing. And this is the idea that you actually spread skills throughout a society, and spiritual first aid. That's actually what I've been involved with this integrated community therapy, is all about task sharing, trying to figure out how to make peers out of everybody able to help and be useful to other folks. So it's really, really important. And I think one of the things that happens with that is that you move out of this idea that mental health is an entirely private thing, that you think about mental health as being somewhat public and connected. And I'm in that case, I'm going to do something that I feel compelled to let folks know about. And I actually, the inspiration for this is Marianne reminding us of the death of Rich Silbert, and tied to Larry Reel and to Trevor Hadley. We have lost folks in our journey here. And I want to share with folks that until actually just today, when I got the results of the bone marrow that I had done a week ago, I didn't know how long I was going to be around. I have gotten good results. I don't have nothing, but I don't have anything that's going to kill me. I don't have to go get chemotherapy immediately. I'm not in the hospital tomorrow. But that was something that was on my mind. And so I'm hopeful. I'm hopeful. I see this as a change. I don't like the pattern of all of us leaving. Rich and Larry left too early. They left too early. And I want to be able to stick around. And I know other folks here, all of us want to be able to stick around and follow along like David is. David, I know, is going to hear about this meeting from Lloyd, and he'll just feel good about it because he got this going. And I've talked periodically to Stell Richmond, and I'm sure some of you else have as well, or Joan Ernie or other folks who are involved with us, that we want to make sure those folks stay involved. But even more important, what we really want to do is just make sure that we're continuing to work at bringing new people in. It is wonderful, Alex, to have you here. Thank you for coming. For the other residents and fellows on the line, wonderful for you guys to be here. That's the continuity we have. We're going to stick around as long as we can to be useful and do what mentorship we can provide, what mentorship we can. But the future is coming, and the opportunities are large. And I think that this small group has an opportunity to make that future be very different than it might be if we were not working at what we are doing. So I'm going to stop there. And unless somebody has some further business for today, say that we are done. And thank you so much. And we will be meeting online. And Lloyd, what else do we need to say?
I want to talk about future meetings.
Yes.
And Ken, thank you for sharing that with us. I really appreciate that. I want you to notice these folks at this front head table here, because those folks, along with Sierra, are FTAC. You know, it's not like there's a head of FTAC and then there's a group of minions back there that are this is it, folks. So what happens not because of us, but because of your willingness to participate. And we very, very much thank you for that. I want to recognize Deb Shoemaker for doing wonderful work in organizing this. Yeah, good stuff. Good stuff. As such, our hope is to have a planning meeting sometime in the middle of the summer. Just a kind of a smaller planning group of the PPLC. Our next hope, because we do think now that we have some grasp on potential funding to be able to continue going forward from both OMSAS and Department of Drug and Alcohol programs. We'll see. You know, needless to say, I got knee pads. If I got to beg, I will. But we think we're going to be able to do that. So we're hoping to have a meeting in the fall of this coming year for the Psychiatric Leadership Council, and then plans for a conference in the spring of next year. And I just can't thank enough the people who are here. Mary Ann, God bless you. Ken, the folks who are significant. You're attending, Kathy, as a regular on the Thursday meetings, as well as you, Jim. So you are the folks that make this happen and work. And we thank you so very much for it. And if on your way home, you're still driving and not flying, hopefully you can feel good about all it is that you do to forward our efforts within our Commonwealth.
Good.
We're good?
We're good.
Thank you. Please drive safely. I can't go anywhere, man.
No, I'm sorry.
I should have.
I'm glad I don't have to.
Thank you. Thank you.